Good morning. I'd like to call the meeting of the Human Services Committee for Thursday, March 13th to order, and we are going to recess. All right, good afternoon. I'd like to call back to order the Thursday, March 13th meeting of the Human Services Committee. And number 2 on the agenda is remarks by the chairs. I think we've made folks wait long enough, so we're going to get right to it. So moving to item number 3 on the agenda, bills for review. The first bill is House Bill 7101, an act establishing a commission to study a Husky for All single-payer universal health care program. Is there a motion?
So moved.
Is there a second? Moved by Representative Kitt, seconded by Representative Comey. The bill does what the title describes. Happy to discuss further. Any questions or comments? Yes, Senator Perillo, and I actually should have said in our welcoming remarks, welcome to the committee. Happy to have you here.
Thank you.
Go right ahead.
Thank you, Madam Chair. I appreciate it. And forgive the fact that I've been on this committee for a hot 5 minutes. So I may ask questions I should know the answer to. It's not intentional. So help me understand. So this would be an expansion of the existing Husky program. And I know we're studying here, but let's play this out. This would be an expansion of the existing Husky program to cover every resident of the state of Connecticut.
Yep. And just to be clear, because it is a study, this would study the potential of expanding, yes, the Husky program to everyone in the state of Connecticut.
What, and again, I'm new. So what consideration has this committee given to the impact on access to care for all state residents should this move forward?
And that really is the reason we're looking at a study, because we want to understand all the impacts before making any decisions.
Thanks. So I appreciate that, Madam Chair. Thank you. So what, a study is fine, I guess. But I think at the end of the day, what I'm kind of wondering is, what is, because look, we oftentimes study things here because there's a desired outcome. Let's just be honest with ourselves here. So what is the goal here? Is there an expectation that this is going to lower cost for employers? Is there an expectation that employers would actually pay in and these would be premiums paid by the employer? Is there an expectation that actually this would just be funded with taxpayer dollars? I'm not trying to understand the definition of this committee's definition of a single payer universal healthcare program, because that could mean different things to different people.
So in the bill, it does have information on what we mean. So if you look at lines 3 through 12, it does discuss what we're discussing when we look at single payer universal healthcare program. I'd say the goal, you mentioned a few things. We know that costs for healthcare are exorbitant for individuals, but also for employers. And so we're trying to understand if we moved in the direction of a Husky for All single payer universal healthcare program, would that reduce costs and increase access, I'd say, are the major goals of this proposal.
Okay, so access. So access is a concern. So let's look at the way that Medicaid and Medicare work in the state of Connecticut. A lot of people covered, provides, insurance coverage, which is great. But let's take a hospital scenario. And we know how reimbursement happens, right? So Medicare reimburses at a rate that's actually lower than the cost of providing the care in the first place. Medicaid reimburses an even lower rate than the cost of providing the care in the first place. So the only way that works, the only way hospitals can afford to exist, is because those losses from Medicaid payment, those losses from Medicare payment are actually covered by commercial payers, right? So commercial payers pay greater than the cost of providing the care, right? Because somebody has to. So they do that. in order to offset the losses incurred when a Medicaid patient is treated, when a Medicare patient is treated. Because again, those reimburse at lower than the actual cost. I'm not saying that the charges, lower than the cost of actually providing the care to the patient. So while Medicare and Medicaid, again, government programs, are able to reimburse coverage for a lot of people, which is extraordinarily important, providing them access to care, you take away that commercial component. How then do we ensure that access to care continues? Because hospitals, look, you can't pay the bills as a provider of care if you don't have revenue coming in from a commercial payer in order to do it. There's just no way to balance those books. So essentially, the hospital is operating at a loss, essentially for every single patient it serves. So the only way for a hospital to make that up, theoretically, is to serve more patients. So what does that end up doing at the end of the day? De facto, not the intended reality, but the de facto reality is that access to care goes down, because what has to happen, right? So the larger systems are the only things that can afford to exist anymore because they can absorb the lower reimbursement rate. Smaller hospitals, forget it, they'll close. I mean, there's no way for the independent hospital to survive. How does Bristol Hospital survive? How does Griffin Hospital survive? They just can't. So when we start talking, when we start talking about universal payer with the idea that it's going to increase access to care, I think we just have to be intellectually honest with ourselves. And we have to say that actually, that's probably not going to work that way. And it's probably going to have a negative impact on access to care. So I would just hope that in the course of studying this program, a single payer universal healthcare program, in the course of studying that, that access is considered in an honest way. Because I've been through this discussion before. When Speaker Donovan was here, when Kevin Lembo was here, this is not the first discussion we've had about universal coverage, universal payer, universal healthcare programs. So I'm very, very hopeful. And again, I'm sure the devil's in the details, and this is not a short bill by any stretch, but I just want to go on the record saying that I'm very hopeful that the commission that's put together is, honestly, I'll just say it, is a fair and unbiased group of individuals who don't have a desired outcome in mind, who actually want to control costs in a reasonable way, provide access to coverage in a reasonable way without sacrificing access to care. Like, I think that needs to be the very clear objective of everyone serving on this commission. I see that, it does list out who would be involved and who would serve. I'm not going to lie, I'm a little bit concerned by some of the folks that are here on this list, because I do think there are some agendas that may be brought to the table, and I guess we all sort of bring our own baggage, but at the same time, you don't want to walk into a commission studying an important issue where the outcome of the study has already been predetermined because of those participating on the commission. So I just think we need to be very, very mindful of that as a committee. Look, let's be honest, this bill is going to get out of here today, and it's going directly to the floor, which is probably okay in this case. But let's just be intellectually honest and make sure that we're going to get a really good discussion of the topic, a good discussion of the issues, a good discussion of the potential upsides, and also the possible risks. And I just felt I needed to share my thoughts on that. And Madam Chair, I appreciate the time.
Thank you, Senator. Any other questions or comments? Yes, Representative Case.
Thank you, Madam Chair. So when we look at this bill, we've done these bills in the past with my years here. Have we entertained looking at studies that we already have commissioned, because they do have the costs associated with them because they passed out of this committee before? And if so, why aren't we just using that instead of commissioning something to do it again? Through you.
Certainly, I would think that this commission will look at those prior reports. Since I've been chair, though, we haven't passed it out. And so I would would assume some of the data, a good deal of the data is outdated at this point in time. And so, like I said, I think they would most certainly look at it. But it is important to have a more updated review.
And I think it's been in the past 2 or 3 years that this has been done, but in looking through this, does it spell out exactly how many members? I think I counted about 23 people on this commission, if not more. Is that quite a few to try to make a decision that's unbiased through you?
So the membership is, you can find lines 20 through about 78. If the right people are at the table, I think it'll be a good conversation and they'll be able to put out some good recommendations.
And I thank you. So just a quick count, there's about 23 members that would make up this commission. I mean, that's just a huge number of people at the table with something they want to bring forward to try to solve something that I'm not too sure that we even have the ability to fund this in the state of Connecticut. That's my concern. The 13 years sitting here, I think it's been 2 or 3 times this bill has gotten out in order to try to figure out how to do single payer or a Husky for all type bill. And I think there's enough on the table to where once you see the numbers originally, I don't know why we're doing it again, because we're trying to lower costs in the state of Connecticut. And this is just going to make it so people who are eligible right now who can't get insurance, it's really going to bat them out of the park. I have concerns with it. I think I'll be a no vote to flag today because it's something that we're just repetitive and keep doing. I'll leave it up to anybody else who has questions so I can hear. Thank you, Madam Chair.
Thank you, Representative. Any additional questions or comments? Yes, Representative Vale.
Thank you, Madam Chair. Again, studies are kind of pointless in this place, as far as I'm concerned. Everyone always jokes about Representative Belcito on the House floor talking about, here we go again, Mr. Speaker. But he was truthful. And a lot of times we do a study, I think, to pacify people, make it look like we're doing something, and in reality, we don't. It gives people some type of false hope that something's actually going to happen. And if we've done this before, and there are studies, I don't see why. And I think if there was an appetite for this, that we would have passed this a long time ago. Out of committee is one thing, but through the House and Senate and over the governor's desk, hasn't happened. And I think there's a reason for that. I mean, to just keep restudying the same issue over and over doesn't make a lot of sense to me. And I do think sometimes, and I'm not saying in this case particularly, but I know in a lot of times we have just put the study on thing to, pacify a few people and make them feel like we're actually doing something. So again, I don't think I really need a study to figure out whether I would support a single payer health senator. I almost called him representative. I'm so used to working him, former mentor of mine, but Senator Perillo, I think, articulated the points very well as to why, we've been through this and it doesn't work. So I'm definitely against it. Thank you.
Thank you, Representative. Yes, Representative Johnson, followed by Representative Pizzuto.
Thank you so much, Madam Chair. And I appreciate the other side's remarks. Really, I do. We have been working on this for a long time. But if you take a look at the structure for the last 100 years, and believe me, I won't go into that, so I'll save you all the. But in any event, we have made changes over the years. And we had, just before the Affordable Care Act went into effect, we had almost gotten to the point where we were going to do a single payer situation here in the state of Connecticut. And then we passed the Affordable Care Act, which we thought was going to address everything. And after 3 lawsuits to the Supreme Court, there were a lot of cutbacks. Nevertheless, the Affordable Care Act was the next step in the next direction. So were other things like the when we look at some of our fairly qualified health centers, another step in that direction. So we're moving in that direction, and it wouldn't hurt to find out where we are after the Affordable Care Act, after all the changes in the regulations have occurred, after our generations, and I have generations in my district as an FQHC, and after all those things, I'd like you to see where we are and what the possibilities are. So I like the idea of this. I don't think it hurts to take a look at stuff. This is complicated stuff, as everybody knows here in this committee. And so I'm speaking in favor of it, and I just want to know more. And I'd be glad to share my 100-year study with you. Thank you so much, Madam Chair.
Thank you, Representative. Representative Pizzuto.
Thank you, Madam Chair. Just quickly, I noticed when you read the people that have opposed this, the Connecticut Hospital Association, to me, which speaks volumes, it's more of a comment than a question. But when I have been on a hospital board for many years, I see what they deal with, huge amounts of costs, many indigent people that they always do take care of and give quality care to. When a hospital association resists just a study, it sends a huge message to me that they don't think that universal health care is the way to go. But I just think that we should take notice of that and say, if they're not willing to sit on this and be part of it, that leaves out many huge, just in Waterbury alone has St. Mary's and Waterbury Hospital, let alone critical care places. So I think we have to look at this a little more deeply right now. I'd have to oppose this bill. Thank you.
Thank you, Representative. Any other questions or comments? All right, seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFHB 7101. Representative Gilchrist. Senator Lesser.
Senator Lester, yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr. Senator Anwar. Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico. Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Hughes votes yes.
Representative Johnson.
Representative Johnson votes yes.
Representative Kitt.
Representative Kitt votes yes.
Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott. Representative Shake. Representative Stewart. Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. We will be holding the votes open. We'll make an announcement later as to what time. Moving on to item number 2, House Bill 7102, an act concerning maternal and infant health care. Do I have a motion? Is there a second? Moved by Representative Johnson, seconded by Representative Kitt. This proposal does 3 things. It asks the Office of Healthcare Strategy, Department of Public Health, and Department of Social Services to develop a plan to increase the number of birth centers and birthing hospitals in our state. It increases the Medicaid reimbursement rate for doulas, and it has the Fatherhood Initiative expand its charge to teach fathers to support maternal health. Any comments or questions? Representative Case.
Thank you, Madam Chair. So want to expand birth centers throughout the state. You hear on the news a lot of hospitals are closing their birthing centers. For the reason that, from what I understand, the utilization. How does that figure into this? What would a birthing center do? Would it be in a hospital situation or be out of a hospital situation through you?
So that's a great question. And a major piece of this is to target areas of the state who have lost their maternity and delivery. And so we'd be looking to see, can we open these birthing centers in areas of the state where there is a desert for folks who are pregnant and about to give birth?
So would these be state birthing centers, or would these be private birthing centers, or would we bring private equity into open birthing centers through you?
So we did pass legislation, I think probably now 2 years ago, that expanded the birthing center statute. So, but only one is open so far in the Danbury area. So these are private entities.
So they're private entities through you that takes state Medicare dollars. Is that their main source, or are they also accepting outside insurance through the birthing centers through you?
They accept all types of insurance, including Medicaid.
So is a birthing center generally associated with a hospital, or is it like an outpatient
Yeah.
type? Because I'm just
Yeah.
concerned because we're looking at this and seeing so far two I've seen, one in the northeast corner, one in the northwest corner, asked for closing of their birth centers in the hospitals. Would we ask for somebody to go in privately and open one up associated with a hospital in those areas?
So under state statute, the birthing center does have to be associated with a hospital.
And so we go into the birthing centers, and there's barriers on that, but the doula aspect of it, do we allow doulas right now, Medicare, Medicaid? I believe that was a bill maybe 3 or 4 years ago. I believe they get a small amount. Is that correct through you?
That is correct.
And most doulas before that were private paid. Does regular insurance pay for doulas? Do you know?
It's a good question. I am unsure if private insurance covers doula care.
Because I know I
depends on the
I
plan.
have an insurance policy through here and they wouldn't cover my doula. I had to
Okay.
pay for it personally. And that was only 6 years ago.
Let me just,
So
Can I go to Rep. Johnson to answer your question?
absolutely, Madam Chair.
Representative Johnson.
thank you. And thank you for that comment because Representative Case, you're spot on. That's because it's an ERISA plan. The we here in the state of Connecticut, we have ERISA plans that are governed primarily by the federal government, and we don't regulate them. So if you're state regulated, it's one thing, and we can require that. And I don't know the answer to your question in terms of whether the state requires it, but ERISA, if we try to regulate all the plans like the state of Connecticut, then in that circumstance, it's a ERISA plan and it's federal, mostly federal, very little state oversight, just to clarify. Thank you.
Thank you, Representative Johnson.
Thank you, Madam Chair. And I think Representative Johnson, we have a little bit too much in common because of the areas that we represent. We have a lot of different things that go on, and over the years, I've learned some things from Rep. Johnson because she has a lot of information. So I
Well,
appreciate her giving that to us.
Thank you for your kind words. I appreciate
Yeah.
that.
No, it's true. And if we don't know this stuff to flush it out, it's difficult. So and the ERISA stuff would have to go to the insurance committee. That isn't our purview. Our purview is state insurance. And then we put in birthing, but then we expand the fatherhood initiatives, and that's been in this committee for years too. Through you, is that under existing law? It's available for federal and private funds, but what else are we trying to do through this with state funds through you, Madam Chair?
Thank you. We are expanding one of the things that the Fatherhood Initiative would work with these fathers on, and it would expand the role of fathers in supporting maternal health.
Okay. And I thank you for that because I believe what we did maybe 3 years ago was expanded by helping them out with more state dollars. So the Fathers Initiative could expand. So this just making and asking them to do more through the birthing situation.
Yeah, what we've heard is that some fathers, not all, feel like they don't have the language or the knowledge to support their partner when they're giving birth in the hospital. And so this would give those fathers some support so they could feel like they were more of an advocate for their partner.
And I think that's why I had a doula, because I didn't have that information to do that in the hospital. So she worked with her to get we all do it different ways. So, okay, thank you. That's all I have. Anybody else?
Representative Pizzuto, followed
Thank-
by Representative Scott.
Thank you, Madam Chair. Just quickly, I saw that it said within available appropriations for Department of Social Services to provide funding for this, yet they opposed it. Do you have any idea why? I know we've been in front of that commissioner many times. So.
Which piece is this? Is this
Uh,
the,
It was on HB 7102, and it was under section 2,
section 2? Okay.
requires DSS within available appropriations. So I'm assuming they can afford it, but if they can't, is she just saying, no, we can't afford it, or?
So what we see time and again is the commissioner does have to oppose anything that's not included in the governor's budget recommendation. But as you know, we're still having our budget process ongoing. And so if we are able to increase dollars for doula coverage,
Then she'll do that. I
Yeah.
see. Okay, thank you, Madam Chair.
you're welcome.
Yeah.
Representative Scott, followed by Representative Vale.
Thank you, Madam Chair. Two questions I have. First one around the birthing hospitals or the birthing centers. Is there a report specifically, and we've heard about these shutting down as Representative Case talked about. Do we know roughly at this point how many were short, what population we're short on, just to try to give a scope and understanding of what we're missing, like where we're not getting great coverage at? Do we have any kind of data on that, or is there any study that's happened already on that?
So great question. That's actually the intention of this section 1. So currently in the state, there have been, I know in Windham County, the labor and delivery closed. Up in the northwest corner at Sharon Hospital, labor and delivery closed. And there might be a third in the state. We only have, so then we also established, we expanded our state statute regarding birthing centers, but so far only one has opened.
Yeah.
And so what we're looking to do is better understand if we can support the birthing centers in opening in areas of the state where we've had that loss of labor and delivery, and in areas with a high Medicaid utilization.
Okay, thank you. I just know that the way I read it was we were just coming up with a plan to increase it, knowing that, so we're almost to the point of like, hey, we know there's a problem. Let's go there. I just want to try to get to the baseline problem. If that's also being looked at too, that's great. I think that's beneficial. Secondly, and please excuse my ignorance, but a doula. Can somebody explain the difference between a doula and maybe a midwife or something like that? I haven't used either. If there's anyone on the panel that could talk, or on the committee, I would greatly appreciate the clarity on that.
Through you.
Yeah, I'm going to
Madam
turn it
Chair.
to Representative Shape.
Thank you.
Sure. As best as I can. This is my this is my wheelhouse because I'm a nurse in women's health. So a midwife is usually a certified professional, certified midwife. It's extensive education, higher education, training, hours, etc. A doula is someone who goes through a type of training and they do not have the higher qualifications of being able to, well, in some states and areas of actually fully assisting with the birth of a child. So in my profession of where I work, and other hospitals have started to incorporate doulas to be available for patients during their birthing process. And then they also get to stay for the postpartum as additional support services. So it's essentially advocating for what the desires and needs are for the patient themselves, so that things happen sometimes very quickly. And depending on what's going on and obvious stress of just birthing a child, it has been a huge benefit and a source of, I would go so far to say truly comfort in knowing that there's additional personnel there advocating on behalf of what it is that the mother wants. So, a nurse midwife a certified nurse midwife is someone who can actually help the patient in the birthing process. And also in the hospital where I work, we have certified nurse midwives, and they're very highly regarded and utilized and appreciated. So I can say because of legislation that had passed and was discussed at length last year, where I work, there have been changes to personnel of who have been hired, and that includes bringing doulas into the hospital service. And we've had nothing but positive responses from our patients. So this is a bill that you didn't ask me, but I will be supporting. So I appreciate. And if there's anyone else who, as I'm looking around, would want to, Representative Kit, to add any information might be helpful.
Okay, Representative Kit, go right ahead.
Yeah, it's a scope of practice delineation. Nurse midwives are certified to provide medical care. Doulas do not. They provide simply emotional support, education, and counseling. So it's medical versus other support. And both have very important roles and can significantly decrease maternal mortality and morbidity around the birthing process. And there's a distinct role and need for both.
Great, thank you both.
Great. Yeah.
Representative
Thank you
Scott.
both for that. So from my understanding then, for the most part, a mother having a child wouldn't just have a doula there. Like there should be another, either a midwife or a gynecologist or something like that there to help just in case there's something medical that would be needed. So that's a huge clarity for me, someone who didn't know. So I appreciate it. That's all the question I had. I just wanted that clarity. So thank you.
Yeah,
Thank
through
you.
you, Madam Chairwoman, that would, my understanding is that is correct in a hospital setting or a birthing center, just to clarify.
Wonderful, thank you. Representative Vale, followed by, nope, I guess she just answered. Go for it. Followed by Representative Pizzuto.
Representative Scott's line of questioning made me have more questions, but then you guys already answered them. So thank you for that. I want to get back. So I represent an area with a small hospital that chose not to do deliveries anymore, which I vehemently oppose, as they know. And one of the reasons it's kind of started through COVID, and now it's kind of the reason we were given that they were going to stop doing that. And the other services they couldn't provide through there. They brought back the other services, but not that. And I think it's a big loss in our area. But their biggest thing was money and lack of nurses. So what is going to be different about birthing centers that if our hospital isn't able to have the money or be able to sustain the costs for delivery and acquire nurses, how are these birth centers or birthing centers going to be able to do that if they can't?
Great question. And again, that really is the strategic plan. So it'll be looking at the barriers, and money is obviously a large one. But are there other barriers to opening birthing centers? And then are there incentives that can be offered? It'll look at that. And then it's also going to look at an evaluation of best practices, because we're not the only state that this is happening in, right? And so I think the reason we want this first step is because we don't have the answers yet to what you're asking. And so how do we make it where we could potentially have birthing centers that might be a more cost-effective option than doing it in the hospital?
All right, because if we're going to put resources behind it, then maybe we could look at putting resources into the hospitals too. So that's where, and I'm worried about, I don't really want to let them off the hook. So I don't know if this kind of does that a little bit. So I'll sit and listen to some more questions, and thank you for your answers, because you answered my questions before I ever asked them.
Great, thank you. Representative Pizzuto.
Thank you, Madam Chair. Upon checking, I was asking about gynecologist malpractice insurance. It's about $400K a year. And when you look at doulos and those, will the birthing hospitals help? Usually a gynecologist has to work in a group on their hospital. They pick up their malpractice. Who does that? Does a doulos buy their own? And won't that be a significant, even though they may only be counseling, they may not be providing, physical medical care, but I've seen, this is no lie, anesthesiologist friends I know, they were sued because when the patient woke up, they lost their ESP powers. And that malpractice had to cover that. How do you prove it? So people will sue for anything. And I worry that's an expense that's kind of buried in just the term doulos, unless they pick it up on their own. Would you know if they're covered by some other policy, like doing CPR on a person? You're held harmless. Does that follow through in this?
So as you said, but I do want to make it clear on the record, doulas aren't going to be doing any of the medical care. Some doulas work in a group, and so the group they work with might do insurance for the group. They also work independently. I think that's up to them individually.
Thank you.
You're welcome. Any other questions or comments? We're just gonna stand at ease for a minute. Yes, Representative Case.
I was just trying to get an answer before I came up, but and on line 130, is that the existing statute, or it says no later than December 1st, 2022? It's a few years back.
So that is the statute regarding the fatherhood initiative, I believe. Yes, so that's the state statute regarding the fatherhood initiative. And so that was established back in 2022. We are just, if you see line 46 and then lines 48 and 49, that's our proposal in this committee.
Thank you for the clarification. So we have gotten those reports back to the committees of cognizance as far as you recollect. correct?
Yes.
Thank you, Madam Chair.
You're welcome. Any other questions or comments? All right, seeing none, would the clerk please call the roll?
Representative Butler did raise his hand.
Sorry about that. Go right ahead, Representative Butler.
Sorry for the late jump in, Madam Chair. I just wanted to add a quick comment for this bill. It's much needed. I think anytime we can increase health care for mothers and infants and reduce the maternal and infant mortality that happens in the state, we need to support those initiatives. Also, quickly about the fatherhood initiative, I think it's very important that we need to keep in mind if we actually increase the relationships between the fathers and their significant others, the role that this play actually reduces some of that domestic violence we see out there. And anything we could do in that arena is a big plus. So for those reasons, I will be voting to support this bill. Thank you, Madam Chair.
Thank you, Representative. Any other comments or questions? All right, now seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFHB 7102. Representative Gilchrist,
Yes.
Senator Lesser, Representative Case,
Flagging for a no.
Senator Perillo, Representative Comey,
Yes.
Senator Marr,
Senator Marr votes yes.
Senator Anwar, Representative Butler,
Representative Butler votes yes.
Representative Dathan,
Representative Dathan votes yes.
Representative D'Amico, Representative Fortier,
Yes.
Senator Gaston, Representative Hughes,
Hughes votes yes.
Representative Johnson,
Representative Johnson votes yes.
Representative Kit,
Representative Kit votes yes.
Representative Master Francesco,
No.
Representative Meskers, Representative Pizzuto,
No.
Representative Santiago,
Yes.
Representative Scott,
Rep. Scott votes yes.
Representative Shake,
Yes.
Representative Stewart, Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. And as a reminder, we will be holding the votes open. Moving on to number 3 on our agenda, House Bill 7190, an act concerning the Department of Aging and Disability Services. Is there a motion? Is there a second? Moved by Senator Marr, seconded by Representative Kit. This legislation would require ADS commissioner to study various needs of senior citizens. Any comments or questions? Representative Case.
Thank you, Madam Chair. So just so we know, this bill really has no content. This is a placeholder dummy bill. Is that correct through you?
They are called different things in this building, but yes.
Okay, and as for that, I don't vote for anything that doesn't have content, so I will be a note on this. Thank you.
Thank you, Representative. Representative Vale.
Thank you. And just to reiterate, what the good ranking member said, I don't believe in this process of placeholder bills. We have a legislative process that we go through. You bring up your ideas, we discuss them. We've had, hundreds or, in the high 80s, 90s, 100 people testifying in front of us at these hearings. And there isn't anything we haven't talked about in this committee. So we shouldn't need to leave a bill hanging around to add other things we may not have talked about. Because technically we can say that this bill has had a public hearing, but there was no substance to it. So it's a way of circumventing the process. I'm a firm believer in the process. Sometimes ideas and bills pass through this legislature that I don't agree with, but if they go through the proper way, I support that 100%. So when we do things like this, and I know we do them in every committee, and I say the same thing in every committee, because it's not something I believe in. I believe in the process. If they're good ideas and they have support, it'll pass. And if it doesn't and they have to wait, we shouldn't be throwing them onto a placeholder bill. So if there are any others after this, I won't repeat myself, but I'll be voting against this for that reason. Thank you.
Thank you, Representative. Any other questions or comments? All right, seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFHB 7190. Representative Gilchrist,
Yes.
Senator Lesser, Representative Case, Senator Perillo, Representative Comey,
Yes.
Senator Marr,
Senator Marr votes yes.
Senator Anwar, Representative Butler,
Representative Butler votes yes.
Representative Dathan, Representative D'Amico, Representative Fortier,
Yes.
Senator Gaston, Representative Hughes,
Representative Hughes votes yes.
Representative Johnson,
Representative Johnson votes yes.
Representative Kit,
Representative Kit votes yes.
Representative Master Francesco,
No.
Representative Meskers, Representative Pizzuto,
No.
Representative Santiago,
Yes.
Representative Scott,
Representative Scott votes no.
Representative Shake,
Yes.
Representative Stewart, Representative Vale,
No.
Senator Lesser.
Yes, the Republicans didn't like that vote.
Representative Dathan,
Representative Dathan votes yes.
the roll call is complete.
Thank you, Madam Clerk. As was mentioned earlier, we'll hold the votes open. All right, moving on to number 4 on the agenda, House Bill 7022, an act promoting equity and Medicaid coverage for fertility healthcare. Is there a motion?
So moved. Second.
Moved by Senator Lesser, seconded by Representative Shake. Are there any comments or questions? Senator Perillo.
Thank you, Madam Chair. And again, in the spirit of getting caught up, what analysis has been done so far regarding the costs to the state of Connecticut from this?
We have gotten some numbers from the Department of Social Services, and then if we vote this out today, we will be able to get a fiscal note from the Office of Fiscal Analysis.
I appreciate that. Thank you. So the Appropriations Committee doesn't JF for a number of weeks. Why would we not just send it there?
The process in this committee, this session is to JF bills to the floor and then have them sent to the Appropriations Committee.
Okay. We're doing that across the board? Okay, thank you. I appreciate it. You know what? That's what I've got so far. And if you don't mind, I may have another question, but right now that's what I got. Thank you, Madam Chair.
Don't mind at all. Any other questions or comments? Representative Master Francesco.
Thank you. Thank you, Madam Chair. So I'm looking at this bill here before us. All the language in this particular bill, if I'm understanding, is all new. Is that correct? To you?
Yes, because this is addressing our Medicaid program, which does not currently cover fertility care unless it is deemed medically necessary, and that term is defined.
Okay, so currently our Medicaid program does cover fertility treatment. Am I correct for you?
No. We were told we're still actually trying to figure this out because we were told at the public hearing that deemed medically necessary, some infertility is covered under Medicaid, which was news to us. But in terms of fertility coverage and the broader infertility, no, Medicaid does not currently cover that.
Okay, thank you for that. So even if it's medically necessary, they do not cover it? I thought you said that they did if it's medically necessary through you.
We're still trying to figure that out because it was mentioned at the public hearing that they do, but we hadn't known that before. And so we are trying to understand what is currently deemed medically necessary by the Department of Social Services so that they cover. Yeah.
So what's deemed medically necessary, I guess, in my mind, because I do know a couple people actually going through this. Medically necessary was that you cannot medically get pregnant. Maybe there's something wrong with your eggs. They're just not connecting, right? Your eggs are just not connecting. So that would be medically necessary. Does this bill expand it even further to people that they don't medically necessarily can't get pregnant?
So this bill does expand the definition of infertility that we have in state statute. We currently have that in state statute for our insurance purposes, but this will expand that definition of infertility.
Thank you. And an infertility meaning what? When I look at infertility, it's you don't have enough eggs, you can't produce. There's a problem with the woman or the man with the sperm. That's in my mind infertility. So I guess I'm just trying to extend what the expansion of infertility actually means to you.
Yes. So this bill will use a definition that was agreed to by the American Society of Reproductive Medicine. And that is inclusive of the inability to achieve pregnancy based on a patient's medical, sexual, and reproductive history, age, physical findings, diagnostic testing, or any combination of those factors. The need for medical intervention, including but not limited to the use of a donor gamete, donor embryo in order to achieve a successful pregnancy, either as an individual or with a partner. And it will also, in patients having regular unprotected intercourse and without any known etiology for either partner suggestive of impaired reproductive ability, Evaluation should be initiated at 12 months when the female partner is under 35 years of age and at 6 months when the female partner is 35 years of age or older.
Thank you, for that answer. So would this coverage also cover, let's say one who, same sex, let's say two females, they do not have, sex with a man? Would this legislation include infertility for them to you?
Yes, it would.
Okay, so it goes beyond a medical condition. Like you said, right?
Correct.
Okay, so if we have two people that are of the same sex, they don't want to have to conceive naturally, what we are going to do is we are asking to pay for IVF, IBS, in vitro fertilization for them. That's correct analogy, correct?
Correct.
Okay. How about someone who has taking hormones, medication for transitioning period? You have a woman maybe transitioning, taking hormone pills, and that medication actually ruins the chances of them for having a baby. We've seen a lot of studies of that out there. Would they be covered under this as well?
This covers any individual who is seeking to achieve a successful pregnancy.
Okay, thank you. Also, would this cover people here that are illegal aliens, illegal immigrants here in Connecticut that are on Medicaid? Through you.
I don't believe this piece would be covered for undocumented immigrants at this point in time under our current state policies.
Thank you. So I do know that any federal funding that we get does not cover undocumented illegal immigrants here, right? But the state portion of it can. And if I'm not mistaken, I've heard in this committee that some of our state funding people that are on Medicaid, there are some that are undocumented that are here, and it covers it. Can you point out to me where it would not cover someone under this particular bill?
So Medicaid in the state of Connecticut, the state portion, as you mentioned, currently covers individuals who are undocumented children under the age of 15, and then pregnant and postpartum women. It does not cover the family planning benefit, and this would fall under the family planning benefit.
Okay, so they would not be included under this particular legislation. Okay. Does this particular bill also cover the preservation of sperm and eggs to be frozen for future insemination? Through you.
Yes, this proposal would cover embryo cryopreservation for men and women, sperm cryopreservation in men, and oocyte cryopreservation in women.
Thank you. And I know you had mentioned when you were talking to Senator Perillo that you did speak with Department of Social Services and did get some numbers from them. Can you share those numbers with us, please? To you.
Yes. So the Department of Social Services, based on an understanding that this would fall under our family planning, which is a 90% reimbursement from the federal government currently. The cost of the infertility services alone in fiscal year 27, the state share would be 1.5 million.
Thank you. So that's the state share. I mean, infertility, IVF and so forth is very, very, very expensive. 1.5 million doesn't seem like a heck of a lot of money. Do you know the portion that we get on a federal level?
Yep. The federal share that same fiscal year 27 would be 13.9 million.
13.9 million. Okay. So 1.5 million, 13.9 million still is taxpayer dollars. It's just coming from a different checkbook. That's the bottom line. 1.5 million is coming from our checkbook. Here, the taxpayers here in Connecticut, and obviously on a federal level, 13.9. I have a lot of concerns with this. Do we know? Obviously, we want people to have families. There's nothing more than I love more than to grow our families here in Connecticut. But I also get concerned, when people can't afford it, and it's obviously causing more hardship. But yes, we know we have that desire that at some point we want to have a baby. what I get concerned about here is we have two people that maybe are the same gender that don't want to go through the normal process of conceiving and having a child. And I can understand that. I'm not insensitive to it, but I don't understand why the taxpayers should have to pay for that. And certainly that's obviously my concern about that. There's one more question I had, Madam Chair. Let me just see if I can find it here. This one, maybe it was in another. And when would this particularly take effect to you?
This proposal takes effect January 1, 2026.
Okay. Would this in any way people right now, because I do know some people that are on Husky that are, well, let me say not Husky, let me just say Medicaid. Is it different when you're on the exchange, the Connecticut, the exchange for this? Is that two different programs through you?
Yes, this would not apply to the private insurance market.
Okay, so the Connecticut market exchange does not apply to them at all, but it only applies to people that are on Medicaid.
Correct. I believe there was a companion proposal in the insurance committee. I don't know if that has moved anywhere.
Okay, thank you. Thank you. I don't have any further questions. Thank you.
Thank you. Yes, Representative Vale.
Thank you. In the title, it says an act promoting equity in Medicaid coverage for fertility healthcare. That's a buzzword for me. Equity for who? Where's the lack of equity in that I'm not picking up on?
So one example, as you might know, I chair the endometriosis working group, and we had a provider share with us that it's been really hard when she has a patient who has endometriosis, who has private insurance, who can access fertility care, because we do have a requirement under state law with regards to private insurance. But if the next patient who comes in is receiving their healthcare through Medicaid, they cannot access that. So the equitable piece is about ensuring that regardless of where you get your health insurance, you'd be able to access fertility treatment in the state of Connecticut.
Okay, because usually that word isn't put around people's medical issues. So thanks for clarifying that. And then, so the infertility piece. So this, just follow up with Representative Master Francisco's questions. This goes beyond infertility. So this will help. This will also cover people who may be fertile, but can't conceive because of the situation that.
So I'd make the clarification that I think our kind of like the commonplace understanding of what infertility is, correct. This goes beyond that, but the American Society for Reproductive Medicine, as of 2023, has a new definition on infertility, which includes individuals from same-sex couples.
And that's their definition. Like, who else uses what makes them their definition is what we should go by? Is that what other states use? Is that what the United States government uses?
So this proposal before you is modeled off of a proposal or a law that's currently in New York and Washington, D.C. More about the American Society for Reproductive Medicine. It's a leading organization that does put out guidelines for those in the reproductive medicine field.
Okay, so we choose to use their guidelines. That's not something that's like governmental or anything like that, correct?
Correct.
Okay. And so what if someone were single and they weren't in a relationship at all and they wanted artificial insemination? Would they be eligible through Medicaid?
They are eligible for the services outlined in this proposal, yes.
All right. Well, I certainly have issues with several things in this, but that one probably concerns me the most. but, I'll let my colleagues ask. Thank you.
Thank you. Yes, Representative Pizzuto.
Thank you, Madam Chair. Once again, if they pay for fertility issues, let's say a woman has a child and then decides to get a tubal ligation, would they cover that? Would they then, because they'd still say that's part of a woman's prerogative? Like, and I was just, okay, I had my kid and I don't want to have any more children. Can they go back and get from Medicaid funding for that? Through this?
That's a great question. Tubal ligation is not included in this proposal.
Right.
I don't know if tubal ligation is something that's covered under Medicaid
Okay.
currently. That would I would need to ask our nonpartisan staff, but that's not included in this proposal.
Sure. All right. And people that oppose this, one of them was Women's Liberation Front, said their mission is to restore, protect, and advance the rights of women and girls through legal argument, policy and advocacy, and public education. Yet they oppose this bill. Why? Any reason? Did they feel it was prejudice against women?
They're an organization that's not here in the state of Connecticut.
Wouldn't they be an advocate for women's rights, no matter what? I mean, what state, regardless of what state?
I've been told that they are a fringe feminist organization.
Jesus,
I don't know
can't be
much
that.
about it.
Yeah. Well, so I again, I don't mean to batter you with questions, but I look at the pros and the cons, the opposition, those for it. And when I see organizations like this, either they're asking for something else that should be in the bill or they don't like something in it. Do you have any recollection based on their testimony of what that might have been, why they might have opposed it? No.
I do recollect one thing they said,
Yeah.
which I found pretty true.
Yeah. We're amongst friends.
They had some pretty extreme views. That's all I'll say,
Mhm.
but I would encourage folks to go back and look at the CTN video.
Okay. That's it. Thank you.
Yes, Representative Master Francesco.
Thank you, Madam Chair. As my colleagues are talking, I have an opportunity to just kind of look further into the bill. I'm looking at lines 24 through 37. And I guess I am going back to the same partner conversation, same sex partner, two women. Where do I find in this language that they would be included in here? Can you kind of point that out to me? I'm a little confused on that.
Yes. So if you go to line 24,
Okay.
That section, so, and then I'm sorry, so actually go to line 35, E, infertility as defined by the American Society of Reproductive Medicine.
Okay.
And the definition.
You knew I was going to ask you that question.
Yes, if it's okay with you, I won't read the whole thing again.
But that's okay. Just a highlight.
Yeah,
You can just-
the piece would be in the definition is the need for medical intervention, including but not limited to the use of donor gametes or donor embryos in order to achieve a successful pregnancy, either as an individual or with a partner. And so what that's explaining, is that you need the donor gamete or donor embryo.
Okay, thank you. You know what I find really, when I see bills like this, to Representative Vale's point, when I see that word equity in there, and this goes for people that are straight, male and female, and these goes for people that have are the same sex partners. When I see something like this, so for example, I know people that have gone through this process, right? And they work, they're not on Medicaid. It's very, very expensive, and they had to pay a lot of money out of their pocket for it, whether they were same-sex partners or not. They work hard and they got to pay a lot of money out of their pocket. But yet somehow, if you are on Medicaid, you get special treatment. They don't have to pay out of their pocket. The taxpayer gets to pay for it to expand their family. Does anybody not see a problem with that? Do you think it's fair that someone who's trying to have a baby, that just because they're on Medicaid, the taxpayers will pay for it? But if you work a full-time job and you're over that income limit and you can afford it, you got to pay. It's thousands and thousands of dollars. I don't know, this is the thing that absolutely drives me crazy in this committee, is that we are always putting people in different categories and giving special treatment to people. It's not fair. Of course, I want everybody to grow their families. 100%, I think it's a beautiful thing. But why should somebody else have to pay for that? I just find it to be outrageous, to be quite honest with you. And that's really my contention with this bill. I don't know how anybody in this committee can sit here and tell me it's fair that somebody who works a full-time job, maybe they don't make a lot of money, they're not on Medicaid, but they're doing the right thing, that they are working and they want to start a family and they can't afford it. And maybe they go take out a loan and do whatever because they have to pay for it out of their own pocket. But guess what? If I don't work, my neighbor will pay for it. And I can start growing my family. The taxpayers will pay for it. It's just not fair. That's my biggest pushback on this bill, Madam Chair. But I appreciate you listening to me vent. Obviously, I'll be voting no on this today, and I have no further questions. Thank you.
Thank you, Representative. And I just want to make clear for the record, with nearly 1 million people who receive their health care through Medicaid in the state of Connecticut, many work who receive Medicaid. Any other questions or comments? All right, seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFHB 7022. Representative Gilchrist. Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey. Senator Marr. Senator Anwar. Representative Butler.
Representative Butler votes yes.
Representative Dathan. Representative D'Amico. Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Representative Hughes votes yes.
Representative Johnson.
Representative Johnson votes yes.
Representative Kit.
Representative Kitt votes yes.
Representative Master Francesco.
No.
Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott's a no.
Representative Shake.
Representative Shake votes yes.
Representative Stewart. Representative Vale.
No.
The roll call is complete.
Thank you. As a reminder, we will be holding the votes open. Moving on to number 5 on the agenda, Senate Bill number 1477, an act concerning a covered Connecticut trust fund. Is there a motion? Is there a second? Moved by Senator Lesser, seconded by Representative Johnson. Any questions or conversation? Yes, Senator, oh God, Perillo. I'm sorry, guys.
Thank you, Madam Chair. I appreciate it. So I'm just wondering, I'll be honest, I'm not a fan of funds like this existing outside. Would this exist outside the budget? I just want to kind of understand exactly where this money would reside.
Great, thank you. And I'm going to turn it over to Senator Lesser.
Thank you, Madam Chair, through you to the honorable ranking member, and congratulations. Excited to work with you in that new capacity. Yes, that would be potentially where it would reside. We're still, I will just also refer you to the language in sections B and C, where this is very much a study in concept. So we're having a conversation about where best to house it.
Senator Perillo.
Thank you, Madam Chair. So I appreciate that, Senator, that it's a study. But section 1 says there is established an account to be known as the Covered Connecticut Trust Fund, which shall be a separate non-lapsing account within the Grants and Restricted Accounts Fund established through blah, 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 blah. So we're creating the trust fund, though. So I appreciate that we're studying it, but at the same time, we're creating it. So I think we need to understand where that money's going to come from, sir.
Senator Lesser.
Totally agree. What I would say is that due to the uncertainty on the federal level, including the potential for the expiration of the expanded ACA subsidies, and as well additional changes to the Medicaid program, we're concerned about how that could result right now in an impact on Connecticut's state spending, since we are legally required to fund the Covered Connecticut program, and that could create a conflict with our state spending cap and other restrictions. And so the question is, how do we best position Connecticut to have these two conflicting laws and manage that? And I don't think we've totally hit on the solution, but what the committee is deciding today is to start the conversation and see what we could do to help manage that budget conversation going forward. And I totally understand that there's a lot of uncertainty right now. We do not know. I do not know what Congress is doing. Maybe other people do, but we're hoping to start the conversation so we can be best positioned to sustain Covered Connecticut, given that uncertainty.
Senator Perlow.
Thank you, Madam Chair, and I thank the senator for his answer. I don't agree with him, but I thank him for his answer. A further question about the account itself. So on line 5, it says the account shall contain any monies required by law to be deposited into the account. So through you, Madam Chair, where does that money come from?
Right now, there is no dedicated funding source. I think this would be a conversation that we can have with the two money committees. It is above our pay grade on human services, but we're trying to start that conversation given the potential for disruptions to the program.
Senator Perlow.
Thank you, Madam Chair. And again, I thank the gentleman for his answer. So we're establishing an account. We're not saying where the money's going to come from. We're not really sure where the account is going to reside. We're not really sure how we're going to spend the money, because it states later on that, in lines 13, 14, 15, that the Commissioner of Social Services and the Insurance Commissioner shall develop a plan to use monies in the fund to sustain healthcare services. Doesn't say why or how. So I'm a little concerned that we've put the cart before the horse here. We're creating a fund. We're creating it. That's what this bill does. It creates a fund. Doesn't say how we're going to fund it. Doesn't say exactly what the money is going to be used for. Doesn't really say very clearly where that fund is going to reside. That's troublesome for me. I would hope it would be troublesome for other folks. We don't typically establish a bucket of money without any sort of indication of where the money's coming from or who gets to put their hands in it and take the money out. I could see where perhaps we would want to study the concept of a covered Connecticut trust fund. I could see that. But to create the fund and then study everything else without any real solutions or ideas is concerning. That's how we make bad decisions in this building, by setting something up with no plan at all. I certainly don't have something drafted. I wish that I did, but I could see a world where I could support a study of all of this. But like I said, that's not what this does. This creates an obligation without any idea of how we're going to fulfill it, where the money comes from, or even what the obligation's intended to do after that. That really wasn't a question. It was a statement, but I see that the senator might want to address it.
Senator Lesser.
I share your anxiety through you, Madam Chair. I think the issue is that the federal Medicaid program writ large, or the Medicaid program writ large, is a partnership between the state and the federal government. And we have, by law, committed to fund benefits with the assumption that federal funds are going to be here. And if they are not, we are still obligated to fund them. And that's been a problem. That was a problem during the pandemic when we had, we had a moment of good budgeting when we got a higher than expected federal FMAP, a federal reimbursement. And then we had this problem where the feds decided to cut back on the reimbursement levels. And that just automatically resulted in a huge impact on our state budget and our spending cap, because we were obligated to keep providing the service, but we don't have a lot of certainty over, we have no certainty over what federal money is going to attach and whether or not the federal government is going to keep its commitment to the people of Connecticut. And so what we're trying to do is to sort of think through covered Connecticut, and I guess by extension, Medicaid, and understand, given, although we're starting with covered Connecticut because it's a much smaller program, it's much easier to understand. But what kind of planning can we do right now for the fact that we are obligated to, by law, to provide a service, and how on earth are we supposed to budget when we don't know whether or not the federal government is going to keep its end of the bargain? And so we're trying to create a mechanism to provide some level of fiscal assurance, because otherwise we could have a situation tomorrow where we wind up having ourselves in $2 billion over the state spending cap if the feds stop funding the Medicaid program appropriately. So that's my concern, and that's why we wanted to start this planning process now. This bill starts it's both planning, but it also creates a fund so that if we're able to identify funding, that could provide continuity and budget stability to the Covered Connecticut Fund. 3.
Senator Perillo.
Thank you, Madam Chair. And again, I thank the senator for his answer to the statement. So I can appreciate that. I can appreciate that. But again, just sort of going back to my concerns about the uncertainty of what exactly we're doing here, and back to lines 13 through 18, where it states that the commissioners shall develop a strategic plan to use monies in the fund to sustain healthcare services offered through the programs. That's a pretty broad statement to say sustain healthcare services. Is that funding to pay reimbursement for healthcare services provided? Is that funding to sustain the agencies that administer those services? Is this intended to pay salaries within the departments? It's just not clear to me. And the fact that we're giving this control of a strategic plan to commissioners whose departments could actually benefit from the spending of the money in the first place, that's concerning. I mean, do we perhaps want to spell out a little clearly what the funds in the trust fund can and cannot be used for? Because, and I say, again, look, I'm not voting for this bill, but in the interest of making it a little bit more specific and avoiding dangerous territory, we're basically letting 2 commissioners decide how we're going to use money deposited in this trust fund. We don't know what kind of money is going to go in the trust fund. For all we know, it could be tax dollars. And let's be honest, that's probably what it's going to be. So can the senator give some sort of narrowing as to how those funds can be spent? Through you, Madam Chair.
Senator Lesser.
So I want to be clear. The bill does not give authority to the commissioner to reorient the Covered Connecticut program. It does direct her to come up with a plan. Obviously, we have a lot of moving pieces at the federal level right now, but one of the considerations, so right now the Covered Connecticut program pays for all cost sharing, all premiums, all cost sharing for people on the program, as well as for dental and non-emergency medical transportation. Perhaps when doing an accounting and realizing that we might lose some federal funding, we might decide, those are really important things, but those are nice to haves, not must haves. And so maybe some lower level of support is something that we can sustain on our own, given a shortfall of federal funding. Obviously, that is a big policy consideration that this committee and other committees will have to make, in viewing recommendations. What we're doing is we're not trying to say that the commissioner will have the ability to rewrite this program writ large, but that we're asking her to start the planning process so we can understand considerations. And with respect to the comment you made earlier, through you, Madam Chair, there is no, this would be support for the programs. It's programs offered through Access Health. It's not for Access Health. Access Health is not funded, but through Covered Connecticut. So it's funded separately.
Senator Perillo.
Thank you, Madam Chair. And again, I thank the senator. I appreciate the answer. a further question. Lines 19 through 26 address the report that the Commissioner of Health Strategy will file. And one of the things that the commissioner needs to speak to in that report is the appropriations and the budgets, and the funds needed to sustain the fund and said programs and subsidies. So that's a report that's due September 1st of 2025. Is the expectation that the trust fund that will have been created and funded prior to that, such that there could actually be a report on September 1, 2025? Through you, Madam Chair.
Senator Lesser.
Through you, yes, I mean, I think the assumption is that this is a conversation we're having right now in the context of our state budget. I do not know what Congress's timetable is for the budget reconciliation package, nor for a potential extension of some or all of the ACA subsidies. The hope is that we'll have more guidance, more clarity by September. And so we'll be able to see what we were able to do in the budget, as well as have some more insight into what Congress is considering.
Senator Perillo.
Thank you, Madam Chair, and thank you, Senator. I appreciate it.
Okay, I see hands. Representative Case, followed by Representative Vale.
Thank you, Madam Chair. And I heard a lot of comments and working here and listening to the ranking senator and the chair senator. And I have a lot of concerns. I see this, and it was said by the co-chair of this committee that this is for the two money committees to decide. So with that, per Joint Rule 3B1 requires that all bills and resolutions carry requiring appropriations shall be referred to Appropriations Committee. The bill before us requires appropriations. Therefore, Madam Chair, I move that Bill number 1477 gets referred to the Appropriations Committee, and I request that the vote on the motion be taken by roll.
Second.
Okay, there's been a motion by Representative Case and a second by Representative Master Francesco for an amendment,
It's a referral.
a referral.
What's the motion on the floor?
The motion on the floor is to refer Senate Bill 1477 to the Appropriations Committee.
It's on our table.
Is there any questions or?
Taken by roll.
All right, Senator Perillo.
Thank you, Madam Chair. I appreciate it. I know it was stated previously that the game plan for this committee is to send bills to the floor and then have the floor send them back. And while I don't agree with that strategy, I understand it. But to the representative's point, the bill before us actually specifically states that it is the job of the money committees to determine what comes in and what comes out. So because the language of the bill specifically gives that responsibility to the money committees, I agree with the gentleman that it would be appropriate to send this over to appropriations. So I appreciate his thoughtfulness on that, and I concur that that's the right thing to do.
So just to be clear, there's an amendment on the motion. So I made a motion to JF to the floor. This is an amendment on that motion to JF to approps. Senator Lesser.
While I thank you, Madam Chair. And while I agree with the proponent of the amendment that this bill will have to go to one or both of the money committees, in the estimation of their chairs, the best course of action working around their schedule is to send it first to the floor, and then subsequently will be referred to the committees by Senate screening. And so as a result, I would ask members to please oppose the amendment.
Any further comments or questions on the amendment? We'll stand in recess. All right, I would like to call the Human Services Committee back to order. Would the clerk please call the roll on the amendment?
Representative Gilchrist,
No.
The aggregate amount of loan
No.
reduction.
Representative Case, Senator Perillo, Representative Comey,
No.
Senator Mar,
No.
Senator Anwar,
Senator Unruh votes no.
Representative Butler,
Representative Butler votes no.
Representative Dathan,
Representative Dayton votes no.
Representative D'Amico, Representative Fortier,
No.
Senator Gaston, Representative Hughes,
Representative Hughes votes no.
Representative Johnson, Representative Kit,
Representative Kit votes no.
Representative Master Francesco,
Representative Master Francesco votes yes.
Representative Meskers, Representative Pizzuto,
Yes.
Representative Santiago,
No.
Representative Scott,
Representative Scott votes yes.
Representative Shake,
Representative Shake votes no.
Representative Stewart, Representative Vale.
Yes.
The roll call is complete, Madam Chair. Oh, Representative D'Amico,
D'Amico votes no.
Representative Johnson, then the roll call is now complete, Madam Chair.
Thank you, Madam Clerk. Would you please announce the roll or the tally?
The tally is 6 yeas, 14 nays.
Thank you. The amendment fails. Representative Case.
Thank you, Madam Chair. And I've said it, if I haven't said it once, I've said it a bunch of times. I've been here on this committee 13 years and we've been able to flush out a lot of these bills that belong to other committees while we go through the screening process. And I think it was actually said while we were having discussion that this is up to the two money committees. And my concern is if it's up to the two money committees, why doesn't it go to the money committees? It doesn't belong here. We're going to find that with other bills that belong to other committees as we go through today and we go through Tuesday. It's always been to refine bills that are in cognizance of us here on human services. I mean, it even mentions in here that the insurance commissioner is involved with this. We don't have purview over the insurance commissioner. I can push this over to insurance. Granted, yes, it's going to go to the House floor. It's going to go to screening. It'll either go to appropriations or I made a note to send it to insurance. Depends what screening decides to do, if they do anything with it. It's just that we need to have cognizance of the bill and send it to the correct committee at the right time so we don't have to have it go through so many processes. I thoroughly believe this bill here, it was actually stated that this bill is the purview of the two money committees to decide how it's funded. So if we can't decide where the money comes from, I don't know why we're voting on it. But I thank you, Madam Chair, for the time.
Thank you, Representative Case. Representative Vale.
Thank you, Madam Chair. I think Senator Perillo might have touched on it, but will this fund fall under our current fiscal guardrails or what will be outside the fiscal guardrails?
Senator Lesser.
This would be outside the general fund. Whether the extent to which the guardrails would apply, I think is a question for OFA and maybe the state treasurer, and not something that I have the information to opine on.
Thank you.
Representative Vale.
I appreciate that. And again, maybe that's why we should have sent it to finance or appropriations or something like that. Also, I was looking at the public testimony. There's only 4 written testimonies, 1 in support and 3 with concerns. And the concerns come from the DSS commissioner, the OHS commissioner, and ARC of Connecticut. Were any of, before the legislation got this far, if they have concerns about it, and they're the ones that are going to be overseeing this, were conversations had with them before introducing this legislation?
Senator Lesser.
We've been having ongoing conversations with the administration about how to sustain the Medicaid program and covered Connecticut, given the potential threat from Washington, D.C. That's happened throughout session, yes.
So maybe not
Representative.
just in general conversations, or about this specifically?
Senator Lesser.
I would answer that with a firm yes.
Okay. And again, reading the commissioner, both commissioners are concerned that I'll quote, non-lapsing funds for dedicated purposes are problematic and limit flexibility needed. It sounds to me, again, I'm going to go back to a process thing, which I think is extremely important. This is the oven. Committee process is the oven. We put the ingredients in, we're supposed to bake the bread here, right? And that's where we're supposed to do the work. And this legislation, to me, is uncooked. Hasn't been put in the oven yet, and it shouldn't be leaving the committee. We're supposed to present this, and then it goes to the House or Senate, and then it's in front of all the whole body, and people can have discussions and ask questions. But again, to me, there's so many bills on this agenda, on agendas in every committee. Why we don't do things through the process, I don't understand. I don't see how people can vote for what I'm calling uncooked legislation when we don't have the answers. And I don't know, it doesn't seem that complicated to me, but I'll be opposing this. Thank you.
Thank you, Representative. Senator Perillo.
Thank you, Madam Chair. I appreciate it. I can appreciate what the representative is saying. I wouldn't call it uncooked so much as half-baked. No, but the gentleman's got a legitimate concern, right? We're creating a pot of money. We don't know where the money's coming from. We don't know really where it's going. And it's for a problem that may or may not exist. So I don't know. This is just bizarre to me. I don't know how we can in good conscience create a fund that exists outside the general fund, without any idea how it's funded or where the money goes, and only what I would call a spotty sense of what it can be used for. I'm a no vote. I appreciate all the answers, and I'm sure a ton of work went into this, but I'm a hard no. Thank you.
Thank you, Senator. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFSB 1477. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr. Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico. Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes. Representative Johnson. Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott.
No way.
Representative Shake.
Representative Shake votes yes.
Representative Stewart. Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. And as a reminder, we will be keeping the votes open. Next, we will move to item number 6 on the agenda, Senate Bill number 1469, an act concerning medical debt. Is there a motion? Is there a second?
Second, Representative Dathan.
Thank you. Moved by Senator Lesser, seconded by Representative Dathan. This legislation prohibits any surviving spouse from being responsible for medical debt related to the deceased's medical services and hospital expenses. Any questions or conversation? Yes, Senator Perillo.
Thank you, Madam Chair. I appreciate it. So if the debt doesn't need to be paid by the surviving spouse, who would pay the debt?
Senator Lesser.
Thank you. Could be borne by the state. Through you.
Senator Perillo.
Thank you, and I appreciate that. So it could be borne by the state. Who else could it be borne by?
Senator Lesser.
Through you, I just want to clarify. I said the estate, not the state.
Senator Perillo.
Thank you, Madam Chair. So, okay, so then this bill must do something very different than what I thought. So it is not a forgiveness of debt. It would just be transferred over to the estate. So if that's the case, then, Madam Chair, what if there is no estate? Or what if the funds available in the estate are not sufficient to pay the debt?
Senator Lesser.
I think the intent of the bill through you is to ensure that there's not an automatic transfer onto the surviving spouse, but it is, but there, and would therefore be attached to the estate, but it would not create an automatic transfer. Through you.
Senator Perillo.
Thank you, Madam Chair, and I thank the senator for his answer to the question. So let's play this out. So it's not an automatic transfer to the spouse, and it could go over to the estate, and the estate may not have funds available to cover the debt. So then what? So who becomes responsible for that debt?
Senator Lesser.
I think what the gentleman is asking, and it's a good question, is what happens when healthcare providers have uncollected debts, and we do have an uncompensated fair fund. We also provide state and federal funding to healthcare providers to assist with debts which for a variety of reasons cannot be collected on.
Senator Perillo.
Thank you, Madam Chair. And again, I thank the gentleman for his answer. So now the uncompensated care fund, where does that money come from? Through you, Madam Chair.
Senator Lesser.
So there's hospitals and other providers can collect funds to cover the cost of uncompensated care through a variety of areas, including from taxpayers, but also certainly they could pass on costs to their balance of their patients.
Senator Perillo.
So hospitals have the ability to pass on uncompensated care costs to the balance of their patients? Is that accurate? Do I understand that properly? Through you, Madam Chair.
Senator Lesser.
Yes, I mean, perhaps not directly, but certainly indirectly, we are all paying for when we go to the hospital, we all pay in part because the hospitals have to treat under EMTALA and other laws. They have to treat folks regardless of ability to pay. They do their level best to collect on bills, but in some cases, they will not get compensated. And so based on that, it stands to reason that they have to charge a level to cover their costs. For you.
Senator Perillo.
Thank you, Madam Chair, and I appreciate that. But at the end of the day, we know that in the state of Connecticut, what a hospital charges is not what a hospital gets reimbursed. So is the expectation that hospitals will consider the fact that they don't get reimbursed for the care they provide by negotiating for higher rates with payers? Is that accurate through you, Madam Chair?
Senator Lesser.
It's not for me to speculate how a hospital would respond, because certainly they have to look at their overall book of business. We certainly do provide direct support for uncompensated care from the state of Connecticut, but there's also an ability, if that is not sufficient, to look at their overall book of business to see what their costs are, and to assess an appropriate charges for their accounts. They're a business like any other. For you,
Senator Pearl.
Thank you, Madam Chair. And again, I thank the gentleman for, okay. So if the hospital needs to collect money from other sources of revenue, from patients who are paying their bill, essentially, they're going to have to negotiate higher rates from commercial insurers. And if they negotiate higher rates from commercial insurers, that ends up funneling through in the form of higher premiums to employers. Is that how that would work out through you, Madam Chair?
Senator Lesser.
I think the good senator is making a bunch of leaps in that. It is certainly possible that if you do anything to increase costs, that could certainly eventually get passed on. But exactly that direct connection, I think, is a little speculative. Through you,
Senator Pearl.
Thank you, Madam Chair, but I disagree. Anytime that an insurer pays more money for any service or covers additional services or reimburses at a higher rate, the money's got to come from somewhere. And the way the insurance business works is that those costs are paid by the premiums charged to those who contract with the insurer to provide the coverage. And in most cases, that ends up becoming employers, at least here in the United States of America. So then I don't see how we can say, I don't see how we can even call it speculation. You know, if you drive up the cost of providing care, it impacts what insurers have to pay, which then impacts what employers have to pay as premiums. So I don't think there's a lot of speculation there. I think it's a logical conclusion to make. But the senator also mentioned another way that hospitals and providers could be reimbursed for the cost of this debt that goes unpaid. And the gentleman mentioned the uncompensated care that the state of Connecticut provides, specifically to hospitals. Could the gentleman explain how that works? 3 minutes.
Senator Lesser.
I believe we have an uncompensated care program through the state budget. Is OLR or OFA able to provide additional answer to that? No, they're not. What's that? Oh, you can. Okay, through you, maybe the good senator could give us an update on where that is, because I know we have dish payments, and I think the dish payment methodology is our main mechanism of doing that. But that I just want to make sure that that's up to date.
Back to Senator Pearl.
Thank you, Madam Chair, and I thank the gentleman for his reference to the disproportionate share or dish payments. So uncompensated care at the end of the day is figured out through a formula based upon reports submitted by hospitals, and payment for that uncompensated care from the uncompensated care fund basically comes out of Medicaid. Medicaid, of course, as we know, is partially reimbursed by the federal government, but also partially and largely reimbursed by the state of covered by the state of Connecticut. Now, of course, let's follow that through. Taxpayers fund the state's Medicaid portion, and so essentially, we have two options for how these debts could be paid. 3, if you throw in the estates. So we understand it. So number 2, of course, as I said, and the gentleman mentioned, is that hospitals could find some other way to pay for it, which I would postulate is payment in the form of shifting cost over to commercial payers, driving up costs, driving up premiums. The third way, which we just discussed, is through the uncompensated care pool, which is paid by Medicaid, which is paid by taxpayers. So we're basically left in a scenario whereby either employees are going to have to pay higher premiums, or taxpayers are going to have to pay higher taxes. So, I mean, is there another, is there an option I'm not seeing through you, Madam Chair?
Senator Lesser.
Well, there may be others. So for example, we get hospital financial reports every year. Right now, the hospitals they might dispute this, but they look relatively healthy. They could pick up the tab themselves. For you.
Senator Perillo.
I'm sure they'll love that. Thank you, Madam Chair. And I appreciate the gentleman's answer to the questions. This is not a simple topic. It's actually pretty complex, and it touches on a lot of different things, I think, as the gentleman and I illustrated. But I'm eager to hear more discussion. Thank you.
Thank you. Representative Vale, followed by Representative Case.
Thank you. Just again, following up, it's, again, we can understand the reason why we'd wanted to have this discussion for people that might have this bill put in their lap after, losing a loved one. But it's, again, putting the onus back on the taxpayer. If it's state funds that are going to be, or the ratepayer, if we're going to push insurance premiums up, which sounds an awful lot like our electric bills, dumping things on our electric bills that ratepayers have to pay because we have wonderful ideas up here in Hartford. It's the same concept. And when will we stop? If there's not a way to fund it, which there doesn't, again, like Senator Perillo said, insurance premiums are going to go up, taxes are going to go up, or the hospitals can just eat it. And again, I don't think my hospital can handle it. As I talked about earlier, they said they don't have enough money for their birthing center anymore. So this is a constant flow of us having these big grandiose ideas and how to solve everybody's problems as long as somebody else pays for it. And that just doesn't work. So I obviously am not going to be able to support this. Thank you.
Thank you, Representative. Representative Case.
Thank you, Madam Chair. And I think I have a few questions through you to the good senator on the bill, on this bill here. And listen to some of the comments. I guess once again, I'll bring it back to it. I've never seen a bill like this flushed to this committee that doesn't belong here as much as this one. So through you, does this affects anybody in the state of Connecticut, whether you're on Medicare, Medicaid, or you're private insured? Is that correct through you?
Senator Lesser.
Through you, yes.
Representative Case.
Thank you. So when somebody goes into a doctor's office, or they go into a hospital, they go into a nursing home, or they go into a group home, you sign off as the fiduciary for the person going in, even though the person going in has a fiduciary, but they always ask for the second person who's in charge of the monies. So would that negate this? Would that no longer be on that intake application on who would be the secondary fiduciary should the person pass through you?
Senator Lesser.
Through you, I think this is about automatic transfer. I wouldn't say that it would not in any case be transferred, but if you present at a hospital, you can get medical care in Connecticut without naming your spouse.
Representative Case.
So once again, I mean, we're human services. We have Medicare, Medicaid. We work with DSS, DDS. We work with the committees that take care of the most vulnerable people in this state. This bill belongs in judiciary. This bill belongs in judiciary or insurance. We don't have control on how people's bad debt is paid. We don't have that say. I mean, if we were just talking on Medicare, Medicaid patients, maybe okay. But if you take an instance where my father passed away in 1996, we had to pay all those bills for him. But if this bill was in place, would my mother not be responsible for the bills that he passed, and she just gets to keep all of her assets? It doesn't make sense. And why in human services, when we deal with things with DSS, Medicare, Medicaid, are we here making decisions, which I know we can't, it's going to have to get to judiciary anyways, because we can't decide who the fiduciary person is when they get signed into a hospital, when they get signed, my God, I go to a physical in the doctor's office and they make you sign off. If you can't pay the bill, who's going to be the one to pay the bill? So you always sign a second person on there. does not make sense. I'm not, and I know the good senator wants to bring some things forward and we want to make some changes, but there's committees for that. This is everybody in the state of Connecticut. If somebody passes, their spouse is no longer liable. But as we heard the other day in a hearing, I mean, we heard a lot about long-term care insurance. People plan. People know when there's debts that might be coming down the road. If the estate has the ability to pay and those plans weren't set forward ahead of time, the estate should pay, not the state of Connecticut. And the taxpayers, I just don't get it. And bottom line is, there's no question here. This belongs in judiciary. I'm not going to do a refer to judiciary, but that's where it's going to end up. We do not have a say on who pays their medical bills and who does not pay their medical bills. That's to judiciary. That's to public health, who has purview over the hospitals. That's not for us. Thank you, Madam Chair.
Thank you, Representative. Representative Pizzuto, followed by Representative Master Francesco.
Thank you, Madam Chair. Just quickly on line 30, it says abandonment without cause by a spouse shall be a defense to any liability. So if a man or woman, husband or wife decides that, hey, this bill's racking up, I'm leaving, is there a time limit on this? Is that to Representative Case's clause? He goes back years, you're liable. But this just removes the liability when the bill comes and then you get back together. Now, I don't know how you determine abandonment, but that's a pretty open clause. Just asking your comment on that. Thank you.
Senator Lesser?
Yes, thank you. It's a defense. So it's not a absolute defense, but it is a defense.
Representative Pizzuto.
Yeah, thank you, Madam Chair. And I just, I know I've heard of elderly people, unfortunately, that would lose Social Security if they got divorced. If they didn't, so they get divorced and keep both of them. I can see something similar like that happening here in order to keep your home or cars or whatever, to suddenly say 50 years of marriage, but I have to leave you. I can't imagine the legalities of that from a hospital perspective or healthcare or dentist or anyone else trying to pursue that when they just say, well, they abandoned you, so you don't know anything. Where does that payment then come from? Just a comment. Thank you, Madam Chair.
Thank you, Representative. Representative Master Francesco.
Thank you, Madam Chair. Yeah, I'm listening to the conversation about this bill today. And the first thing that actually came to my mind is, where did this bill stem from? Would anybody be able to give me an answer to that? Thank you.
Senator Lesser.
Yes, I think this was a recommendation through you to the gentlelady. I believe this was a recommendation given to states by the Federal Consumer Financial Protection Bureau.
Representative Master Francesco.
Thank you. I'm sorry. By who? I'm sorry.
Senator
I
Lesser.
couldn't hear you.
The United States Consumer Financial Protection Bureau, through you.
Representative Master Francesco.
Thank you. Did they contact our committee and ask them to raise this bill? Is that what I'm understanding through you?
Senator Lesser.
Through you, yes.
Representative Master Francesco.
Thank you. So listening to the conversation here, it appears to me that everybody in the state of Connecticut qualifies, should this pass, for this medical debt relief. Is that correct to you?
Senator Lesser.
No, through you.
Representative Master Francesco.
Thank you. Who qualifies?
Senator Lesser.
Surviving spouses, through you.
Representative Master Francesco.
Thank you. I guess I should have been more clear and said everybody living, obviously. I mean, duh, obviously. If you're living. Oh, God. Okay, now then you got me off track there. That was pretty funny. Where was I? Okay, so is there for the living an income qualifier attached to this language through you?
Senator Lesser.
No.
Representative Master Francesco.
Okay, so my point is every person living in the state of Connecticut that is left behind with some debt from their spouse for whatever reason it is qualifies for this. So they could be rich people. That doesn't matter what their income is, right? They could have a lot of money and able to pay off their debt, but yet what we're asking, so I'm curious, who's paying for this for you?
Senator Lesser.
Through you, I would want to say, one, this does not indemnify the estate of the deceased. So they are still responsible for the debt. This is not a debt absolution or forgiveness. But what it is saying is that there is not an automatic transfer of the debt to the surviving spouse. And that is not an automatic decision that happens in the law if this bill were to pass. Through you.
Representative Master Francesco.
Thank you. The wording I'm looking at says that the spouse is not responsible for the medical debt related to reasonable and necessary service as a physician or dentist. So if they're not responsible for it, I guess my question, who is? Through you.
Senator Lesser.
The estate of the deceased. Through you.
Representative Master Francesco.
Okay, so it would only be the estate. So it's not the person, the spouse, the wife, the husband, or so forth. If the spouse was the sole heir, they are the estate. Would they be responsible through this, through you?
Senator Lesser.
The spouse, I am not an attorney. I'm not certainly not an elder law attorney. We might have to phone a friend and now Judge Kelly to help us out here. But I don't believe the spouse would be the estate. I think the estate is the estate. Through you.
Representative Master Francesco.
Thank you. If the estate only has one person overseeing the estate, the executor, I guess, is it the executor of the estate? If it's the spouse, who would be responsible? Through you.
We have someone else who would like to answer.
Thank you.
Representative Johnson.
Thank you. And these are all excellent questions. But what would happen is once the estate is gone to, it goes to the probate court. The probate court then the purpose of the probate court in general is to make sure the debts are paid, make sure the taxes are paid. That's what the purpose of the court is. So if there is a debt that is, and the spouse is exempt, however, when the debt, if there is an estate there, all the estate goes to the probate court, then the judge decides what should happen at that point in time based on the law. But nevertheless, if there is the other thing that I think we haven't really fully looked at is the fact that when somebody goes into a nursing home, then they're paying as they're there, they pay and they pay. And then at some point in time, they may spend down. Once you get to spend down, at that point, then you have your spouses and your assets and they get divided. They get divided in accordance with the Medicaid law. So that happens at that point in time. So then the assets are divided, the spend down continues and the Medicaid program takes over. So when this thing happens that we're speaking of right now, it must be where the nursing facility and the procedures got caught up somewhere in the process, because the nursing facility does not want to let that kind of occurrence continue. So there is a process in place to make sure that people have made the transfer from the spend down to the Medicaid program, and then if in fact there's debt that's left because the process occurs and the person dies, then those things must go from there to the probate court for the judge to make a determination. I know that's not everything you're asking, but it's kind of like what the process is. So I hope that helps a little bit.
Thank you. I know you're trying to, and I appreciate that answer. So when someone passes, they have medical debt. The spouse, if it goes to probate, if I'm understanding, of course, I don't know if anybody in this room is a probate lawyer. When it goes to probate, the hospital, if they owed money to the physician or perhaps a dentist, that money that is owed would be part of their estate. Is that correct?
Representative Johnson.
Yes, Madam Chair. Yes, through you. Yes, that all the debt would be, that's the whole purpose of probate, to pay the taxes, to pay the debt. So they would do that. Now, again, the spouses, if they went through the procedure they should go through, should have split their assets. And then the spouse is left, that they don't have to worry about that because they already split the assets. Nevertheless, if there's, other debt, then the probate court would have to take a look at that, and that's outside the scope of anything I can answer, in terms of what the judge would decide and what the what the divisions were, what was left for the spouse. Because one of the things you don't want to do with senior citizens is take away whatever they have left to live on, so that they don't end up on total Medicaid and total support too for the state. So it could be, for example, the state could lien, say they have a house. The state could lien the house until the spouse passes, and then collect the debt at that point in time when the house is sold.
Thank you. Representative Master Francesco.
I think I'm just gonna get you like a voice recording that says Representative Master Francesco. You just hit the button.
I think it's impressive I can say it over and over.
Oh my, oh, yeah, yeah. Thank you. So it seems to me that this is supposed to be a way around that. I mean, that's just the way it appears for me. At the end of the day, they owe the money, right? And they could be very wealthy people that owe the money that they're certainly qualified to pay. And it seems like the hospital and the physicians are the ones that are really getting, not being paid whatever is owed to them. I mean, we see this all the time. You pass on your family member, your spouse, it goes into the estate. And if this, the estate, the executor of the estate, if they owe money, and if there's a lien, could be a lien along your house, that obviously needs to be paid. I guess I don't understand why we are doing this. I mean, there's a lot of people out there that obviously have a GoFundMe page. If somebody's sick, to pay for medical, pay for medical debt. Would that affect that in any way? Through you? Mr.
Through you,
Chairman,
Madam
or
Chair.
Representative
Representative
Johnson?
Johnson.
Sure. There, certainly, the GoFundMe page would help pay the debt, but that's not part of this, the joint assets that people work their whole lives, and they accumulate their houses or one house. You know, their insurance is separate. That's a contract. So that doesn't go to probate. So if there's types of insurance, one of the things we've debated here is the nursing home insurance, you know, long-term care insurance bill that we have here, to make sure that people can continue to afford that, the long-term care insurance. What kind of recommendations are going into that? So there's another avenue. I don't know what the CPFB, why they would have contacted us on that. The CPFB might have found that there was some fraud going on between the nursing facilities. Maybe there's some difficulty with nursing facilities that are owned by national private equity firms, for example, that have gone after people unreasonably. So it sounds to me like it's a CPFB where somebody's been that has already split the assets, has already been with the state of Connecticut. Everything has been transferred. And whatever's left for that person, they're not usually really very wealthy when they have these circumstances, when they split the assets like that, because they have to spend down. And very wealthy people that have a lot of resources split the assets pretty much 50-50. So if they're multimillionaires, they're probably going to be able to pay off the debt. So it sounds to me like there is a problem with the CPFB discovered that maybe private equity got involved and told nursing facility staff to do something. I'm speculating now. So
Yeah.
you asked a question and I'm going to tell you what I speculate, but it sounds to me like if it's a CPFB problem, there's been some odd thing. And I know the other thing that I do know is that after having done numerous cases with nursing homes, that that sometimes they get the information not quite right. And so, and that would be another situation where we, have to take a peek. But I think those are very good questions. But I think that is pretty much the standard procedure where people, if they have a lot of money, they're going to be paying. If they don't have a lot of money, they're splitting the assets between the spouses, so the spouse can stay in the community and not have to go on 100% state aid. And that's probably all I know. So
Thanks, Rep. Johnson. Representative Master Francesco.
Thank you, Madam Chair. So I appreciate your answer. Doesn't really answer my question, but you got a lot of knowledge out in that, and I really do appreciate it. I'm just trying to figure out if the spouse is the only person in the estate. At the end of the day, they're not responsible to pay for it, whether it's going to go to probate or not. It's not coming out of their estate of whatever assets or money that they have left, because they are the only surviving spouse. So somebody will not be getting their money because that person is not responsible for it. And I guess that's what I was trying to get to the bottom of. I still can understand why we have this bill before us. As Representative Chase made, obviously this needs to go to either to judiciary committee. Again, we're tinkering with another policy that's not in our purview here in the Human Services Committee. Although I see a lot of that going around this year because maybe it has a little aspect of it that may relate to human services, that we kind of feel that the whole policy should be brought into this committee. So I thank you for your answers. I thank you for the conversation, Rep. Johnson, and Madam Chair, I won't be voting for this today. Thank you.
Thank you, Representative Vale.
Sorry, I stepped out for a beverage. I got a feeling we might be here for a minute. It wasn't an adult beverage. That came off wrong. All right. Arizona. All right. So I was under the assumption that this applies to medical expenses and hospital expenses. And then I heard us talking about long-term care as well. Would this also apply to monies owed to a nursing home?
Senator Lesser.
Through you to the honorable gentleman, the language covers reasonable and necessary expenses of a physician or dentist or hospital expenses. Through you.
Representative Vale.
Okay, so it's not mentioned in there. So the assumption would be no, but we never know how people interpret things. So, all right, thank you.
Thank you. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JF SB 1469. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico. Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes. Representative Johnson.
Oops. Sorry. Rep. Hughes
Representative
votes
Johnson votes yes.
yes.
Double
You're
yes.
recorded, Representative Hughes. Thank you.
Thank you.
All right. Representative Kit. Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott's a no.
Representative Shake.
Yes.
Representative Stewart. Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. We will hold the votes open. Next, moving on to number 7 on our agenda, House Bill number 5580, an act concerning Medicaid coverage for diabetes prevention, education, self-management, and medical nutrition therapy programs, and establishing an advisory council. Is there a motion?
So moved.
Is there a
So
second?
moved. Second, Representative Dathan.
Moved by Representative Fortier, seconded by Senator Marr. Any questions or discussion? All right, seeing none. Oh, okay. Representative Master Francesco.
Thank you, Madam Chair. I didn't know if my ranking member was going to ask a question, so that's why I was holding off. So can you kind of just give me an overview exactly what this bill is doing? If I'm not mistaken, it's to cover educational material for diabetes prevention. Can you give me an idea overall of how that is to be done?
Yes, it's my understanding based on what we heard in the public hearing that currently Medicaid in the state of Connecticut does cover diabetes services and education, but we don't have any real preventative programming. And so what this is going to do is it would require the commissioner of DSS to provide Medicaid coverage that's aligned with federal law for diabetes treatment, medical nutrition therapy, and education. It's also establishing a diabetes advisory council that would make recommendations concerning diabetes education, prevention, and treatment. And we heard at the public hearing that 1 in 3 individuals are pre-diabetic.
Thank you for that answer. And the advisory council, how many members are on that council?
All my good colleagues on the other side of the aisle are asking a lot of quick counting up questions today. So if we go to the bill and look at line 16, let's see, 2, 4, 5, 6, 7, 8, 9, 10, 11. It looks around 11 to 12 people. 12 people.
Okay. So we have to, and on this council are they paid to be on this council?
So good question. Anyone who is through their employer is participating on this council, one could argue are being paid. But the legislation itself will not establish any type of payment for folks to serve on this council.
Okay. So, usually when people have diabetes, they go to the doctors says you have type 2 diabetes and so forth, whatever it is, they actually educate the patient on these are the things that you need to do to help yourself, to prevent yourself from making your condition worse. So they already get the proper education from the doctor's office. Now, what they do when they get home is another story. You can't legislate behavior for people. So why I think the goal of this is the intention as well, that we want to educate people. We can do it all they want. I think the best person to educate somebody with diabetes or pre-diabetes is their physician. And I believe that they are doing that. So I think really this is an unnecessary expense at this point. So I'll be voting no today, but thank you, Madam Chair.
Thank you, Representative. Yes, Representative Scott.
Thank you, Madam Chair. I have a little personal tie to the word in the title, and I'm a type 1 diabetic. Not many people know that. And it bothers me as a type 1 diabetic. A lot of times when we talk about diabetes, people talk about diabetes in general. They're totally different things. Type 1 and type 2 are totally different. Type 1, my pancreas does not work anymore. My pancreas does not produce insulin. I have to have insulin. I give myself insulin shots all day to make sure my blood sugar levels are in check. Type 2 diabetics are people who are usually tend to be overweight, not in good shape, don't eat well, don't exercise well, and then ultimately build themselves up to be a type 2 diabetic, and ultimately can also come out of being a type 2 diabetic. There's a choice. They have ability. There are genetic things that hurt them and maybe slow them down and maybe stop them from having a better chance than the average person of being a type 2 diabetic. But 90% of the people who have diabetes are type 2. Type 1, like myself, are very limited. There's not as many of us. So we tend to be missed in this world of diabetes when we talk about diabetes. So when people talk about diabetes, they're not talking about me. And it bothers me, to be honest. It should be more of a clarity in there. So it's something I'm always going to call out as a legislator, since I have a voice, to making sure that we're talking specifically about type 2 diabetes in this scenario. And that's either here, no here of if I'm going to support the bill or not. I just want to make sure it's a clarity, because there's those type 1 diabetics are out there that don't have any say and don't have really control their body, unfortunately, that I just want to make sure they're being represented as much as possible. When language like this is not for type 1 diabetics, these are for type 2 diabetics. I just want to make that very clear. Thank you.
Thank you, Representative. Any other question? Yep, Representative Pizzuto.
Thank you, Madam Chair. Just a comment that when they form this advisory council, it would behoove them to not include someone from, say, the Yukon Health Center, someone who has expertise in stem cell and genetics, because I think that's the next magic bullet, the next penicillin for diabetes. And I'm afraid that if they're not familiar with that, they may not go that route. So just an inclusion. Thank you.
Thank you for the recommendation. Senator Perillo.
We'll keep doing that. Thank you, Madam Chair. I appreciate it. I'm just trying to understand exactly what Medicaid would be covering if this bill were to pass. So it references providing Medicaid coverage for diabetes prevention, education, self-management, and medical nutrition therapy. So I guess my first question, because I truly don't know the answer, what diabetes prevention programs are out there that somebody can actually pay for and that Medicaid would actually reimburse? The biggest thing I find is the diabetes prevention program sort of within CDC, and I don't see any indication of whether or not you would pay for that. I mean, it simply states on calorie reduction and increasing physical activity. Well, no kidding. Representative Mastro Francesco mentioned that. You go to the doctor says, hey, watch what you eat and do some exercise. That's diabetes prevention. I'm just wondering, are there programs that that offer more information? Are there programs that offer additional services? I just want to understand exactly what we as the state of Connecticut would be paying for through Medicaid.
Yes, great question. And I think I just found there. So we heard at the public hearing from a number of providers who currently work at a diabetes prevention program here in the state. And so this is, we don't like, well, some people are not liking the equity piece, but this really is allowing folks who get their healthcare through Medicaid to be able to access that program and others across the state. But since your question was, we did hear from many people who spoke to the benefits of that program and that there's lots of states where Medicaid already covers this.
Well, thank you, Madam Chair, and I appreciate it. Look, we even in our own health insurance plans, they're actually in some cases, I mean, we are penalized if we don't go through with certain preventive measures. So prevention proves itself, generally speaking, to be effective over the long term. But again, as I look at the bill, it references paying for diabetes prevention, diabetes education. What exactly does that entail? To you.
And this in some ways speaks to what Representative Scott was addressing in that it's specific to type 2 diabetes. And again, 1 in 3 people are pre-diabetic. And so the program works with folks who have been identified as pre-diabetic to talk them through things they can change with their lifestyle, as one example, to avoid becoming diabetic.
So thank you. So, but again, and the representative from Wolcott mentioned, that's generally happening when you go to see your primary care physician. I mean, every time I go, we talk about how to live a healthy lifestyle. Get exercise, watch what you eat. And that is part and parcel of the education that this bill references. I'm not sure, I'm just wondering, is there some sort of education out there beyond going to your doctor that, by the way, is already reimbursed by Medicaid? Is there something else? In these bills, I always kind of worry. Like, is there somebody offering a service that wants to get paid for it that we currently don't pay for? Like you always sort of, the devil's in the details and follow the money. So I'm just wondering, is somebody in the business of providing healthcare services benefiting financially from this that we aren't necessarily talking about here today? That sort of becomes my question. Again, to be very transparent, I don't have the benefit of having been here for the public hearing, but I'm always skeptical when I see bills like this that mandate coverage, because very, very often some specific provider is benefiting financially from the bill that's before us. And I'm very, very concerned about that. And I'm wondering if there was any sort of inkling that there were specific providers for whom the education they offer is not currently covered.
Yes, so we heard from the Connecticut Hospital Association that what are referred to as diabetes self-management education and support and medical nutrition therapy programs, DSMES, provide the education on managing diabetes, medication, healthy eating, and physical activity. They offer a more intensive personalized approach with a dietary advice from a registered dietitian who help the patients. So we heard that having this program for certain folks, again, not everyone would need access because some people, yeah, when they have that conversation one-on-one, then they're good to go. But this is for folks who need that more intensive approach.
Thank you. I appreciate that. And you know, and you actually just mentioned, and it's interesting. So you mentioned self-management. How would Medicaid reimburse for someone to manage their food intake and exercise and make healthy lifestyle choices? I mean, does that mean that Medicaid would pay for the cost of someone's gym membership?
No, so this bill would only cover those the services, and I believe in the hearing we heard that folks, I think they explained it's like a year-long program, you meet monthly. And so the Medicaid coverage would cover that service. The self-management happens in all the days, not the person's not coming to that appointment.
So self-management doesn't necessarily stand alone. It's a component of a large, understood. Got it. Okay. And I just want to clarify also, when we talk about medical nutrition therapy, are we talking about the cost of food?
No.
Thank you. I appreciate that. Like I said, sometimes the wording in these bills isn't, unless you're educated on what it means, you don't know what it means. So I appreciate your answers to those questions.
Thank you, Senator. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFHB 5580. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey. Senator Marr. Senator Anwar. Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico. Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes.
Yes.
Representative Johnson.
Yes. Representative Johnson votes yes.
Representative Kit.
Representative Kit votes yes.
Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott votes no.
Representative Shake.
Yes.
Representative Stewart. Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. Moving on to number 8 on the agenda, Senate Bill number 981, an act expanding Medicaid eligibility for older persons and persons with disabilities. I'd entertain a motion to JF this bill to the floor.
So moved.
Motion by Representative Hughes. Is there a second? Second by Representative Kett. Is there discussion? Senator Pearl.
Thank you, Senator. I appreciate it. Just sort of for clarity, I'm seeing that this is very specific to disabled adult children under the Social Security Act. Why is it simply restricted to those individuals and not just Social Security beneficiaries across the board?
Great question, Senator. This is the so-called pickle bill, pickle language. It has nothing to do with preserved vegetables, but is about a federal option that almost all states have exercised to provide expanded supports for adult children with disabilities. Connecticut has not taken that, and so what we're considering is we're trying to get some information by JFing this bill today about how much it would cost. We'll get a full fiscal note, and then we'll be able to confer with our colleagues over in the Appropriations Committee to find if there's a way to do this, given the constraints of the state budget.
Thank you, sir. I appreciate that. That's it for now. I appreciate it. Maybe there are some other questions from folks who are more educated than I. Thank you, sir.
Seeing no discussion, the clerk will please call the roll.
A motion has been made and seconded to JFSB 981. Representative Gilchrist. Senator Lesser.
Senator Lesser, aye.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr. Senator Anwar. Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico. Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes.
Yes.
Representative Johnson. Representative Kitt.
Representative Kitt votes yes.
Representative Master Francesco. Representative Meskers. Representative Pizzuto.
Yes.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott is a yes.
Representative Shake.
Yes.
Representative Stewart. Representative Vale.
Yes.
The roll call is complete.
Thank you, Madam Clerk. Moving on to number 9 of the agenda, House Bill number 7103, an act concerning the Katie Beckett Working Group recommendations. Entertain a motion to JF to the floor.
So moved.
Motion by Representative Hughes. Is there a second? Seconded by
Second, Representative.
Yeah. Is there a discussion? Yes, Representative Case.
Thank you, Mr. Chair. So looking at section 1, to clarify the eligibility up to 18. Once they are 18, they can access Husky C. Is that correct?
Through you, yes.
So we're moving this from 21 to 18. What is the reasoning for that?
Well, I think you just answered the question. It's because they have access to the Medicaid program. The concern is for children. They are not eligible. Children access Katie Beckett when they are not otherwise eligible for the Medicaid program. And so once you've reached 18, you can access the Medicaid program. And so it's no longer needed, thus freeing up resources for the really sick, terminally sick, in many cases, kids who benefit from the program.
And thank you, Mr. Chair. So we've talked about this for many years, and we've been trying to fund the Katie Beckett waiver. Do we know how many people are on the waiting list, and moving it from 21 to 18, how many does it take off the waiting list through you?
I think I don't have the numbers right in front of me, but I believe it's about 330 are on the wait list. And I'm sorry, I missed your second question.
No, that was the question. And how many are on the waiting list? 330 is what you're saying? Because I remember a couple of years ago, we were just cresting 200. So more is growing. Okay. So how is going from the second part of the question? Thank you, Senator. I did have the second question. Going to 21 to 18, does that lower the waiting list?
It should, because it should free up resources for us to take kids off the waiting list and provide the services. So it should help us reduce the wait list. Not through you, just answering your question through myself.
I mean, I wholeheartedly agree with the Katie Beckett program. It's just for years we've been looking at this and trying to figure out why we keep growing a waiting list and why we don't take care of the waiting list as expeditiously as we should. Somebody who needs services, who is in that situation, should be moving forward much farther than they have been, and not having the waiting list grow like it is. That's my concern with it. I guess I'll wait to hear other questions. I was just, the waiting lists in this state stink, and we try to work on it year after year, and they just keep growing, and that's a sad state of affairs. But maybe moving this age is going to change some things. But I'll let some other people ask some questions, and I'll come back. Thank you, Mr. Chair.
Thank you, Representative. Representative Master Francesco, then Representative Vale, and then we're going to get to the good chair of the committee, Representative Gilchrist, who I know wants to speak on it.
Thank you, Mr. Chairman. So the Katie Beckett waiver program, it provides Medicaid services, correct, to people that are 21 and individuals that are 21 years that have a physical disability. Is that correct?
I don't think that's the criteria. It's for very sick kids. And so this is for folks who would otherwise would not be eligible for Medicaid program. But it's for some of the sickest kids in the state who desperately need healthcare through you or to you.
Thank you. So they wouldn't, the people that are on the Katie Beckett waiver program, they would not normally qualify for financial assistance for Medicaid due to their family income. Correct.
Correct.
Okay. Then you mentioned that, and I think Representative Case wanted to make sure that people that are already on the waiting list up to 21, they'll no longer be on that waiting list, right? Because the age will be at 18 years old. So what happens in between to the people that are on the waiting list now that, and you mentioned that, well, they can get on Husky C, but maybe their income limit does not allow them to do that, to get these services because of their income limit. And that's why the Katie Beckett waiver program is important to them. I'm concerned, and I want to make sure that these people are taken care of through you, Mr. Chairman.
I hear that. I think we don't think that there are not a lot of the kids on the wait list are profoundly ill and are not generally making a lot of money. If they're employed at all, I would be surprised if any were. The issue is once you turn 18, you're no longer going to be ineligible because of your parents' income. And that's the issue that we're trying to fix here.
So can you repeat that again? Did you say that you are not eligible because of your parents' income?
No, ma'am. I'm saying you're no longer ineligible because of your. So right now, if a child is born with a profound or terminal illness, who would normally qualify for the Katie Beckett waiver, they might be ineligible for Medicaid because their parents' income is too high. But once you turn 18, you're no longer restricted in accessing Medicaid because of your parents' income. So that's why we don't need to cover the folks who are between 18 and 21.
Okay, thank you. Yeah, I'm just a little concerned. I'm curious as to why, when we do programs like this, if you want to change it to 18, there's people clearly on that waiting list up to maybe they're 20 years old or 19 years old. Why can't they be grandfathered in? Why not say, okay, going forward, this is the new policy and people that are there should be grandfathered in? Was that discussion, has that discussion taken place? To you, Mr. Chairman?
Well, we think we can get those folks who are between 18 and 21 Medicaid today. They shouldn't have to wait on a wait list.
Okay, thank you for your answers. I don't have any further questions.
Representative.
Thank you. You answered some of my questions through her questions, but again, I want to dig in a little now. So if they're eligible now, why aren't they currently doing that? The ones that are 18, if we're peeling this back and taking those people off the list, why weren't we already doing that? And why do we have to make this adjustment?
That's a great question, Representative Vale. I don't know the answer. But Representative Gilchrist represents that she does know. Representative Gilchrist, can you answer that?
Yes, thank you. And I don't know if it was said, because I'm sorry, I stepped out of the room, that there was a working group that discussed this. And so interestingly, some of these folks might already be covered by, so they might have already gone on to Medicaid. What's happening is the list just kind of sits there until it's someone's turn. And so by the time it's their turn, they might already be 23 and have been using Medicaid since age 18. And so what this will ideally do is kind of both clean up the list and potentially reduce the list for folks who are already getting services covered by Medicaid. This came actually from the very families who have children on the list. And so in no way is this going to take away. It's just kind of an oversight that we've had in the state.
Okay, well explained. Also, like, my kids can stay on my insurance till they're 26. So are we encouraging people who may have parents that have good insurance once they turn 18 to come off of their parents' insurance to be eligible for this? Because that would concern me a little bit. You know what I'm saying? Because they could have good insurance. And are we almost enticing them to come off so that they could be on Medicaid and then receive these services and circumvent the list?
Yeah, we're definitely not doing that. Many of the kids who are on the Katie Beckett waiver do have a primary private insurance program, and we're not discouraging anybody from getting that. In fact, we're looking to make sure that that insurance gets billed. But there are additional services that typically, first of all, if you're a parent of a kid with profound healthcare needs, there's just a lot of healthcare expenses, and so private insurance, even the cost sharing might be exhaust the family's resources. We also learned through the working group that there's some important programs that the Katie Beckett waiver program funds, including case management, that are not typically funded by private insurance. So this is an additional support, not instead of private insurance. But this would be an additional support, and these are 100% of these are heartbreaking cases where we're trying to figure out what can we do to keep a family from, in addition to wrestling with a profound and healthcare diagnosis, what can we also do to keep them from facing financial ruin?
Thank you. Again, I'm new to this committee this year, so I'm not as familiar with this. The Katie Beckett working group, and or the waiver program, are we making it, like, I looked at the language, and are there any other changes being made besides the age change?
Yes, we have a number of other sections of the bill. And so we're providing a brochure with information and eligibility criteria for the program. We're creating a portal. We're directing the Commissioner on Social Services to develop a 5-year plan to eliminate the waitlist. We got a fiscal note that suggested that we could eliminate the waitlist, meaning we provide these services to these profoundly disabled kids without any waitlist for $8 million or $8.5 million, which is a lot of money to me, but is a very small amount of money in the context of the state budget. And so other states don't have a waitlist, we found out. Connecticut is unusual in having one. And so we'd love to figure out a way to ensure that, the idea that we would be telling a kid who may only have a 3-year life expectancy that they're going to have to wait 5 years before getting the essential healthcare services seems unnecessary, and something we could probably do something to address.
Okay, thank you.
Representative Gilchrist. Any other comments or questions? Seeing none, the clerk will please call the roll.
A motion has been made and seconded to JFHB 7103. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar. Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico. Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes. Senator
Representative-
Anwar, I missed. Senator Anwar votes yes.
Received, Senator Anwar. Representative Hughes.
Representative Hughes votes yes.
Representative Johnson. Representative Kit.
Representative Kit votes yes.
Representative Master Francesco.
Yes.
Representative Meskers. Representative Pizzuto.
Yes.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott's a yes.
Representative Shake,
Yes.
Representative Stewart, Representative Vale.
Yes.
The roll call is complete.
Representative Johnson votes yes.
Recorded. Thank you.
Just under the wire, Representative. Next up, no, we're keeping all the votes open, so you're good. Next up, number 10, Senate Bill number 1416, an act expanding long-term care options for Medicaid beneficiaries. Entertain a motion, Jay, up to the floor.
So moved.
Motion by Representative Gilchrist, seconded by Representative Kitt. Is there discussion? Representative Case?
Thank you, Mr. Chair. So expanding long-term options for Medicare beneficiaries. What it was talked about a little bit in the hearing. People with IDD not included in this piece of legislation for you?
This is the strategic plan for Medicaid long-term supports and services. It covers the Connecticut home care program for the elderly. And so it's specific to that program. To you.
So the answer is no, even if they're not receiving the full gamut of services through DDS, but they are part of the program. Okay, I'll move on. What are we actually expanding as far as benefits through you?
The bill doesn't expand benefits, but it shall direct the commissioner to rebalance the strategic plan for long-term services and support, just to increase opportunities for Medicaid beneficiaries in a home or community-based setting. It doesn't specifically spell out what that is, but it directs the commissioner to come up with a plan to do so.
So through you, it's just coming up with a plan. It's not expending any dollars.
That's my read.
Okay, I'll let others ask questions and I'll come back. Thank you.
Representative.
Yeah, I just noticed that OPM opposes this, so I was trying to dig into their testimony. Do you know what their opposition is?
They say they are already doing this. And they also don't think they can come up with a plan by December 1st, 2025.
Is there any reason to believe that they're not doing this now? And that this bill is necessary? What prompted this? If they say they're doing it and we're telling them they're not, where's the?
We have been, over the course of many, many years, working to rebalance long-term services and supports to get people out of nursing homes and other institutional settings and into home-based and community-based care. And that's something we've been working with for seniors. And as Representative Case pointed out, we're also covering other populations as well. And we think that will save money and provide better care. And what this bill seeks to do is tell OPM to move faster, to do it faster and get it to support more folks in the community. And they say they don't need to, and we're saying we disagree.
Okay. Again, I'm reading the DSS commissioner's testimony as well. Kind of get the same feeling that they feel like this is already being done. And so, I mean, that gives me concerns. I'm not. Yeah, it's a big deal, home health care, but I also don't want to be using our resources on things if we can be focusing them elsewhere. And if the people that lead these departments say that they're doing it and that their time and energy could be used elsewhere dealing with some other issues we have, that concerns me, but I'll listen. I don't know where I stand on this yet.
Thank you, Representative. Representative Mastro Francesco.
Thank you, Mr. Chairman. So if I'm understanding this correctly, what the goal of social services, DSS, is that we want to get people more to into home care programs to kind of age in place at home. Is that the ultimate goal here? To
Yes.
move away from the nursing facilities and so forth and bring them home.
That is the state's policy, and that's what this bill is trying to do faster.
Correct. And also what I believe is happening here is that Department of Social Services, what we're telling them is that they have to do an outreach to contact people or the elderly that are on Medicaid and to give them the option or talk to them about the Connecticut home care program. Am I reading that correctly, Mr. Chairman? They're specifically talking about outreach.
Yeah, it's outreach and assistance to help them do that. Yes.
Okay, so we're trying to go, so would that be going into the nursing homes to people that are on Medicaid and explaining to them about the home care program? Would
I
that be
think-
accurate assumption? I don't know.
That seems reasonable.
Okay. Yeah, I mean, listen, I used to work in assisted living, so I totally understand it. Beautiful place. There's some people that do need a skilled nursing. They do need to be in a nursing home because their family can't take care of them and maybe they have to work. And then we have situations for family that they want to age in place and they want to stay home. I think they're all good, to be quite honest with you. I think they're all very important. I don't like the idea that we're kind of taking one from another, but to maybe beef up a certain program that I have. Through you, Mr. Chairman, would you be able to give me a little bit more information about the Connecticut home care program so people can actually understand what it does? This is a great opportunity to educate. Through you.
I don't know that I'm paid enough to represent the Department of Social Services, but I will do my very best. Look, it's we provide we provide programs and supports to help people stay in their homes who do not need to have the level of care that they would receive in a nursing home setting. And my understanding is that in general that yields happy people with good outcomes, and you stay in your home and people like that. So I would also just point you to the testimony of the long-term care ombudsman's office. The ombuds, Mary Painter, has testified in strong support of this bill.
Thank you. Yeah, and I did see that. I'm also looking at the testimony from DSS, Department of Social Services, basically saying that it's not really necessary for this bill. I don't know. Do we have to put into law that they refocus or rebalance their strategic plan for long-term services? Why does it have to be in statute? Is there something in statute that says that they must have a plan and they must report to this committee? Through you.
We've been working to rebalance the state's long-term services and supports for many, many years now, long preceding my time here. And it's something that we've been doing. And the reason we do it through this committee is because we are the funders, right? We're providing billions of dollars to the Department of Social Services for these services. And we're telling them how to spend that money. We don't have, I guess we could do it over a handshake or a beer, but given the amount of money that we're spending, we're trying to do this formally because it's important.
Thank you, Mr. Chairman. I don't have any further questions. Thank you for the.
Thank you, Representative. Other comments or questions? Oh, Representative Dathan.
Thank you very much, Mr. Chair. And I just wanted to clarify, because I may have misheard you. For a Husky C income and asset eligible person, they would qualify for these services, is my understanding. Is that correct? Or did I mishear you saying that they would not be covered?
I am actually going to ask that question over to our trustee, nonpartisan folks to see if they can answer that question better than I. Don't want to give you misinformation, Representative. So they're asking, Representative, if you could repeat the question. I think I can get it, but if you don't mind,
Sure.
that'll help.
So the question I have is, we have income eligible and asset eligible folks that qualify for Husky C. I was wanting to confirm that they would be eligible to participate in such programs like these we have an aging population and a number of folks in our that are managed by DDS now receiving long-term care supports, and that number's growing as people are living longer, and many folks that have IDD are also having also other issues regarding with Alzheimer's and other things. And I was initially under the impression that they would be included, but I wasn't 100% sure based on the discussions here during the meeting.
Hi, Rep. Dathan, Marie Grady from LCO. When you say these programs, are you talking about the Connecticut Home Care Program for the elderly and programs like that?
Yes, the ones that are part of this bill.
Yes, yes. Husky C, there's a state-funded portion of that program. There's a Medicaid-funded portion of that program.
Okay, that's helpful. Thank you very much. Thank you, Mr. Chair.
Thank you, Representative. Other questions or comments from members of the committee? Seeing none, the clerk will please call the roll.
A motion has been made and seconded to JFSB 1416. Representative Gilchrist. Senator Lesser.
Senator Lesser, yes.
Representative Case. Yes. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dayton votes yes.
Representative D'Amico. Representative Fortier.
Yes.
Senator Gaston.
Yes.
I didn't see you on the screen. Can you please repeat, Senator Gaston?
Yes. Could you hear me?
Yes, thank you.
Okay,
Received.
thank you.
Representative Hughes.
Representative Hughes votes yes.
Representative Johnson.
Representative Johnson votes yes.
Representative Kitt.
Representative Kitt votes yes.
Representative Master Francesco.
Yes.
Representative Meskers. Representative Pizzuto.
Yes.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott's yes.
Representative Shake.
Yes.
Representative Stewart. Representative Vale.
Yes.
The roll call is complete.
Thank you, Madam Clerk. We will continue to hold the votes open. Moving on to number 11 on the agenda, Senate Bill 1418, an act reducing barriers to food security. This is a JFS. Do I have a motion?
So moved.
And is there a second?
Second, Representative Dayton.
Moved by Representative Hughes, seconded by Representative Shake. You should have the S language, LCO 6338. And so just to talk folks through what this legislation will do is in Section 1, it requires the Department of Social Services to apply for an 1115 waiver for what is commonly called food as medicine. In Section 2, it increases within available appropriations the minimum monthly supplement. So the minimum monthly amount of SNAP from $23 to $95. And then also in Section 2, within available appropriations, it would implement a program that's being done elsewhere in the country that gives a match when someone uses their SNAP benefit at a farmer's market, which is we already allow SNAP to be used at farmers markets. This would allow the match. Any questions or conversation? All right. Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFS SB 1418 LCO 6338. Representative Gilchrist.
Yes.
Senator Lesser. Representative Case.
No.
Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar.
Senator Anwar votes yes.
I did not see you on screen, Senator Anwar.
Senator
Please-
Anwar votes yes. Can you see me now?
Yes, thank you.
Thank you.
Representative Butler,
Representative Butler votes yes.
Representative Dathan,
Representative Dathan votes yes.
Representative D'Amico, Representative Fortier, Senator Gaston,
Senator Gaston votes yes.
Representative Hughes,
Representative Hughes votes yes.
Representative Johnson, Representative Kit,
Representative Kit votes yes.
Representative Master Francesco,
No.
Representative Meskers, Representative Pizzuto,
No.
Representative Santiago,
Yes.
Representative Scott,
Representative Scott's a no.
Representative Shake,
Representative Shake votes yes.
Representative Stewart, Representative Vale.
No.
The roll call is complete.
Great, thank you, Madam Clerk. We will continue to hold the votes open. Moving on now to number 12 on the agenda, Senate Bill 1481, an act prohibiting discrimination in services funded under Medicaid. Is there a motion? Is there a second? Thank you. Moved by Representative Comey, seconded by Representative Shake. Any questions or conversation? Representative Case.
Thank you, Madam Chair. So I guess my first question is, what are we classifying as discrimination in this bill for you?
That is a great question. I am pulling up. So discrimination is defined in current state statute under chapter 814C. So I was trying to pull that up for you, but that's the definition.
So basically, we have civil rights protect the people in Connecticut. This belongs to CHRO. For that consideration, for the joint rule 3B1, I move that we refer this bill to judiciary, Madam Chair. And I request that the vote on this motion be taken by roll call.
Second.
Okay, there has been a motion by Representative Case and a second by Representative Master Francesco to amend the motion on the table to refer Senate Bill 1481 to the Judiciary Committee. Any questions or comments? We will stand at ease. right, I'm going to bring us back to order. I do see that Senator Gaston has his hand raised. So before I move forward with the vote, I just want to give him an opportunity.
Oh, no, that was an accident. I'm so sorry.
All right, no worries. All right, would the clerk please call the roll on the amendment?
Representative Gilchrist,
No.
Senator Lesser,
Senator Lester, no.
Representative Case, Senator Perillo, Representative Comey,
No.
Senator Marr,
Senator Marr votes no.
Senator Anwar,
Senator Anwar votes no.
Representative Butler,
Representative Butler votes no.
Representative Dathan,
Representative Dathan votes no.
Representative D'Amico,
D'Amico votes no.
Representative Fortier,
No.
Senator Gaston,
No.
Representative Hughes, Representative Johnson,
Representative Johnson votes no.
Representative Kit,
Representative Kit votes no.
Representative Master Francesco, Representative Meskers, Representative Pizzuto,
Yes.
Representative Santiago,
No.
Representative Scott,
Representative Scott votes yes.
Representative Shake,
No.
Representative Stewart, Representative Vale. Oh,
Yes.
Representative Hughes. The roll call is complete.
Thank you, Madam Clerk. The amendment fails. Representative Case.
Thank you, Chair. I see some more of that, so we can see some people to vote. What I'd like to say is, my concern is, why are we, as human services, we are protected under the civil rights, and it says presumably this is to be determined by CHRL, presumably. So who else can determine discrimination through you, Madam Chair?
I'm unsure. In looking at the language in the bill before us, all we're doing is asking the the Commissioner of the Department of Social Services, as a condition of someone receiving Medicaid reimbursement, that they have to agree in writing not to discriminate against any persons.
But who is the holder to decide if discrimination was happening through you?
I suppose if an individual reported to the Commissioner of Social Services or the Department of Social Services that they've been discriminated against, then it would be that department that would decide if Medicaid would be withheld.
I mean, I'm wholeheartedly on stopping discrimination. I think we're a slippery slope here. I don't think well, some of us might be lawyers in this committee, but I'm definitely not. I wholeheartedly feel as though this is the discrimination law and things that happen within this state, especially with presumably by CHRO, should be handled by the Judiciary Committee and not here. I think we can make a suggestion to the Judiciary Committee, but we can't hold them responsible for something that we don't have cognizance over. So for that reason, I'll be voting against it and hoping that through screening out of the House, this will go to Judiciary, to the right place, because it's very concerning that it says presumably CHRO. Thank you, Madam Chair.
Thank you, Representative. Any other questions or comments? Yes, Representative Vale.
Thank you, Madam Chair. I was reading through some of the testimony. Again, see more opposed than in favor of. And there's a medical doctor in there. And seems to be implying that this has something to do with puberty blockers. Is that correct for you?
There was some interesting testimony that did seem to be targeted at the trans community, but this bill is about discrimination across the board.
But what, again, I understand that nobody likes discrimination, but what does this bill have to do with with that and what they said, this would violate their oath to do no harm just to receive Medicare reimbursement. Is our puberty blocker something that's already approved by Medicaid?
It's a good question. I'm gonna go. Does Medicaid cover gender affirming care? I'm gonna ask my nonpartisan staff.
Yes, I believe Medicaid does cover some aspects of gender affirming care, but I'm not sure at this moment whether that includes minors. We could look into that.
Well, blockers, you said?
That's what I'm just
Puberty
reading that testimony.
blocker.
I think they do.
Okay, again, so I remember years back, in the House chamber, because I didn't serve on the committee that it went through. We had a bill about, conversion therapy and how important it was that we do not, do that type of, practices with people under the age of 18. And I supported that legislation. I listened to a long debate. I'm all about parental rights, big time. You know, being a father of 4 children, their mother and I, we certainly believe that we have the right to make those decisions. But there are times, and I listened to the debate, and I thought probably not a great idea what people choose to do beyond 18. But it seems like we have a double standard here. You know, and then when it suits somebody else's narrative, then we kind of go the other direction. I don't think we should be allowing anything with our children before they fully developed and understand what it is they're doing. So if this incorporates that certainly gives me some pause. I'm going to look a little bit more into some of the other testimony, and I'll reserve any other questions if anyone else is going to ask them. I may want to ask a second question. Thank you.
Thank you, Representative Vale. Representative Pizzuto.
Thank you, Madam Chair. I noticed that Commission on Human Rights and Opportunity are the ones making the determinations if there's been discrimination. But that would never supersede a federal law, I don't think, which we already have with respect to discrimination. And I'm going through, as my colleague Representative Vale did, testimony from like OPM and them who are against this bill. And is it because of the financial burden? Is it, appropriations wise?
That they are opposed?
Yes. I mean,
they might be citing, I'd have to pull up their testimony because I don't recall the commissioner speaking to this bill in particular.
I mean, they're a state agency that you would think would back up Commission on Human Rights and Opportunities if they oppose the bill. So I don't know.
It is currently in federal law. This is to codify anti-discrimination policies with regards to Medicaid into state law.
Right. So why would OPM be against that? She's the lead planning analyst for OPM, Heather Ferguson Hull.
You give me just a second. I'm going to
Sure.
pull up the
Yeah, take
testimony.
your time.
Thank you.
Thank you.
The commissioner, thank you for your patience. It appears the commissioner, she doesn't oppose it necessarily. She's suggesting further conversation, because she is making the case that under the provider enrollment agreement, Medicaid providers sign comprehensive language regarding, the prohibition of discrimination. And so I don't want to put words in her mouth, but it appears she thinks it's a bit redundant, but is open to conversation.
What I see is that they asked OPM to assess the feasibility of a pilot program, similar to employee reasonable accommodation fund, which was implemented in a different state, obviously, but I just, usually state agencies are kind of in sync. And it behooves me that even if it was questionable, to say you weren't sure if she opposed it or not. It says that in one section, 1A -2, facilitating increased use of transitional services for youth entering the workforce and creating distributing a disability employment toolkit. They're saying that all of these things basically have, to boil it down, costs that are not contemplated by the bill, but will exist. And I think OPM supports discussing them, but doesn't support the cost. So my question to you is, do you believe there will be further costs by simply approving this Medicaid provider bill?
I'm just wondering if we're talking about two different things.
1481, right?
Yes, and I don't see any testimony from OPM.
Oh,
but
I'm sorry. Maybe that's what I clicked in, but
and I mean, if anyone else, please correct me.
It's not.
And there's no 1A, right?
Let me go back.
It's a very brief
apologize
bill.
if
That's okay. It was a very,
Yeah, I mean, it did make sense to me. So that makes sense that I'm picking up the wrong bill. Yeah, there's a village out there that's missing an idiot right now. Yeah, but I apologize, Madam Chair, and I rescind my question.
there's a lot of bills on this
Yeah.
agenda, so no worries at all. Yes, Representative Scott.
Thank you, Madam Chair.
Yeah.
So I look at when we do some things like this, like the hospital organization group did oppose it, and they oppose it because they feel they're already doing this. It's already happening, and it's something that is like you mentioned before, duplicative. It says, you know, they already do this under the Connecticut Medical Assistance Program. I looked through all the other testimony. There's no one spoke up as saying that this is something that happened to them and they're discriminated against, and there's a need for this. I can't imagine, state or federal, the way our laws are, that there is a loophole that from medical coverage, that there is not some kind of protections against discrimination for those individuals in that are looking for medical care through Medicaid. I honestly think this is duplicate. We're doing something that is, no one's asking for it. And I think, you know, sometimes when we do this, it just really we're doing this to pat ourselves on the back. And sometimes I just don't think that's doing the people service the best, wasting the time doing that. So again, I'm going to be a no, because I just don't think it's accomplishing anything. I think it's already protected. The hospitals say it's already doing this. No one's come forward in terms of any of the testimony saying that this is happening to them and this needs to get corrected. So for those reasons, I'm going to be a no, and I just don't understand the need for it. So thank you.
Thank you, Representative. Yes, Representative Vale.
Again, thank you for the second time. And again, there's concerns too in there about the Connecticut State Medical Society opposes it too, because they feel there's times when they may have people who are violent, and this kind of handcuffs their ability to be able to do that. If you look at that testimony, they definitely have concerns in like whether it be ERs or in the office, that, you know, that people might be able to still do that, but that's comes from the State Medical Society, which represents a lot of doctors and such. So again, if they have concerns, I feel as if they're voicing these concerns, that they weren't really brought into the conversations. And if this is something that's going on, again, it seems like we're looking for a solution, which we don't have a problem for. So, and sometimes when we do these things and trying to do what seems to be the right thing, there's unintended consequences, and they're concerned that this bill might create some of those. So again, another reason makes me reluctant to support this bill. Thank you.
Thank you, Representative. Any other questions or comments? Yes, Representative Master Francesco.
Thank you, Madam Chair. When they're talking about Medicaid reimbursement here, they are talking specifically for medical treatment? For anything? When they're talking Medicaid here, is that right through you?
This would be any Medicaid covered service or, yeah, any Medicaid covered service.
Okay, so any Medicaid covered service. So are there any services that Medicaid covers outside of healthcare? So it could be for food, denying somebody food when they use for their SNAP because that's paid for through Medicaid. I'm trying to know exactly what falls under Medicaid under this particular
So
language.
Medicaid doesn't cover food. That is the
That's the
supplemental,
right.
SNAP. But I say it that way because some of our services for those with intellectual and developmental disabilities covered through Medicaid, like group home, nursing homes, which some might think are medical, others wouldn't.
That's covered.
That's covered under Medicaid. So those are the types of things I mean when I say services and not just specific to medical.
Okay, so it could be nursing homes, could be in-home care, because there's some people that are.
Correct.
Could be
Yep.
things like that. It could be within the medical field. It could be a host of things. So how would someone, CHRO, I guess they are the ones that to determine whether or not discrimination occurred. If they were to determine that discrimination occurred, what would happen under this language? Through you.
I do want to be clear that nowhere in this bill does it say that CHRO would be the one determining that.
I'm sorry, social
that's-
services.
Yeah, that said, what would happen is if it is determined that they have discriminated against someone, then they would be at risk of losing their Medicaid reimbursement.
Okay, thank you. And I meant to say social services. Thank you for the correction. So they are at risk of losing their Medicaid reimbursement. Would they be actually kicked out of the program? They would get no reimbursement, or how would that work? Would they the state ask for a refund to give back the Medicaid reimbursement that you received? Through you.
Great question. So that still needs to be worked out. The language does say commissioner may withhold. So within that, a number of things could happen. They could maybe give a warning first to make, again, these are things that could potentially happen. They could give a warning and say you have a time period to fix your practices. Or they could make the decision to take the payment, to withhold the payment.
Okay, thank you. And I guess I'm still trying to figure out who determines the discrimination. Would they have to go through the court proceedings first? Based on the language in this?
It doesn't specify in this piece of legislation who would determine that. And so that too would need to be worked out as this moves through the process.
Okay, so thank you. So it has to be worked out, but we're asked to pass something before it's worked out. I guess it's kind of putting the cart before the horse. But I understand that. And also this would, under discrimination, it would be discrimination if somebody based on their faith did not want to perform a certain service. Would that be considered discrimination under the provisions of chapter 814C? I think it's actually section 46A, 81. I don't know.
We do
814C of the statutes it says in here. I'm not sure if that's correct.
There are federal and state laws that do protect individuals from performing certain services based on their faith.
So 814C, are you talking about the Connecticut general statutes?
Yes.
Okay. I gotta be honest with you. I find this bill pretty disturbing that we're gonna give somebody a condition. It's like, you're coercing them, holding them hostage. I guess, let me put it to you this way and understand this. So somebody's taken Medicaid, we're giving, whether it's the state portion or the federal portion, right? We're telling someone that you can take Medicaid, you can come into this program, but these are the conditions that apply. Is that basically what we're saying here? The conditions that apply, that you need to sign this documentation saying that you will not discriminate against someone. If you would like to participate in the Medicaid program, You need to sign this document to say that you will not discriminate against any persons whose rights are protected under Chapter 814C of the Connecticut General Statutes. That's correct, right?
Correct.
And if they do not accept those terms, they cannot be entered into participating in Medicaid. Is that correct? Even going forward?
Correct.
So currently, right now, through you, Madam Chair, we don't have any language in place that has people sign off on something like that. Is that correct?
According to the Commissioner of Social Services, they do require as a stipulation of participating in the Medicaid program that folks cannot discriminate.
So what is the difference between that program and this one?
This kind of more strongly codifies it in state law.
Okay, so right now it's not a state law. They have it just on their contract that they cannot discriminate, which is common in many, many contracts. But now they want to codify this into state law. Am I understanding that correctly?
Correct.
Okay. Thank you. I don't have any further questions.
Thank you. Representative Vale.
She inspired me again. So we have a lot of faith-based hospitals in the state, especially Catholic hospitals. Does this apply to them? Is this an issue where maybe there's some procedures that don't align with their faith? Is this an issue there? Is that part of the reason why we're doing this? I don't know. There might be other faith-based hospitals. I know there's definitely a lot of Catholic ones, but
So as I mentioned to the good representative, there is currently federal law that protects individual providers who, for faith-based reasons, wouldn't perform services, and in no way does this change that.
okay, thank you.
Okay. Any other questions or comments? Yes, Senator Perillo.
Thank you, Madam Chair. I appreciate it. Just, there's been some question about the role of CHRO in this. I just want to reference that Chapter 814C is actually the chapter on human rights and opportunities, and references very specifically that CHRO is the agency that would determine whether or not there was some sort of violation of someone's rights. I have a question very specifically. When I looked that up, it sort of begat another question, which is how CHRO complaints are disposed of. In some cases, they're just dismissed because there was no claim or there was no reasonable finding. But in many cases, in fact, in most cases, more than any other, there was a settlement, some sort of financial settlement. No determination was reached by CHRO, but the parties agreed, obviously, typically with some sort of financial settlement, to sort of walk away. The bill as written doesn't really seem to take that into account. It's basically a yes or no, as I read it. Maybe I'm wrong. It's basically a yes or no. There was discrimination or there was not. But am I interpreting it inaccurately? Would there be room for some sort of settlement here? What might those settlements look like? I think we sort of need to play out in our minds where these cases could go. Can you give some clarity?
Yes, and thank you, Senator, for clarifying Chapter 814C. I appreciate that. I think where there is that room for that potential agreement is where the commissioner may withhold Medicaid payments. And so it's not saying that she shall. So in that may, that's when there could be these different arrangements.
Thank you. I appreciate that. I'm kind of, again, sort of thinking through what the process would be and what those potential settlements could be. I mean, I imagine there could possibly be some sort of partial repayment of benefits. It doesn't seem, though, and I think this was mentioned previously, there's no call in this, there's no permission or prohibition, I guess, in the bill as drafted, such that a provider's participation in the Medicaid program could be withdrawn, like that they would no longer be able to participate in Medicaid. I don't see that in here. I just want to clarify that indeed that is not the intent here.
Nope, the intent is just that they could potentially withhold payments from the provider.
Thank you. That is what I thought. I just wanted to clarify. I appreciate your answers. Thank you.
Thank you. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFSB 1481. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes.
Yes.
Representative Johnson. Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott's no.
Representative Shake.
Yes.
Representative Stewart. Representative Vale.
No.
The roll call is complete.
Oh, yeah. Moving on, we'll do item number 13, Senate Bill number 1473, an act requiring Medicaid coverage for FDA-approved gene therapies to treat sickle cell disease. Entertain a motion to JF this to the floor.
So moved.
Motion by Representative Hughes, seconded by Senator Marr. Is there discussion? Representative Case. You have my permission to get your notes.
All right, so we're looking to expand on the coverage for approved gene therapies. In looking through some of the notes, what do we see as this is an expansion and a cost? I know we have to wait for a fiscal. Is there any anticipation of what this will be?
This is directing us to ask the CMS for their support to be in the program that's specifically mentioned in the bill, the cell and gene therapy access model, which is a program that CMS has created to allow states to afford these essential life-saving therapies for people with sickle cell disease. So we know how much the actual treatment costs, which is quite a lot, and this is a proposal from the federal government to make it affordable to states.
Has DSS already submitted a proposal for this to CMS? Through you?
I believe the DSS has been working to make they've applied. I believe the funding was withdrawn or canceled, and so I think we're working to make sure that they continue to participate to the extent that the federal government is continuing that.
Okay, so thank you, Mr. Chair. So this is in the works previously with DSS. So there was a plan moving forward with expanding this previously. No other comments unless somebody else does. Thank you, sir.
Thank you. Yes, Representative Pizzuto.
Yeah, thank you, Senator. My question was, when I was looking up the cost of these gene therapies, I'm all for the gene therapy and stem cell, all that, but it was between 1 and 2 million per person. And so, and if you're the person that has that dreaded disease, sure, you don't care. But my question is, how do we get this through something like our state funding appropriations to do this?
Well, that's exactly the question. And that's why this federal program is so important to allow us to afford it. Because if we were just going to be affording it without this access model, then we would have to pay in some cases $2 or $3 million per person, which is a staggering amount. The only thing I would also say is that we received testimony as well about the cost of providing lifetime care for persons with sickle cell. It is a debilitating lifetime condition that puts people in extreme pain and puts also has enormous long-term costs. So we're talking about billions of dollars nationally per year to support these individuals, whereas this treatment can potentially cure the condition. So it's a potentially miracle treatment, but the question is, how do we afford it? And CMS has created this model that will supposedly make it possible for states to do it. I think that's better than us not participating, where we don't have access to the funding.
To the good chair, do we have any knowledge of other states that already do this?
I don't have that knowledge, no.
All right, thank
This is a new model from the feds.
Thank
you. Representative Vale.
Thank you, Mr. Chair. Does this require us passing a law? Isn't this something the commissioner, we could just request for the commissioner to do?
We want to make sure that the treatments become available to Connecticut Medicaid recipients. We had been under the impression that this was a done deal earlier, but then due to some hiccups, the federal government actually canceled, as I understand it, promised grants for 10 individuals in the state battling sickle cell. We wanted to make sure that there was at least some protections in the law to ensure they have access to these treatments. So there's just a lot of turbulence happening, and so it's important that this committee send the message to DSS that we have their back, and we want to make sure that the individuals in the state on the Medicaid program have access to these life-saving essential gene therapies.
And I understand that, but again, this applies directly to the commissioner, correct? That she apply for these grants or this money.
Correct.
Thank you.
Representative Mastro Francesco.
Thank you, Mr. Chairman. So what I'm trying to figure out here in this bill on line 1 is for the Commissioner of Social Services to provide Medicaid coverage for gene therapy approved by the FDA and sickle cell disease. According to the testimony from the DSS, they're saying here the Medicaid program is already required by federal statute to cover FDA-approved treatments from pharmaceutical manufacturers that participate in Medicaid drug rebate program, including gene therapies for sickle cell disease. So it is my understanding that they are already providing that. Can you tell me what the difference is between that and the language that is in this bill?
We want DSS to maximally cooperate with CMS to ensure that these therapies come down to the patients. 10 people that, to my knowledge, were promised therapies by the federal government. The federal government said, we are going to pay for the cost. The federal government then said, you know what? We're putting a pause on all federal grants to help people. And so they actually canceled those grants. So these are folks who have this, life-threatening, lifelong, crippling condition. They were promised a cure, and then the federal government, I think in a very cruel and capricious way, canceled that funding. We're saying, look, DSS, we know you can't control what Washington does, but we want you to work with CMS to the maximum extent possible to find a way to provide this treatment to the folks in Connecticut with sickle cell. And so, yes, they may already be doing it, but we're really trying to put light a fire at CMS. There are lots and lots of federal grants and programs out there. We're trying to direct CMS. This is something, DSS, this is something you should prioritize. Hopefully we can get this done and provide these treatments to patients. And we're glad that the federal government, at least in theory, is offering help to states to afford it. Otherwise, we're stuck with a tab, which is, as I mentioned earlier, quite expensive. If we don't do this, it could be $2 or $3 million per patient, which is a lot of money.
Thank you for that. You mentioned that the federal government has already canceled these grants. Is that correct?
Well, it's unclear to me. What I was told was that the 10 folks who had been initially granted grants to get these gene therapies were then told that permission had been revoked. I don't know whether the federal government has subsequently changed its mind. I see things in the news about this, but I don't know where things stand today. And I think we need some clarity on that.
So we don't know for sure. We're just, was it canceled last year? Were these grants canceled last year, or these recently the news that you're reading today that things are going to be canceled? Are we just assuming? Well, I guess I'm trying to figure out, when did this transpire?
The Department of Social Services, I think, received notice in, I believe it was either late January or early February. I think it was early February, that the new administration had canceled those promised grants to those individuals in Connecticut, and we were trying to figure out what to do about it.
Okay, I guess the ones that you were talking about, the grants for 10 people, was that information relayed to you through Department of Social through DSS?
Yes.
Okay, and those just happened recently within the last, you said sometime at the end of January, beginning of February?
Correct.
Okay. So last year, I guess what I'm trying to figure out is this was covered the prior year? And you're telling me how did, I guess,
No, I think
I'm just trying to figure out how these programs got canceled. And without you saying it's from the current administration in Washington, because it just doesn't happen that quickly. So there must be a reason for it.
Well, I read the newspaper, as I'm sure you do, Representative. So I don't have any specific insight into what the administration is doing or why, other than what I read in the news. But I will tell you what, as I understand it, these FDA approved therapies were just recently approved. And so they provided the promise of a cure for patients with this debilitating disease. And so a year ago, I reached out to DSS, knowing that there are folks in Connecticut with sickle cell who could benefit from this. And I asked if DSS was planning to cover it, and they said they were interested, but they needed to figure it out how to actually do it. And obviously, it was a little discouraging to see the price tag be so enormous. And yet it was good when CMS stepped forward and said, you know what, we recognize that states need to pay for this. The majority of folks with sickle cell are actually on Medicaid. And so if this is going to be available to folks, we have to figure out how to help states pay for it. So they created this program. They created the cell and gene therapy pathway program to allow states to pay for it. States have applied, and hopefully this works. But no, I don't know what exactly transpired in I think February, but to the best of my knowledge, that there were federal grant programs all over the place that were being paused or canceled, and so I assume that was caught up with that, but I don't have any specific knowledge.
Thank you. Yeah, and again, I'm just looking at the testimony from DSS, basically saying that this bill is not necessary because they recently just applied. So I appreciate your answers on that. Thank you, Mr. Chairman. I have no further questions.
Representative Case. For the second time?
I haven't talked on this one yet, sir. So
then I apologize, sir.
Or maybe I did, I don't know. But just for clarification, I want to read from the commissioner's testimony. In addition, the department submitted Federal Centers of Medicine and Medical Services application for cell and gene therapy access model on March 5th, 2025. She just applied for it. We haven't been cut off from it yet. We just applied for it. It's her testimony. Thank you.
Any other comments or questions? Seeing none, the clerk will please call the roll.
A motion has been made and seconded to JFSB 1473. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case.
No.
Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar. Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
You're not on camera, Senator Gaston.
Senator Gaston votes yes.
Thank you. Representative Hughes.
Yes.
Representative Johnson.
Representative Johnson votes yes.
Representative Kitt.
Yes.
Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott's a no.
Representative Shake. Representative Stewart. Representative Vale. The roll call is complete.
Okay, time flies when you're having fun. Senate Bill number 14 on the agenda, Senate Bill 1480, an act concerning private equity and real estate investment trust ownership of hospitals and nursing homes. Is there a motion to JF this to the floor? Motion by Representative Gilchrist. Is there a second? Second by Representative Kitt. Is there discussion? Senator Froelich.
Thank you, Mr. Chairman. I appreciate it. I'm just trying to wrap my head around this. So would this, if passed, prohibit privately owned nursing homes and hospitals?
No.
It would not prohibit. Okay. So could you just explain what it does, please, sir?
Absolutely. It says that after October 1st, that nursing homes or hospitals that receive Medicaid reimbursement shall not have new ownership interests that are private from private equity firms or real estate investment trusts.
Okay, thank you, sir, and I appreciate that. So if there is a nursing home that exists in the state of Connecticut right now, and it were nonprofit, it would not be able to be acquired by a for-profit entity. Is that correct?
No. Okay. That is not correct.
Okay, but it would not be able to be acquired by a private equity company or a REIT. Is that correct?
After October 1st, that's correct.
Okay, so what about nursing homes that are currently owned by a private equity company or a REIT?
They would be grandfathered in.
They would. Okay, thank you. So as we know, there are a number of financially distressed nursing homes in the state of Connecticut. It's a real problem. For some of them, the only way to survive is to be acquired by a for-profit entity. And in many cases, that for-profit entity has been a private equity company or a REIT. In fact, if I'm wrong, please tell me, about 90% of nursing homes in Connecticut are owned by some type of for-profit entity. Now, not all of them are PE and not all of them are REITs, but some sort of privately held for-profit entity. So I'm a little concerned that what is obviously well-intended, I'm sure, it would actually stifle opportunities for our existing struggling nursing homes to survive. Because at the end of the day, some of these buildings, they are old, they are tired, Medicaid sufficiently to cover the cost of rehabbing, reconstructing, beautifying some of these nursing homes. In many cases, the only way to do it, as I said, is via a for-profit entity. Oftentimes here in Connecticut and throughout the country, that's PE or that's a REIT. So I worry that we are, what's the saying? We're putting out a candle with a fire hose here. That's my concern. I understand that there have been some problems with nursing homes here in Connecticut owned by private equity or REITs. I understand that. And we obviously certainly don't want that to happen. We don't want dangerous places. We don't want places where patients are mistreated. That goes without saying. That said, this seems like a pretty broad bill to address those issues. I mean, in fact, we already have a mechanism here in Connecticut to address those issues. It's the certificate of need process, right? And we've seen the CON process function in exactly this way in the past, whereby OHS has considered every applicant different, which is fine because every applicant is different. There are very good actors who happen to be for profit. And there are also very bad actors that are for profit. In fact, there are bad actors that are nonprofit. We should be focusing on those bad actors who have a history or a track record of poor practices in other states. And then we should be stopping them from acquiring nursing homes here in Connecticut. Unequivocally, that is something we ought to do. But to simply say that private equity, real estate investment trusts, you're out. You have no right to be here. I just think that's a pretty big thing to say, to enact, when there are good actors out there. We don't want the bad guys. We don't want them. We all know that. Everybody around this table can agree on that. But I think we, with this bill, really eliminate, not just stifle, eliminate an opportunity for a lot of these nursing homes who want to thrive, who want to survive, who want to continue to be a good place for their residents. We eliminate the opportunity for them to rebuild, to refresh, to hire the right number of people. And that is my concern here. That is my concern. I certainly would love to weed out the bad guys. But this does far more than that. It weeds out bad guys. It weeds out good guys. It weeds out angel investors who can come in and save the day for distressed nursing homes. It's just a really big overreach. And that's my big concern. And I laud the intent here. You know, we want to keep people safe and healthy. But this goes far beyond that. Thank you.
Thank you, Sam. Representative Kiss.
Thank you, Mr. Chair. And I think we've talked about this in the public hearing, and I agree with my ranking senator has said. We have to realize we have an aging stock out there, with aging people, and we need some help because our Medicare rates and Medicaid rates for reimbursements to the nursing homes are crappy. We always talk about it, that we do not meet what the nursing homes need as far as what we provide them with financially. I think to cut it off, and we have the CON process, which is what's put in place to protect. We could have some bad actors, but I think we're going to have more better actors, and we're going to have better facilities if we open up and not stop, quote unquote, private equities to come in and help those aging facilities to better themselves. I don't know. I've visited a few nursing homes in the past few weeks. I'm embarrassed to say they're not in the best of shape. And they're not going to get any better shape unless we give them money or a private equity group gives them money. Just take a walk into some of these places. They're doing the best they can. I mean, I'm looking at one, walked into one in up near my way that's $218 a day. That's what they're getting. $218 a day from the state. You tell me we can give care and take care of a facility at $218 a day? Feed the person? That's incredible. Whereas, I won't do the calculations now. I mean, private pay in that same facility is $15,000. But we pay $218. I think that's just shy of $6,000. So that's less than half of what private paid people are paying. We need to open up and not shut down and allow people to come in and work in these facilities if they're a private equity. So every occupation, even the one I'm in, private equities come in and buy up companies. It happens. People just can't afford, companies can't afford to do upgrades and do the things that are needed to make things better. I just really think that we're being short-sighted. I know there's been some problems with some hospitals and some takeovers, some things that are going on, but let's let the CON process work. We're going to hinder our stock of nursing homes, hospitals, if we shut this off. I'm not pleading that private equities come in and take everything over, but if they need some private investment or something to better a facility where my loved ones are going to, I welcome it. Do they need to be controlled? Do we need to have the best care in there? Absolutely. That's the CON process of the state of Connecticut. With that, Mr. Chair, I cannot support this today. I do laud that we're trying to protect, but I think we're trying to protect at the cost of the aging stock of our facilities in this state and what we pay these facilities. People go out there and look at the reimbursement rates or the daily rates, what we pay these nursing homes. It's sickening. I mean, a couple states over, they're probably $200 to $300 more a day. The one I looked at the other day was $218 a day. You can't make a facility look good, smell good, be good. Your people in it work the best they can when the facility is up to par. With that, I can't support it. Thank you, Mr. Chair.
Thank you, Representative. I will just say, I don't think the committee has any particular animus towards any class of investor or pooled investment vehicles. The issue here is just simply a pattern, which is that across the state, both on the hospital side with regards to Prospect Medical, but also in nursing homes across the state. And I'm see Representative Fourier over there. I know what's happened recently in Bristol, but we've had a lot of nursing homes wind up deeply in debt, not because of anything specific to that nursing home, but because the ownership structure has really been oriented in a way where they're incentivized to maximize debt, to pay off their investors, but that leaves the asset looted, and it creates a real problem for the taxpayer, because when they're not investing in their resources and they're not and their focus is on short-term return for their investors, that often leads those assets looted and deeply in debt. And then we have to figure out, what are we going to do to support the affected residents of the nursing home or the patients when that and we're left holding the bag. So this is not our first. This was not our first thought, but this is unfortunately where we're headed, just because of the long pattern of behavior that's led to this. And so the hope is that other ownership structures, including other for-profit ownership structures, are more associated with sustainable business practices that don't leave the taxpayer holding the bag. Other comments? Yes, Representative Pizzuto.
Thank you, Mr. Chairman. I had the well, I don't know if it's a privilege or not, but to live through the Prospect Medical thing as part of my territory, Waterbury. And one of the variables in this formula is the certificate of need process. That should take 30, 60, 90 days, whatever. This was 420 days. And so the private equity firm that had come in had put 50 million in and had done a lot of things. And then 420 days waiting, Yale walked away and with the $475 million deal. The reason I bring all this up is hospitals can usually absorb big hits like that. For a nursing home who may work out a deal with a private equity firm that everyone's content with, like we were, a certificate of need or a state process can undo what we're trying to do here. So I think in this bill, whether it passes or not, and I don't think I'm going to vote for it, but is that the certificate of need can make or break any entity, whether it's a private equity or anyone else. So I don't think we put enough emphasis on that. And I'd like to see in the bill how you, if we're attaching who should buy it, who can't buy it, let's put a constraint on the certificate of need process, if we can, to get this done. So those are my comments. I'd like to see if you'd be amenable to that.
We were just trying to figure out, I'm not sure if I know that there are two different CON programs. There's the hospital CON program and there's a nursing home one, and they're not the same. And I'm not sure, I know we don't have cognizance over the hospital CON program. I'm not sure if we have it for nursing homes. We don't have that either. So it is a good question. This is not a bill that is intended to solve all the issues, and certainly Representative Case's comments about reimbursement rates, we have a Medicaid reimbursement bill. We're very much focused on those other issues. This is looking at one piece of the puzzle. But you're right. There are other issues out there. And I will just also say, in terms of attracting investors, because that's another thing we need to do. We've already voted to JF a bill that will suspend the long-time nursing home moratorium. And hopefully that will in part, and hopefully that will provide some additional influx of private investment to support these nursing homes, because all of us, Democrat or Republican, no matter where we are in the state, we have an interest in making sure that nursing homes are on a sound financial footing. And that's something that, you know, I think we all can come together on, and hopefully we are ensuring that. But appreciate your
Mr.
comments.
Chairman. Yep.
Other comments or questions? Seeing none, the clerk will please call the roll.
A motion has been made and seconded to JFSB 1480. Representative Gilchrist. Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr. Senator Anwar. Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Yes.
Representative Johnson. Representative Kit.
Yes.
Representative Master Francesco.
Recidivism because it's a moving target.
Representative Johnson.
Representative Johnson votes yes. Thank you.
Representative Meskers.
Continue that path.
Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott said no.
Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. Next, we have item number 50 on the agenda, and Senate Bill number 1479, an act concerning arbitration and healthcare. Entertain a motion to JF this to the floor. Motion by Representative Gilchrist. Is there a second?
Second.
Second by Representative Hughes. Is there discussion? Representative Case. Senator Perillo.
Thank you, sir. I appreciate it. So I just want to get my head around exactly what we're doing. So this, correct me if I'm wrong, I'm going to try and summarize. So the bill as proposed would prohibit a Medicaid participating provider from including a mandatory arbitration clause in their agreements with whom?
Patients.
With patients. Okay, understood. Thank you. What is mandatory arbitration?
To the best of my knowledge, Senator, it's when when two parties agree that in the event of a dispute, they will hire an arbitrator to resolve the differences rather than pursuing a claim through the court system.
Thank you. Who determines who the arbitrator is?
That is typically a subject of the agreement between the parties.
Thank you. Is the arbitration binding?
Typically, yes.
Okay, so what other rights are waived when there's an arbitration proceeding?
Again, it depends on the specific terms of the agreement, but certainly you would waive your access to the court system, and with that, an access to a jury trial. You could also waive, by extension, your ability to pursue a class action. There are other potential things that could be waived as well, and this has all been covered. I think it's all subject to the rules of the Federal Arbitration Act and the number of court rulings federally that have discussed this.
Thank you. I appreciate that. So in what types of contracts with a patient would there be this kind of clause?
Well, I'm not sure, but the bill is only specific to billing disputes.
Okay.
So there could, I mean, I don't know if there are other circumstances where a patient might have to arbitrate a claim involving quality of medical care or some other concept. I'm not aware of that, but this bill is only specific to billing issues.
Thank you. So, but in what type of contract would there be need for an arbitration clause as it relates to billing? I'm just trying to understand what kind of contract a patient would sign with a provider where this would even come up.
Well, I don't know. But imagine you are going to receive medical care out of medical facility, and they ask you to sign a contract as a you get a lot of paperwork when you go to a healthcare facility, and you have to have a HIPAA waiver and all the other stuff, or a notice of HIPAA. You accept the HIPAA. I forget. There's a HIPAA thing. And the question is, if you're also being asked to waive your ability to sue in the event of a billing dispute, we're saying that would be a prohibited practice, at least for institutions that accept Medicaid.
Okay. I mean, so here's the vibe I'm getting right now. I don't think we really know exactly what's going on here. I think the Judiciary Committee would. So I would move to refer this to Judiciary.
Motion to refer this to the, this is a question for LCO. Is that a motion to refer? We have a motion on the floor to JF. So is this a motion to amend?
It's a motion to amend.
Okay. A motion to amend the motion to refer this to the Judiciary Committee. So the motion's been made by Senator Aprillo and seconded by Representative Case. And so Senator Aprillo.
I would just kindly ask that the vote be taken by roll.
Yes. The Senator Aprillo has requested that when the vote be taken, it be taken by roll, and would just ask members to oppose the motion. This bill may well be referred, but I think that's a judgment that will be determined by the screening committees of the Senate. Yes, Representative Vail.
Yeah, I'd like to talk on the amendment. So,
Absolutely.
this bill is 10 lines, correct? Or 11, if you count the word services, correct? It's a short bill.
Your math is my math.
Oh, yes. So I just listened to that whole exchange between you and the good senator. And I still don't understand what we're trying to do here. I understand arbitration, I understand insurance, I understand this, but I'm not understanding when these clauses come into effect. And again, I'm sitting here and maybe someone else can articulate it in here for us, but it doesn't seem like anyone has an answer on this committee. And that's probably why I think it's important that we do send this one to Judiciary. So I would hope that my colleagues feel the same, unless someone wants to explain it to me in a way that I can understand. I think we should do that. Thank you.
We don't have personal attacks in this committee, and I won't interpret it as a personal attack that you just called me inarticulate, but I will, I apologize for not explaining it in a way that.
No, it wasn't that. You probably did explain.
I was not offended, Representative.
Okay. It's seriously, and I do think that's where, not that I even like the Judiciary Committee that much, but I would agree with the good senator. Thank you.
Thank you, Representative. Any other comments, questions? Representative Case.
Thank you, Mr. Chair. And I respect for what you're saying. It's just, we have too many questions on this, and I'm not a lawyer. I mean, you may be a lawyer, but it's not something that I'm comfortable with passing out of here. You're talking about arbitration. We don't know what arbitration they're going after. We talk about people signing off that they won't sue. We talk about people in a previous bill that if they have bills that come to them after they pass out of a nursing home or wherever, that the state will pay for them. I think bottom line, this needs to go to a legal committee, to Judiciary. I mean, I don't even understand why it's here. It's arbitration in healthcare. We have a portion of healthcare, but we don't handle the bills. We don't handle legality. So I think this motion to move it to Judiciary directly so they can get it now, instead of going to the floor so it has 2 or 3 more hoops to go to, let's get them now so they can start working on it. So I respectfully hope we can pass this out and get it to judiciary first. With that, I look forward to the vote.
Other discussion from members of the committee? Seeing none, the clerk will please call the roll.
Representative Gilchrist.
No.
Senator Lesser.
No.
Representative Case.
Yes.
Senator Perillo. Representative Comey.
No.
Senator Marr.
No.
Senator Anwar.
Senator Anwar votes no.
Representative Butler.
Representative Butler votes no.
Representative Dathan.
Representative Dathan votes no.
Representative D'Amico.
D'Amico votes no.
Representative Fortier.
No.
Senator Gaston.
Senator Gaston, no.
Representative Hughes.
No.
Representative Johnson.
Representative Johnson votes no.
Representative Kit.
Representative Kit votes no.
Representative Master Francesco.
Yes.
Representative Meskers. Representative Pizzuto.
Yes.
Representative Santiago.
No.
Representative Scott.
Representative Scott's a yes.
Representative Shake.
No.
Representative Stewart. And Representative Vale.
Yes.
The roll call is complete.
The clerk will please announce the tally.
Five yeas, 15 nays.
Motion fails. Any other discussion on the bill? Seeing no discussion, the clerk will please call the roll.
A motion has been made and seconded to JFSB 1479. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes.
Yes.
Representative Johnson. Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers.
Representative Johnson votes yes.
Thank you. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott.
Representative Scott's a no.
Representative Shake.
Yes.
Oh my God.
Representative Stewart.
I was in.
Representative Vale.
They hear me? They hear me?
No.
Representative Johnson, if you're not talking to us, could you please mute yourself?
The roll call is complete. Thank you.
Thank you, Madam Clerk. Moving on, we have item number 16 on the agenda, Senate Bill number 1478, an act concerning Medicaid billing by school nurses and for special education. Is there a motion?
So moved.
Second.
Motion by Representative Fortier, second by Representative Hughes. Is there discussion? Wow, clerk will. Please. Oh, just under the wire. Representative Vale.
It's just for clarity. So we're developing a task force, correct? And so are they going to report to us or are we going to automatically implement their recommendations?
No, they're going to report to us.
And then we'll make that decision no later than they're reporting to us.
October 1, 2025.
Okay. So this is something we more than likely will take up next year.
More than likely.
Okay, thank you.
Okay, I have made a terrible mistake. We were supposed to JFS the language with a minor amendment that just has a typo correction. So with that, I would ask that whoever made and second Representative Fortier, you made the motion? Would you please withdraw the motion?
I withdraw the motion.
Okay, great. And Representative Hughes?
I withdraw.
Okay, so I misspoke and I apologize. I would like to JFS and LCO 6337, which changes a typo in the reporting date in line 18. Motion, Representative Porter, would you like to remake your motion?
So moved.
Seconded.
Seconded by Representative Hughes. So this was simply a typo where I think we had the correct deadline, Representative Vale, was October 1st, 2026. So we will be taking this up in 2027. Any discussion? Clerk will please call the roll.
This is a roll call vote on Bill SB 1478 JFS to the floor. Representative Gilchrist,
Yes.
Senator Lesser,
Yes.
Representative Case, Senator Perillo, Representative Comey,
Yes.
Senator Marr,
Senator Marr votes yes.
Senator Anwar, Representative Butler,
Representative Butler votes yes.
Representative Dathan,
Representative Dathan votes yes.
Representative D'Amico,
D'Amico votes yes.
Representative Fortier,
Yes.
Senator Gaston,
Yes.
Representative Hughes,
Yes.
Representative Johnson,
Yes.
Representative Kitt,
Yes.
Representative Mastro Francesco, Representative Meskers, Representative Pizzuto,
Yes.
Representative Santiago,
Yes.
Representative Scott,
Representative Scott's a yes.
Representative Shake,
Yes.
Representative Stewart, Representative Vale.
Yes.
Thank you. Roll call is complete.
Thank you, Madam Clerk. Number 17 on the agenda, Senate Bill number 1474, an act concerning the Department of Social Services. Entertain a motion to JF this to the floor. Motion by Senator Marr, second by Representative Gilchrist. Is there discussion? Representative Case.
Thank you, Mr. Chair. So we have a requirement, or we do accept, I believe, the weight loss drug. Can you explain a little bit what this bill is doing to us? For you?
It's helping to slim down. The bill has a couple of parts, a few different components. One, it just clarifies a law that we passed in 2023 that suggests that weight loss drugs include GLP-1 prescription drugs approved by the FDA. It also requires that the commissioner shall report on state plan amendments to this committee. Right now, the commissioner provides some state plan amendments for approval by the Appropriations and Human Services Committee, but not all of them. And so the concern is for us to have to fulfill our role to provide adequate oversight over DSS. We want to make sure that they're coming to us with all state plan amendments that they're submitting to CMS. So we know what's going on and we can potentially disallow stuff. And then lastly, it's about making sure that we're doing what we can within the scope of the Medicaid program to educate folks about non-opioid treatments for pain. This is an idea about with reducing the prescription of opiates where clinically appropriate.
Thank you, Mr. Chair. So through you, we passed this 2023, and that was basically the Ozempic bill. Is that correct?
Well, DSS says it was an Ozempic bill, so we're clarifying that it was.
Is this the one that had the large expenditure so far this year out of state insurance?
No, sir, because the DSS has not fulfilled the requirement under this bill.
Okay, so state insurance other than the DSS, social services, I think Medicare, Medicaid, but our state plan is the one that has the Ozempic in it. I'm just trying to, there's a few bills out here for this.
The GLP-1 drugs may be prescribed for weight loss or for other reasons, including cardiovascular risk and sleep apnea, and of course for type 2 diabetes treatment. And I understand that what Representative Scott said, there's a big difference between type 2 and type 1 diabetes. These drugs have multiple uses. There definitely has been prescription for things other than for weight loss, but as to my knowledge, DSS has not provided any coverage of GLP-1 drugs for weight loss.
Thank you, sir. So we're looking to expand what we did in 2023 so we can get other drugs in the program. Is that correct?
We're hoping that DSS will comply with what we believe was the initial intent of the bill, and there's some dispute about that.
Okay, thank you, sir.
Representative.
Thank you again. To follow up, just because you call it GOP1 doesn't mean we're going to vote for it, by the way. Okay. Because we agree
GLP,
GLP is
not
number
GOP.
one. So, anyways, so what was done in 2023 again, was something that we did above and beyond, Medicaid in Connecticut. So we're approved services that would reach beyond what Medicaid covers. Is that correct?
We in 2023 asked that Medicaid cover a bunch of different approaches to obesity, including nutritional counseling and bariatric surgery and weight loss medications. And so this bill is really specific to the weight loss medications piece, and we want to make sure that patients on the Medicaid program have access to them.
And so this is more of an interpretation where we passed a law that there was a certain intention. Someone DSS interpreted a different way. And so this would solidify that intention.
Correct.
Okay. And are there other GLP-1 medications? Like obviously the one that comes to mind is Ozempic. I think I don't know. There's a lot. This applies to many of those?
Yeah, so some of them have been approved for weight loss and others haven't. And I don't want to, I believe at least 2 have been approved for weight loss. But this is specific to ones that have been approved for weight loss, not for, some of them are used off, they're commonly prescribed off label for weight loss. This is for those who have it specifically approved for weight loss.
Okay. And again, I see also there's language in here about BMIs being over 35. Is that new to the language, or was that just also part of or clarification, or is that to make it more clear?
So that is a cost containment issue. But one of the issues that we're wrestling with is we understand that there has been the intent of the agency may have been to kick people off their medications if the medications work, which is probably not a good idea. So if somebody's BMI drops below, we only wanted to cover folks who were severely obese. There are certainly folks who might want to use this for less extreme circumstances, but is a way of focusing this class of drugs on those who would most need this to avoid severe health consequences. We really wanted to target people who are severely obese, so people with a BMI of over 35. But then the question in this language just clarifies is that if they are above 35 and because the drug works, their BMI drops below 35, we don't want DSS to then pull the medication, say you don't need it anymore, which would then cause their weight probably to boomerang and go back up, and which would defeat the purpose of the program.
Well, let's say their weight get down, or however that is measured. I'm sure it's not just weight, but however that, if it got below 25, is there some point where it would be considered? Because I asked that question, we had public testimony on it. If in some cases, maybe where some people are more obese than others, that they wouldn't have to stay on it. No offense, Representative Case, I saw you look over at me when I said that. They could actually come off it. So is there any type of gauge?
Yeah, it's the physician. We're asking a physician to certify that
Okay.
that they really do need to continue to be on it to ensure that their weight doesn't boomerang.
Okay.
If you're able to control your weight through lifestyle changes and whatever else, and you don't need to be on these drugs anymore, that's fine. That's great. But we're saying if the physician is certifying that it's not appropriate to discontinue it, then we would continue it.
Okay. Thank you.
Representative Pizzuto.
Thank you, Mr. Chairman. I understand that weight loss drugs like Wegovy, Manjaro, and Ozempic, Jesus.
Representative, did you say Bon Jovi?
No, yeah, Bon Jovi, that's a good weight loss routine. But I know those are given in priority to people that are diabetics. So there's basically a pecking order. And I know that people take it for thyroid issues, especially Ozempic. And so you'll have people that will say, well, I'm just taking that because I want to lose weight. But they won't get in line for that unless, even with this bill, because it should go, I guess, supposedly to diabetics first and things. But I guess my question is, these drugs have other benefits, and that was a spinoff. Just like whatever that was, Rogaine grows your hair years ago, was never intent for that. So will there, if this passes, does DSS have a pecking order on who they will pay for?
Yeah, so under the Medicaid laws, the DSS is required to cover all medications that have been approved by the FDA, except hair loss and weight loss treatment. So we are saying we also want them to cover this type of weight loss treatment subject to these restrictions, including that it only applies to people with a BMI of over 35. So in a narrow circumstances, we also wanted to cover weight loss treatment. But certainly under existing law, if you are in need of one of these drugs because of your type 2 diabetes, you can get that coverage today because that is all medications approved by the FDA.
I understand the expense to that. Those are probably $1,000 a shot or whatever. They come in packages of 3. I've seen family members that have used it. It requires refrigeration and so forth. So it's not simply a matter of paying for it and getting in a pecking order, but also understanding how to use it. You're injecting yourself. So, I can imagine people that say, I want to lose weight, and they're not used to doing that. And so take an injection to do it. Is there some training that would be required other than, the physician telling them, you qualify?
We are not that committee. That's really a public health question. It's a good question. I don't know how. I know that there's the American Academy of Obesity Medicine or something along those lines. There are certainly guidelines about how to prescribe these, but that is way outside of our scope. And I think those smart people over at the Public Health Committee can tell you better about what safety circumstances should be in place. That's all FDA approved stuff, and that's not us. We just handle the money. Are there other comments or questions from members of the committee? Seeing none, the clerk will please call the roll.
A motion has been made and seconded to JFSB 1474. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar.
Senator Anwar votes yes.
Thank you. Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Yes.
Representative Johnson.
Yes.
Representative Kitt.
Yes.
Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott. Representative Shake. Representative Stewart. Representative Vale.
No.
The roll call is complete.
Okay, moving on to number 18, numbers 807, an act concerning the elimination of asset limits for Husky C beneficiaries over a 5-year period. Entertain a motion to JF this to the floor.
So moved. Seconded.
Motion by Fortier, second by Representative Hughes. No, is that right? Yes, okay. I saw Representative Johnson looking at me, so I was questioning my own thirded by Representative Johnson. Is there discussion? Representative Case?
Thank you, Mr. Chair. Again, this is something we've seen multiple years. And it's something we have a fiscal note on. But a fiscal note, not for this year's bill, but for 2023, I believe it is. There was a Senate bill back then also, but it brought the limits much lower than these. I think it was up to 2,500. I just ask, it hasn't gone before because we can't afford it. In 2023, SB 283 was $1.1 billion, and it was doing less than a quarter of what this is doing. I have it right in front of me right here. So $1.1 billion. What are we looking at? I know we want to change things. We want to make Husky C. If we do Husky C with this, once we get into the 5th year, is it just everybody has eligibility for Husky C through you?
No.
Through you, Mr. Chair, can you explain that, please?
Yes, this bill just talks with the asset limits. It doesn't apply to income limits. You also have to be disabled to be on the Husky C program. So if you're not disabled, you wouldn't qualify.
So, Mr. Chair, and I know this might not be your purview in this committee, but it's going to be the purview in appropriations. Have we had discussions with the Propes chairs to see where they feel this can land this year? I just hate putting something out of a committee if we know that it's not going to get its steps. We've had this conversation multiple years that I've been here, and it just gets more and more costly through you.
Well, we know it's expensive. That's why we're clearly a policy committee. We're not the money committee. We for a number of years have made the judgment on a bipartisan basis that our Husky C asset limits are woefully low. They're way too low, and that has a huge and frankly a discriminatory impact on people with disabilities in Connecticut. Because if you don't have a disability, you don't have these asset limits. You don't have any. If right now on Husky A or B or D, you have no asset limits. It's only Husky C recipients who have an asset limit. And that is a discriminatory difference that only applies to people with disabilities. It doesn't apply to any other population in the state. And so as a policy committee, we're trying to say that that's not a good policy. And we want to make sure that we're doing what we can to support people with disabilities in the state and provide equity and equality and equal access to healthcare. So we got to work with them. I'm not sure if we can do all of this, but maybe we can do some of it. And that's a conversation we want to have with the Propes chairs. If we don't do this, then we don't have the conversation.
Thank you, Mr. Chair, and I do respect that, and been in this building for quite some time, and I am very concerned and have my heart with anybody who has a disability. That is one of the reasons I became a legislator, because we need to work with those, and we need to make sure that everybody in this state has a fair shake. My concern is we have done this, and alls I see in this bill right now is increasing levels higher than what we've had in the past, and that's not going to lower costs, that's going to higher costs. And the 2023 bill, like I said, a cost of approximately $1.1 billion for the first phase. I set that in, 1.1 billion. What do we, and we're not the money committee. I've been saying that all along as we're sitting here. We are the policy, but we pass it along. But we need to pass things along, I believe, so they can pass out of another committee. I don't see this as something that we at this committee, it is a policy, but it is a standard that we are going to have a conversation with appropriations people. And I really think that the bottom line is it needs to go to appropriations. So with that, I'd like to amend this and insert that this bill, SB 807, be referred directly to appropriations so we can get it under works to see if it's within our budget. I request that the vote be taken by roll, sir.
Second.
Motion to amend the motion and refer this to appropriations made by Representative Case, seconded by Representative Mastro Francesco. Is there discussion on the motion? I see Representative Hughes waving her hand. Representative Hughes.
Thank you, Mr. Chair. And I share my good colleagues' outrage at the proposed fiscal note. I really want to question that cost analysis, how they got there, because I just don't think it's accurate when we compare it to other states that have, reasonable asset limits. It doesn't increase the cost, because what you're saying is that this many more people would suddenly be eligible for this program that are disabled. And from working within the disability community, I just don't think that's true. I don't know how they came up with that fiscal note, but I too question the validity of the process of coming up with that. And that's why we're putting this forth again with reasonable asset limits that are, comparable to, the other folks in our states that can qualify. Again, it's not income, it's asset limits. And if we think about updating our asset limits to the cost of living, car repair or boiler repairs, to stay in their own home and be able to afford to be on Husky C with severe disabilities. I think we're going to get a different outcome this time. I really do. And that's just because that was crazy and not accurate. So I understand the motion to refer this to appropriations. I think we need a better economic analysis and fiscal note, honestly.
Thank you, Representative. I will just say also, just in general for this type of referral, if we direct a bill directly to appropriations, we will not get a fiscal note. But if we send it to the floor, then we get a fiscal note. Only the chairs will get access, I think, in the appropriations to an informal fiscal note. But that's just a practice. It's not in the rules. And so the public and the committee writ large won't get access to a formal fiscal note unless it hits the floor and gets on the calendar. Is there other discussion from members of the committee? Seeing none, the clerk will please call the roll on the motion to amend the motion.
Representative Gilchrist.
No.
Senator Lesser.
No.
Representative Case. Senator Perillo. Representative Comey.
No.
Senator Marr.
No.
Senator Anwar.
I think, well, I know for
No. Senator Anwar votes no.
Representative Butler.
Representative Butler votes no.
Representative Dathan.
Representative Dayton votes no.
Representative D'Amico.
D'Amico votes no.
Representative Fortier.
No.
Senator Gaston.
Senator Gaston votes no.
Representative Hughes.
No.
Representative Johnson.
No.
Representative Kit.
No.
Representative Mastro Francesco. Representative Meskers. Representative Pizzuto.
Yes.
Representative Santiago.
No.
Representative Scott.
Yes.
Representative Shake.
No.
Representative Stewart. Representative Vale.
Yes.
The roll call is complete.
Thank you, Madam Chair. Madam Chair. Madam Chair is
I've been promoted.
someone else. Thank you, Madam Clerk. Number 19 on the agenda, Senate Bill number.
Go for it.
It's been a long day, apparently. We have to vote on the bill, apparently. We have to no, we don't have to do any of those things. We have to get the tally.
Yes.
Clerk will please, thank you for bearing with me tonight. Clerk will please announce the tally.
5 yeas, 15 nays.
The motion fails. Any other discussion on the bill? Seeing no discussion, the clerk will please call the roll.
A motion has been made and seconded to JF SB 807. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Mar.
Senator Mar votes yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
I didn't see you on screen there, Representative. Could you
I'm
please?
so
go again?
sorry. Representative Dathan votes yes.
Thank you. Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston. Rep Hughes.
Yes.
Representative Johnson.
Yes.
Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. And as a reminder, we're keeping votes open. Moving on to number 19 on the agenda, Senate Bill number 805, an act requiring nursing homes to spend not less than 80% of revenues on direct patient care. Is there a motion?
Second.
Moved by Senator Mar, seconded by Senator Lesser. Yes, Representative Vale.
Thank you, Madam Chair. Again, I might understand the intention of the bill is to make sure we're not wasting money, be efficient, and that the money generated is going to direct care. I can appreciate the thought, but in reading testimony, the DSS commissioner says that this will also create unintended adverse consequences to the residents. And I think that's because it will take away from some of the other services. Again, everybody in here knows the ombudsman and uses, we value her judgment, people on both sides of the aisle very much. And her comments seem to be in opposition to this as not included in Connecticut's definition of direct care, laundry, housekeeping, social work, meal services. Other states may recognize that, we don't. And so if we're forcing a specific number, I think that's where her concern is that although this may be well-intentioned, there could be adverse consequences. And that if we're going to do any type of percentages, that they should be applied to more than just medical services alone. That certainly gives me pause. And I think if people want to be consistent with listening to certain people, then it should give you pause as well. And maybe there's a different way to do this and approach this, and pushing this hard line number through, I don't think is, again, though well-intentioned, is going to actually accomplish what we needed to. And I would go along with the experts on this one. Thank you.
Thank you, Representative. Representative Case.
Thank you, Madam Chair. I concur with my colleague. I concerned if we restrict and go 80% of their revenues. Like I said earlier on the private equity bill, these homes are aging. And if we don't do something, or if we do something like this, it's just going to more restrict and put projects on the back burner. I get it. The facilities take care of our most vulnerable people, our elderly, our veterans, our special needs. And to restrict how a business does this, I think there's other ways that DPH, who regulates how the homes are kept and how the care is given, really tying their hands. And I think you might see some that might not want to be here. I think those are the unintended consequences of we trying to strap how people can spend the dollars that they're getting, especially when some of these, like I said earlier, they're at a $218 a day. So 80% of that, I mean, you're giving them $20 or $30 to spend on the facility. Where does that do for the facility? Granted, the care is the most important thing that we need to worry about. But they need to have the facility to do the care in. I think there's other ways that we need to look at, as we will with the rates bill. I don't think this is a way of doing it. And through you, a question, so is this 80% for both private paid and state paid? Through you.
Senator Lesser. Need just a couple of seconds.
Through you, Madam Chair, it's not less than 80% of funding received from Medicaid, Medicare, and all other payment sources on direct care.
Representative Case.
So all other payment sources that includes private pay for you.
Senator Lesser.
Correct.
Representative Case.
Thank you. So that just, I mean, the money's from private pay, they're gonna, I don't know. It's not a good situation. I can't support this today. We need some more work on it. We need to get our nursing homes to where they need to be in a physical plant. We also need them to be taken care of. We've done some things to the nursing homes so that they have the hours of care was increased in the past couple years. This is something that I don't feel as though is the proper thing for us to do. If a nursing home isn't meeting the standards, then that's something that Department of Consumer Protection and or Commissioner of DSS needs to take up. And we have ombudsman to tell us what's going on within the home. So I can't support this today. Thank you.
Thank you, Representative. Representative Pizzuto.
Thank you, Madam Chair. You know, under a certificate of need process at a nursing home, they may say, yeah, that's great, 80%. But we also want to measure you on your cleanliness, food preparation, safety protocols and all that. If 20% isn't enough, what do? What suffers? I mean, they won't meet this need. So I would look at the certificate of need process unique to nursing homes and say, is this realistic? You know, just a comment. Thank you.
Thank you, Representative. Representative Vale.
Again, to who this may apply, were the nursing homes part of this conversation? Because maybe there's a way to, you know, have that conversation. Maybe there's things that would work, that would fit within that. But sometimes we just kind of take one side without listening to the other. So I was just curious if in developing these bills, if we had kind of brought everybody to the table and had the conversation.
Senator Lesser.
You know, Senator Looney introduced this bill. I can't speak to who he talked to before or after. I have no idea. Through you.
Thank you. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFSB 805. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar. Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Senator Anwar votes yes, sorry.
Representative
Representative Davis.
Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Yes.
Representative Johnson.
Yes.
Representative Kit. Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. Again, as a reminder, we're leaving votes open. Moving on to number 20 on the agenda, Senate Bill 806, an act expanding Medicaid coverage for treatment of certain emergency medical conditions. Do I have a motion?
So moved.
I'll second.
Moved by Representative Hughes, seconded by Representative Shake. Any questions or conversation?
I'll take it. So she's ready.
Representative Case.
Thank you, Madam Chair. So this requires Commissioner to expand emergency medical coverage. What emergency medical coverage do we have now for you?
Senator Lesser.
Thank you, Madam Chair. Madam Chair, I believe the emergency medical program is a program to provide Medicaid coverage for certain individuals who present at an emergency room.
Representative Case.
So through you, the emergency medical conditions, how is that funded through you?
Senator Lesser.
Through the Medicaid program.
Representative Case.
Through the Medicaid program. So if you are uninsured, is that what this program will help along as far as the emergency medical conditions?
Senator Lesser.
Through you, yes.
Representative Case.
Who in the state is covered under this bill as it's written through you?
Senator Lesser.
The uninsured.
Representative Case.
Okay, so all uninsured residents through you?
Senator Lesser.
No, you have to be income eligible. Through you.
Representative Case.
So through you, when we talk about income level, are undocumented policy covered through this through you? Do they have documentation of their income?
Senator Lesser.
My understanding is that yes, under certain circumstances, undocumented folks may be eligible in an emergency setting for a coverage through the federal Medicaid program.
Representative Case.
So I thought earlier it was for people who can have an income eligibility. So would we be able to know if somebody who was not documented with what their income eligibility is through you?
Senator Lesser.
There would be a determination made, yes. How that's made, I am not entirely sure of, but I know this is a provision that's required by federal law.
Representative Case.
Okay, I thank you for now. I know that we do have a program right now that is working fairly well. This one through you, I think, is just covering more than what we cover now. Is that correct?
Senator Lesser.
Yeah, we're trying to come up with our understanding is that this is done right now at a ad hoc basis, and this is trying to systematize it, come up with a real system so we understand how this program is working and try to reduce the administrative burden on the Department of Social Services.
Thank you, Mr. Chair. That's all I have for questions right now. I'll pass it.
Thank you. Representative Master Francesco, followed by Representative Pizzuto.
Thank you, Madam Chair. When you were having your conversation with Representative Case, you said that the emergency conditions for certain individuals. Can you describe what you meant by certain individuals for you?
Senator Lesser.
Yes, if you're uninsured and you present at a hospital under federal law, the hospital is required to treat you. So the question then is how do we compensate the hospital for the care that's provided? The Medicaid program is one option for doing that. And then there are a couple of ways to enroll people through the Medicaid program.
Representative Master Francesco.
Thank you. So when you go to the hospital for an emergency, they can't deny you coverage. They can't deny seeing you. Is that correct through you, Madam Chair?
Senator Lesser.
In many cases, yes.
Representative Master Francesco.
So in many cases, what do you mean by that? Are you saying that they can deny you treatment? Because you said in many cases, and I'm assuming that I'm thinking that there's some cases where they will not through you.
Senator Lesser.
I think it's a question about, I'm not entirely sure what the law is, but there is definitely a standard if you present and you want and you're in a totally stable condition and it is not a serious condition, I believe the hospital can turn you away. But they are required to stabilize you if you are in an emergent situation.
Representative Master Francesco.
Thank you. Yeah, I don't know any emergency room that would turn anybody away. For any, whether it's a serious health event or not. I haven't seen them teared away. So I guess what I'm trying to find out from really, so where did this bill come from? What is the actual purpose of it? Where did this generate from? Through you, Madam Chair.
Senator Lesser.
We actually just had a recent appropriations hearing that Representative Gilchrist and I were in just this week. This was after the bill was submitted, obviously. We just got a number that the state spends tens of millions of dollars on emergency Medicaid treatment, we're required to do by federal law. This is about reducing the administrative burden and figuring out if there are ways that we can simplify the program, have better understand it, and make it more predictable and understandable. For you.
Representative Master Francesco.
Thank you. Does this particular language that we have here, I know, have a price tag to it? We don't know what that is, but will it have a price tag to it? For you.
Senator Lesser.
There's a similar bill last year that I believe did have a fiscal note, and it was a one-time fiscal note that involved helping develop. It was a capital investment, I believe, for DSS. We were not able to find the funding last year. There wasn't a budget, but maybe we can find it this year for you.
Representative Master Francesco.
Thank you. So in the bill on lines 10 through 16, it's talking about the Commissioner of Social Services, they're going to expand emergency Medicaid coverage too. And then it talks about medical conditions. It says high risk pregnancy, diabetes, so forth, type 1. Renal failure, requiring ongoing dialysis and so forth. I guess what I'm not understanding in this bill is isn't this covered already? Are you saying that these services, if somebody went to the hospital or an emergency, would not be covered? Am I understanding that right?
Senator Lesser.
We don't think that they are, or they may not be. Obviously, there's a federal law, EMTALA, that does require them to treat many conditions, but we want to make sure that there's certainty that these, particularly important conditions are covered. And right now, as I mentioned, this is done as on an ad hoc basis, I think by hand, but some staffer at DSS, and that is a huge administrative burden on the agency that we're trying to simplify for you.
Representative Master Francesco.
Thank you. So we picked out these particular sicknesses, illnesses on top of what is already covered. Bless you. There are so many emergency situations out there that, you start going down the list here that you're picking out ones that I don't know where they came from and I don't know why. These particular ones were picked out. It couldn't be an endless list. I mean, endless. We all know what's out there. As I look on today's agenda, we did this is our 20th item we're looking at. Can you imagine today what the price tag is on this agenda today to the taxpayers? The price tag on the items that we voted on today. It is amazing how much money it would cost the taxpayers just for these items, just for today. It seems like we have no problem spending other people's money. I mean, that's just kind of the way I look at it. Some things are important, but we obviously need to prioritize our funding here. State of Connecticut is in jeopardy. We could be losing a lot of money from the federal government because the state of Connecticut will not comply with their requirements of what they want when they give us money, like requirements that we put on businesses and people. When we give them money, we have requirements and the federal government has requirements. If you don't want to comply with them, then you lose money. It's like we just did a bill with Medicaid. If you don't want to comply with these requirements, we're going to knock you off the program. It's no different than what's going on a federal level. So we're spending an awful lot of money today. And yes, some of this is probably necessary, but boy, I'll tell you, we have to be very careful. I don't know how these taxpayers in Connecticut can actually afford any of these things. And yeah, sometimes it's hard to say no. But we have to get our own financial house in order before we do a lot of these things. So I'm looking at this as that expanding Medicaid coverage for emergency medical conditions that I see that it's already covered. We're picking and choosing what kind of coverage, which sicknesses and which illnesses should be covered, which to me is not the right thing to do anyway. So I will not be supporting this today, Madam Chair, but I appreciate the dialogue. Thank you.
Thank you, Representative. Representative Pizzuto.
Thank you, Madam Chair. One of the items I noticed that they were covering under emergency medical conditions was psychiatric treatment. Quite often behavioral health. I know most of the hospitals I've dealt with, they deal with about 37 patients and they're maxed out. They have to divert them to another facility or a private pay critical care facility. If Medicare is used for that, is there a limitation? Another issue is quite often many illegal immigrants come in, the children have never had one day of medical or dental care. And so it's not a one shot, like you come in with a broken bone or a cut. Is there a limit? Again, to Representative Mester Vasesco, we're not opposed to taking care of anyone. Hospitals, the emergency rooms, Senator Lesser said the same thing. They'll take everybody. But that's sometimes a 1 or 2 shot deal. Behavioral health or maintaining children's health that have never had any could be an enormous expense. And so are we prepared for that when we ask for something like this?
So when you look to section 1 of the bill, it does put parameters. The care itself would only cover kind of that immediate need. It wouldn't be the long term.
Just because they say psychiatric treatment, I can't imagine one visit and you're cured, So I think we'd have to flesh that out more. Please, Senator.
Yep. Senator Lesser?
Yes, to the chair's point, she's absolutely right. So if you look in section 1, line 6, we're talking about where the absence of immediate medical attention could reasonably be expected to result in placing the patient's health in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of any bodily organ or part. So it's not just a general access to behavioral health care. We're talking about an emergency situation, and I think that language comes from federal law. So we're trying to mirror that, and yeah, we're not saying you should be able to go to an emergency room whenever you want to. We're also this is not about, nothing in the bill speaks to access to care. All of the care that's spoken to the bill is already required. This is a question about whether or not we're going to compensate the hospital and bringing in that federal match to pay for where we could get reimbursement.
Thank you.
Thank you, Representative. Representative Vale.
Thank you, Madam Chair. Again, kind of stay on point. Like lines 13, we start numbering off these different type of ailments that will qualify for this. And again, you said they're already covered. So I know it's been asked, but I must have missed it. Why do we have to name these things specifically in this legislation?
Senator Lesser.
It's really tough when you ask a question, I don't remember the answer to it. We did this last year. This is a duplicate from last year, and I'm struggling, Representative Vale. I was just trying to rack my brain as to how those specific conditions were identified. But what we were directed to do, I think this was another bill introduced by Senator Looney, was to maximize federal funding. We're trying to figure out, are we leaving funding on the table? And these were areas that we thought were not covered by the DSS program. We're not clearly covered, that we want to make sure we're covered.
Okay, just because if you look at the list, you would assume that those things are covered previously. So that's why I was just curious as to if that was the reason why we had to add them on or not.
I don't recall the specific reasons why they were delimited, other than I think the concern was that they might not be.
Okay. And so then we go to line 16, fracture of a bone in the skull, arm, neck, leg, spine, or pelvis occurring in the 2-month period prior to a request for emergency medical coverage. Does that only apply to section 5 there with the fractures, the 2-month period, or does that apply to 1 through 4 as well? And if that could be explained also. So what's 2-month period?
Senator Lesser.
I think the 2 months is where something stops being an emergent condition, right? If you have a chronic problem and your bone didn't heal properly, that's a different issue. And it's more of a chronic condition rather than an emergency condition where if you fall, you break your leg, you need to go see the emergency room right now.
So, so the 2-month part. So if I break, let's say I fracture my arm, does that mean maybe I choose not to go to the emergency room right away? Does that apply to the 2 months, or is it, I'm just trying to understand the 2-month period.
Senator Lesser.
Hopefully you will go to the emergency room if you break your arm. The issue is if folks have, it may require follow-up care if there's another issue.
Okay. And I see the hypertension, it talks about, blood pressure 180 degrees, or 180 degrees, 180. So I understand that, but section 7 in line 22, unstable seizure disorder characterized by at least 5 minutes of uncontrollable seizures. Again, how is that determined? Is that some type of medical standard? And if someone were to have 4 minutes of uncontrollable seizures, I can't imagine that they're going to get kicked out of, so I'll let you answer that first.
Senator Lesser.
I believe that definition through you, Madam Chair, and I'm in deep trouble of practicing medicine without a license, is something called status epilepticus, which is a medical condition that has that definition. And so that is like a particularly concerning condition. And so that's why we wanted to make sure that that was particularly treated through you.
Okay. And again, I guess that's put in there because it has a definition, but I can't imagine. Does this apply to like walk-in clinics, emergency rooms, everything, or just anything that's covered by Medicaid that would be an emergency care facility?
Just give 1 second. Senator Lesser.
I think the criteria would be set in federal law, so it would be to the extent permitted by federal law. Our understanding is that this is typically done in emergency rooms. I'm just not sure at this point whether that under federal law there is a potential to do this outside of an emergency setting, but I'm only aware of emergency settings being that place. Great.
Okay. All right. That's all I got. Thank you.
Thank you. Anyone else? Questions or comments? All right. Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFSB 806. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey. Senator Marr.
Senator Marr votes yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Yes.
Representative Johnson. Representative Kitt.
Yes.
Representative Master Francesco. Representative Meskers. Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. We will continue to hold the votes open. Moving on to number 21 on the agenda, Senate Bill 1470, an act concerning Medicaid reimbursement for community health worker services. Is there a motion?
Second.
Moved by Senator Marr, seconded by Representative Hughes. This committee passed Medicaid reimbursement for community health workers some years back, but it is slow to be fully implemented. And so all the bill you have before you does is require 2 reports annually in an attempt to try and move this program along here in the state. Any questions or comments? Representative Master Francesco. Thank you, Madam Chair. So have they submitted any reports thus far? Because I think you said that the program didn't get off. It did not take off yet. That the bill originally was to do 1 report annually. Have we received anything? That's a good question. I'm going to turn to the bipartisan staff to see, or nonpartisan staff to see if they know if we have received. There's a lot of reports. Thank you.
Yes.
Thank you.
We believe they issued 1 report, but I can verify that for you if you like.
So so through you, Madam Chair, they submitted 1 report, and this took effect when, Madam Chair? I guess what I'm saying is, are they up to date with their reporting? And when was that report submitted?
We will look into it and
Yeah.
find that answer for you.
Okay, so
I
we don't, so
do-
we're asking, I just want to make sure you were asking them now to submit it semi-annually, right? Twice a year. have they been up to date submitting it annually? And what did that report say?
So I will direct you, if we look at line 29 in the bill, it does, what we're taking out is not later than January 1st, 2024. So again, we will get further clarification, but it would be my understanding that the first report would have been due January 1st, 2024.
Okay, so,
Oh, we have some info.
okay.
They did submit their report. It was submitted, we received it in March. The date of the report is January 2024.
So we just received the report this month?
2024.
Oh,
one
in
year.
2024, okay. Through you, Madam Chair, was that report to the Committee of Cognizance, to the Human Services?
I would assume yes, but since we've got it open over there, let's check with,
Yes, the report was distributed to Human Services.
thank you.
Okay, so, I know we get a lot of reports, but listen, I'm the minority here on we're in the minority, our team, so what I say, I don't know if it really matters, but did this committee review that report and take any action on it? So as I'm saying, if the report was annual, was there anything in that report that would concern us that we would have to make them submit that report by semi-annual? Through you, Madam Chair.
This is the action from that because we're seeing that in the state, they are not implementing it at a rate we deem appropriate. So this is now attempting to get a report twice annually so that we can better understand their compliance and kind of keep a better handle on it instead of waiting an entire year.
Okay, thank you. So if they are not implementing what? I guess I just want a clarification on through you, Madam Chair.
The Medicaid reimbursement of community health workers.
Okay. So if they are not, I guess my point is why do they have to submit? And I'm not defending them by no means, trust me. But why do they need to submit a report, another report to get them to kick it off? I mean, why don't we just call them and ask them? Why do we got to put it into law?
We have had discussions and we're told it's in progress. So we,
Okay, so I get it. It's in progress, but putting it here on a piece of paper isn't going to change anything. Because we haven't had any answers thus far. So just putting it into law, into statute, is not going to change the outcome. A matter of fact, in this state, we have a lot of things in statute that never change the outcome. So that is my concern. I don't think it's a bad thing, to be quite honest with you, to have them submit it twice a year. I guess I'm just trying to point out that I don't know if it makes a difference. So I'm kind of on the fence, actually. I don't see it as a bad thing. I don't see it as a good thing. So I'm just kind of raising my concern. So I guess I don't know if anybody else has any questions, but I'll listen to the debate. Thank you, Madam
great,
Chair.
thank you. Representative Bale.
Thank you. I'm gonna finish where you started because I'm staying on the same thing. So we had a report. The first report was due January 1st, 2024, and we received it, or someone received it in March of 2024. Is that correct?
Correct.
And so in the previous law, so then a new report would be due annually, correct? So I would assume then there was a second report due on January 1st, 2025.
Yes.
And have we received that report yet?
To the nonpartisan staff.
Not to our knowledge. I'm going to check if the statute authorizing this report is the same one we're discussing currently.
Thank you.
So again, I'm kind of in the same boat with Representative Master Francesco. Like I don't see the point. If they're having trouble getting us a report once a year, and I'm not sure what we actually did with the report when we got it, having them do it every 6 months, maybe they don't have the resources. Because I mean, a lot of these bills that have come up today, we're on the 21st on our agenda. We're adding more and more and more stuff to put on these commissioners' plate. And I'm not exactly sure if it's good or bad. They get paid a lot of money. They have a large staff. Certainly they may be able to get it done, or we're taking them away from doing more important things to do that. So I'm not sure whether this is a good idea or bad, but I don't even think we have enough data yet to change the law that we already passed, requiring them to do it once a year. So I just don't see the point in this, I guess. Thank you.
Thank you, Representative. Any other? Yes, Representative Case.
Thank you, Madam Chair. I think, and I know staff is looking for it, but we haven't gotten January 2025s. If we can't get a report annually, how are we gonna get one biannually? I mean, I think the staff is crimped totally. I mean, I think we should try to enforce what we're doing now. That would just be me, and maybe have a discussion with the commissioner, but do we have anything yet for 2025?
I don't, not that I've received, but I'm still looking.
So we're in March. It was due January 1st, 2025. Last year, we received it in March of 2024. So we're lagging a little behind. Do we think we're gonna get it twice a year? If we don't, not getting it once a year? Just asking for you.
The hope is that this illustrates that we really want them to implement it.
We can't impose penalties on our own DSS department, can we? Or does that go to judish?
Are you suggesting an amendment?
I'll give me do a referral. No, I, as I say before, our DSS and our commissioner, I mean, they have a lot on their plate. They have a lot of things that they're working on. I'm sure there's an explanation. I'm sure there's something going on. I think we need to investigate it further with them and see where the reporting is. This is a tough one for me because I know that office and that agency, as we all talk about all the time, they have a lot on their plate. And we need people to be working together here. Because our most vulnerable population deserves it, and our people in the agencies that cover our most vulnerable in the catchment agencies, we need to have them here to work together in the office. So I think we can be more productive and we can get these reports going. I think there's a lot floating out there that is just, it's imperative that we get our reports, is what I'm saying. But by adding another report, that flag almost fell twice today. It wasn't you, Robin, this time. So anyways, I don't know if asking for double the amount of reporting is the thing to do, or to go after and see why we don't have this. So I'll wait to see how, I know how you're gonna vote.
Well, I would just, in looking back and now having the, for those of us who were on the committee in 2023, the conversation around community health workers has been going on for some time now. And they are a very important role in the healthcare system, and can connect folks to resources, including food, housing, and transportation that can have, long-term preventative health impacts and savings. So it's frustrating, that we haven't been able to get this program up and running.
I honestly, I did not look at her testimony. I know she came the other day and she said she couldn't answer all the bills, but did she testify on this? I'm not on the reporting.
I am pretty sure it'd be in there because they really do respond to everything. Yeah.
We located the 2025 report. They did submit one for January 2025.
Thank you.
Yeah.
Boy, it shows how good we look for
Good
reports.
news.
Okay, so I guess we'll move forward and see what you want to do. I think if they're complying, we need to look at the report and see what we need to do an action on. Maybe once a year isn't enough. Maybe we need to act on it twice a year, because there's a lot of information that we need to get for this this population of workers.
Thank you, Representative. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFSB 1470. Representative Gilchrist.
Yes.
Senator Lesser. Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
I didn't see you on screen. Would you please repeat?
I'm so sorry. Representative Dathan votes yes.
Thank you. Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Yes.
Representative Johnson. Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers.
Representative Meskers votes yes.
Representative Pizzuto.
Yes.
Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. Moving on, we're going to go to number 22 on the agenda, Senate Bill number 11, an act concerning prescription drug access and affordability. Entertain a motion to JF to the floor. Is there a motion?
Second.
Motion by Representative Gilchrist, second by Representative Hughes. Is there discussion? Seeing none, the clerk will please call down. Oh, I almost got away with it. Representative. Who wants to go first? We normally I see lots of folks signaling, but by custom, we usually give an opportunity for the ranking members to speak if they prefer. And if they don't, that's fine. Senator Perillo.
Thank you. I appreciate it. There's a lot here, as you well know.
I was hopeful we would just go on consent, but
yeah, I considered it. So if we could start out just with sections 1 through 3, I'd like to get a handle on the intent and the approach of, I assume the intent here is to not control, that's not fair, to tamp down pricing. How do we, there's a lot here. How do we expect this to work? If indeed that is the desired goal.
yes, that is the desired goal, to lower the price of prescription drugs in Connecticut. So it's to adopt reference prices, and they will be the and to adopt a penalty for manufacturers or distributors that exceed the reference price.
Okay, so thank you, sir. I appreciate that. So by exceed the so this would be the reference price is in any state?
No, it just in Connecticut.
Just in Connecticut. Okay. And that's the wholesale price. Is that correct?
It's the wholesale acquisition cost.
Got it. Okay. Now, but what? I'm just trying to. I'm thinking about situations we've seen these very often. What if there's a shortage of the product? What if there's a shortage of the drug?
This section does not speak to shortages. There are other sections of the bill that do speak to shortages. If you're asking about sections 1 to 3, or you're talking about
1 to 3? 1 to 3. Thank you.
So sections 1 to 3 is really about when prescription drugs exceed at a level that exceeds CPI. So it's about unjustified price increases.
Yeah. Yes. No, I understand that. And completely.
I'm sorry, you're asking, yes, there is language in section 2, subsection, section 2A2, that allows manufacturers and distributors to sell at a higher price if the Department of Health and Human Services has determined that there's a shortage.
That's
Sorry about that. I'm a little slow tonight.
No, thank you. And so that's USHHS.
Correct.
Got it. Understood. What happens if what happens if that actually happens? What happens if there is a sale beyond the reference price?
There's a civil penalty. And there's a formula for the penalty. It's 80% of the revenue from selling the prescription drug minus the revenue they would have earned if they sold it at the reference price adjusted for inflation.
Okay, so there'd be a penalty of that. You said 80% of the revenue?
80% of the difference.
Of the difference.
And then there's also an exclusion of small manufacturers, distributors. There's a de minimis exclusion of under $250,000 in sales.
Okay. Now, so who would be fined? It would be the company that would be fined, but I know there are some penalties in here for actual individuals who work within the company. Is that correct? Or am I could be misreading, but that's kind of what I pick up.
This covers pharmaceutical manufacturers and wholesale distributors. And so those are defined as a person or partnership who manufactures a prescription drugs and sells directly through or another person the drug for distribution in the state. And a wholesale distributor includes a repacker, an own label distributor, a private label distributor, or an independent wholesale drug trader, and anybody else who distributes a wholesale prescription drug.
No, and I appreciate. I thank you. So the penalty is levied, and the penalty isn't paid. Then I see in here that there could be fines or even imprisonment for officers or employees of the manufacturer or distributor who fail to pay the civil penalty. So or file statements, keep records. So how would we determine who was responsible for the failed payment? And who would determine it?
Well, DCP would be responsible for collecting the penalty. But there's a statement that would be filed with the revenue commissioner.
Oh, okay. So then the penalty is levied by the Department of Consumer Protection. But the Department of Revenue Services is given the task of collecting it. And then would DRS then determine whether or not specific officers or employees within the company should be penalized if the payment of the original fine were not made? I'm just trying to figure out who's responsible for what.
Well, the manufacturer distributors can apply for a hearing with the DRS commissioner, and then there's a whole procedure about that.
So they would a hearing. Thank you, sir. I appreciate it. So a hearing to do what?
So manufacturer or distributor can apply for a hearing to the Department of Revenue Services Commissioner in writing within 60 days after getting a notice of a civil penalty, explaining why DRS should grant a hearing and why they are not liable for the civil penalty in full or in part. And then the DRS Commissioner shall promptly consider applications and may grant a hearing, noting the manufacturer or distributor of the hearing time, date, location. They can deny a hearing. There's an appeals process. If they're aggrieved, they can appeal to Superior Court in New Britain. And so there's this whole process set forward in the law. And then it allows, there's a administrative process spelled out about what questions can be asked and how the DRS commissioner can get information about compliance with the law.
Got it. No, thank you. I appreciate that. It's that particular section is kind of involved. So I just want to make sure I understand what I'm voting on. I'm going to stop. Fair warning, I may have more questions as we move through this. I will try not to. But thank you. I appreciate the answers to the questions.
You're welcome, Senator. Other questions? Representative Case.
Thank you. Thank you, Mr. Chair. Thank you, Senator Perlow, for going through portions of that. This is quite a big bill. And I think some of the things that I take seriously is what we do in this committee, and we go through bills and we vote on them. My concern is, why are we voting on them twice? And I guess this bill contains a lot of bills that we've already discussed. I don't know if it's an avenue to put stuff out there twice, or to try to figure out how we can get them voted on, a couple of times. I don't know if it makes a difference out on the floor, or whether it's the House or the Senate. But with that said, I guess, I'd like to call a few amendments, and the first amendment would be, LCO 6369. If the clerk has that, can she please pass it around?
Madam Clerk, I have a question. We have members who are online. There's been printed language that's been distributed to members in the room, but I've had an inquiry from members online if they could see the language. I don't know what the procedure is for doing that.
I do not have an electronic copy of the language. We could read it.
Yeah, we will certainly read it for the members online, but I'm not sure if there's a way to I don't think there's a process for distributing it to them. Representative Case, you've made a motion. Do you want to?
Basically, yes, sir. So the bill LCO 6389 is basically amendment, the amendment in front of us is quite mirroring SB 807. And this amendment will, out of SB 11, strike section 9, which is to redesignate the renaming sections accordingly. So by striking section 9, we've already voted on SB 807. That language doesn't need to be in this bill. It just eliminates it from SB 11. It's already been voted on by this committee, so it'll be voted out of this committee probably about 40 minutes ago. With that, I move for adoption and be taken by roll.
Motion made by Representative Case, second by Representative Mastro Francesco. And you just said a couple of things. I just want to be clear. You're talking about LCO 6369.
Oh, I'm sorry. LCO 6369. Yes.
Okay,
Sorry.
just wanted to clarify that. 'Cause I heard some stuff. Okay, so and I just want to be clear for folks online that the language that was handed out, the amendment simply strikes section 9 and redesignates the remaining sections accordingly. Is there discussion? Senator Perla.
Thank you, Senator. I appreciate that. So I want to understand first of all, I'd love to know why the language in this bill is exactly the same as language from another bill. That doesn't make sense to me. I'll get there though. So, but to the proponent of the amendment, why specifically are you concerned that the language is repeated? Is there a concern that perhaps by passing two bills with the same language that we could cause problems down the road in terms of the legislative process? Because I would be concerned about that, but I'm curious about your opinion.
Absolutely. The legislative process through you, through you, Mr. Chair. Through you, Mr. Chair.
Yes, absolutely. I apologize. Yes, Representative Case. Representative Case, prepare yourself.
So through you, Mr.
To the
Chair,
proponent of the amendment.
Yes, to good Senator Perillo here. Yes, that is exactly. We have a process here. Bills go by bills, and this is going from one Senate bill to another Senate bill. We've already passed Senate Bill 806. Actually, this one isn't 806. This one is 807. And we're passing the same language in Senate Bill 11. So we're passing the same language twice within the same committee on the same night. It's a process. It's not right. I'd like to remove it from Senate Bill 11 and have one bill going out that we can all work on and get across the finish line. Because if we fix something in 807, how does it get fixed in Senate Bill 11? Through you.
Senator Perillo?
Thank you. And I thank the gentleman for his answer to the question. I thank you, sir. So you actually make a very good point. And it's not even what I was thinking of. So if at some point in time we amended Section 9 in this bill, and this bill passed with that amended language, yet we passed the other bill without amending the language, now we've got a problem on our hands. So, I mean, this seems like an easy one. You just pull the language out of this. We've got the other bill. We passed it. We know you can get it out of, we know the majority can get it out of committee. So that's not a question. It's out already. No, good point. So I guess I'll ask sort of the obvious question. And I guess I would ask the proponent, the chair, whatever. Why did we do this?
It's a good question. I'm not sure. Well, I could be a stickler. I'm happy to answer that question. It is important to my caucus, which put this forward, that we do something to help Husky C beneficiaries. And the way to do that is by adjusting, lifting, or eliminating the asset limits that restrict access to the Husky C program. And as you know, because you've been in this building a long time, there's oftentimes people are trying to come up with a good legislative strategy to get something done. And so in this case, there's a standalone bill, but there's also the hope that perhaps this could be tackled as part of a larger caucus priority bill. And I think it's obvious because the individual bill was introduced by Senator Looney. This is particularly important to Senator Looney. And so he went to the Senate Democratic Caucus and made an argument that this bill should be part of our caucus priorities. And that's why it's in here today.
No, understandable. And Senator Looney certainly has the right to do that and the ability to do that. And I understand that. I mean, look, at the end of the day, this bill's got what, 31 sections? It just really bothers me when we do that. A bill this big, stuff gets lost. I've seen it happen a million times. Plus, at the end of the day, I know on this side of the aisle, there are probably things in here that we absolutely love. I know there are things that we really don't like. So at the end, we're going to end up voting one way or the other and being unhappy with the result. And, there may be individuals on the other side of the aisle who feel the same way, perhaps in reverse, but they feel the same way. I wish we could do these things differently. Even if, look, I know it's a lot, even if there were 31 bills, we would at least be able to vote up or down on the things we like or don't like. So in that spirit, I would support the gentleman's amendment, and I would urge adoption as well.
Thank you, Senator. Other discussion on the amendment? Representative Messers.
Just to ask for clarity from the chair. Is it whether or not to amend, or can I discuss the content of the prescription drug access and affordability, since I wasn't here prior to this?
So we have an amendment before us, Representative, that is to strike Section 9. So if you could speak to that amendment, after the amendment is voted on, you certainly are welcome to speak on the balance.
Well, then it would be my intention to vote the amendment down, because I'd like to comment on improvements, I think, on the prescription drug access.
You're absolutely welcome to do that. Let's do one thing at a time, though.
Okay, thank you.
Representative Case.
Thank you, Mr. Chair and Representative Maskers. I appreciate that, but we already voted out that bill. And that bill has language in it. And I'm just saying if we amend SB 807, which is the prescription drug access and affordability, that exact language is in SB 11. If we do any changes to SB 11 in section 9 and we vote out, which 807 already got passed out of this committee like 40 minutes ago, we have two of the same bills. The same language in a standalone is in SB 11. So we can amend language in 807 if we want to, or we can amend language in SB 11. Let's say S 807 passes, but the language we adjusted was in SB 11 and SB 11 doesn't pass. We have the same language in two bills. Through you.
Mr. Speaker, if I might,
Representative Masters.
I appreciate the difference in your legislative intent. I wasn't here to comment on the first passage and I want to register my concerns so that when the reconciliation happens between the prescription bills, my concerns, I'm not looking for an amendment. I'm looking to address some of the concerns in intent so that the drafters of the bill will hear my concerns. So I'm looking to speak to it. My problem is if I strike it now, I'm not speaking to it because the vote has already happened. I can only speak with the vote. That's why. That's why I'm going to vote no on the amendment, because I do want to bring it up. I missed the commentary when the bill was raised, 807.
Thank you, Representative. Other discussion on the amendment? Seeing no discussion, the clerk will please call the roll.
Representative Gilchrist,
No.
Senator Lesser,
No.
Representative Case, Senator Perillo, Representative Comey,
No.
Senator Marr,
No.
Senator Anwar, Senator Anwar, Representative Butler,
Representative Butler votes no.
Representative Dathan,
Representative Dathan votes no.
Representative D'Amico,
D'Amico votes no.
Representative Fortier,
No.
Senator Gaston, Senator Anwar.
He's there.
Senator votes no. Thank you.
There he is.
You heard me, Senator.
Senator Anwar,
Yeah. Senator Anwar votes no.
Oh.
No.
All right, we will come back to you,
I
Senator.
vote no.
Representative Hughes.
Yes.
Oh,
I
boy.
mean, no. No. Sorry.
Representative Johnson.
No.
Representative Kit.
No.
Representative Master Francesco. Thank you. Representative Meskers.
No.
Representative Pizzuto.
Yes.
Representative Santiago.
No.
Representative Scott. Representative Shake.
No.
Representative Stewart. And Representative Vale.
Yes.
And Senator Anwar still votes no. I don't know if you can hear me.
I can hear you now, Senator. Thank
Okay,
you.
thank you, thank you.
Senator Gaston.
Senator Gaston votes no.
Thank you. The roll call is complete.
The clerk will announce the tally.
Five yeas, 16 nays.
The amendment fails. Is there discussion? Senator Perillo.
Thank you, Senator. And I appreciate the opportunity to speak for a second time. I had kind of left off at section 3 and had a chance to go through section 4. So I want to understand this. So I believe in section 4, we are directing the Yukon Health Center to negotiate pricing for other agencies and departments within the state of Connecticut that would purchase pharmaceuticals. Is that correct?
Correct.
Thank you. I appreciate that. So that section, that subsection of section 4 goes into effect July 1st of this year. On September 1st, just 2 months later, the director of the Yukon Health Center, is supposed to report back telling us how things have gone. So what are they going to figure out in 2 months?
Good question. This recommendation actually came out of a report that I believe the governor's office commissioned from the comptroller, looking at bulk purchasing across state agencies. And this was one of the recommendations of the report, was that it didn't make sense for all agencies, but it did make sense for the specific agencies outlined here and through Yukon Health rather than the comptroller's office. And there are a number of reasons for that. But because this is already a recommendation that's out there, we think it could be stood up fairly quickly. If in the balance of the session, we hear clearly from Yukon that time is not achievable, I think we could adjust the date, but we do think this could happen very quickly. Senator Pearl?
Oh, thank you, Senator. I appreciate that. I'm not sure that we can adjust the date. This is a shall that we're going to pass before July 1st. We would actually have to come back in to special session to change the date. Yukon Health Center doesn't have any flexibility to use a different date, and we don't have any flexibility after this bill is passed and signed into law by the governor to offer them a second date. So might we want to reconsider that date? I'm just concerned, and I get it. I understand we want the information back. I completely agree with that. I'm just concerned that honestly we're going to get a lousy report because there's not enough time to generate one.
It's a good question, and I don't have a perfectly satisfactory answer. We think this is a doable time just because of a lot of the legwork has already been done. But if we're not voting, this is not becoming law tonight. This is simply getting out of committee tonight, and we'll have to go through. I'm sure we'll discuss this at least a couple other committees before it would be voted on by our chamber and then the House. And so, if during any of that we hear from Yukon that this date really needs to be adjusted, we'll have some questions for them. We have not talked to them in a while, and when we do, we will ask them, that question and see if that date needs to be adjusted. I think for the purposes of tonight, the date will work because we do think, based on the comptroller's report, that this is a pretty simple thing for them to do. And if we hear that it's not, we can adjust.
Thank you, Senator. So there is willingness to move on this if we get feedback that it's not feasible.
Absolutely.
Thank you. I appreciate that, because I know some things are non-negotiable. It sounds like this one is. Okay. Moving on to Section 5, and forgive me because I don't have the history on this. What was the impetus for the use of maximum fair prices, and then subsequently working with other states to generate pricing? I just did that come from somewhere? Was that is that already done in other states? How do we get here?
Yes, this comes out of efforts that have happened in other states, and specifically would point the committee to efforts in Colorado and Oregon and Washington and Maryland and Maine, and perhaps other states in addition to those. And what those states have tried to do is to use this metric to control excessive prices for prescription drugs, to sort of determine what a maximum fair price could be in their state. To my knowledge, none of them have implemented the law, but they are working to do so expeditiously. And the innovation that Connecticut is making, which other states have not done, is to say, as much as this is something that maybe Colorado can do within its borders, drug prices are really a national problem. And so maybe there's a role here for interstate cooperation, because little Connecticut has limited as limited economic clout. And so if we work together across multiple states, it's possible that we can have more clout and it can be more feasible. Because if we were to just say to a big drug company, we think your excessive prices, the concern, and I think a justified concern, is that the drug company could threaten to shut us off. And that's obviously not what anybody is trying to do here.
We are small but mighty here in Connecticut. Thank you, Senator. I appreciate that. And that makes sense to me. And I'm looking at Section 16 or Section 6. I don't have a question. I do have a comment. So we are in this section establishing a prescription drug affordability council to advise the executive director of the Yukon Health Center and drug purchasing agencies on negotiations. So back to my previous question about the timing of the report, the odds of us actually forming this council within 2 months is zero. There's no chance we're going to have this council put together by the date the report is due. I'll be shocked if we have it done by New Year's, to be quite honest with you. So again, because that section and that timing is negotiable, I would just ask that the chairs consider that, and as this moves forward. I think we need to consider it. Moving on to section 7 of the bill, regarding nursing home rate setting. Can someone, perhaps the senator, explain to me exactly what this is doing?
Yes, it requires that nursing homes spend 80% of their funding from Medicare, Medicaid, and other sources on direct patient care.
Thank you. I appreciate that. So how would DSS get this information to make the determination about 80%?
I apologize, Senator. I have a lot of notes in front of me, and I'm just trying to pull up the correct ones.
It's better than pulling the incorrect ones. Thank you, Senator.
As I want to get you an accurate answer. I don't see that spelled out in the bill, but I think it would be through their cost reports.
Thank you. So it would be the cost reports that are already provided. So we're not asking that nursing homes submit an additional report.
I don't believe so.
Okay, understood. Thank you. And that's fair. Don't have to have all the answers. So that 80%, who determines, or how would we determine, how would DSS determine what is actually direct patient care?
Hands-on care provided to a facility resident by nursing personnel that includes but is not limited to assistance with feeding, bathing, toileting, dressing, lifting or moving residents, medication, administration and salary, fringe benefits and supplies related to direct care. And that is a definition. And it only applies to, nursing personnel, which has its own definition.
So thank you. I appreciate it. So it's just staffing, doesn't include durable medical equipment, supplies, pharmaceuticals, all the other things beyond staffing that you need for direct patient care.
Well, no, because it includes hands-on care provided to a facility resident by nursing personnel. So it's the direct care, I think, would include medical supplies, et cetera, that are provided. And it includes fringe benefits and supplies, it specifically says on line 559.
Thank you. I see. Okay. Supplies related to direct care. Okay. Thank you. I appreciate that. I guess I'm a little bit concerned. Look, I want as much, I want every penny going to patient care. I don't know how we are going to be able to manage that. And I'm wondering, that's how we're going to be able to manage it. I'm wondering whether we should be making those decisions. And I'm just also wondering, and in fairness, I don't know the current review process that goes into the cost reports and the evaluation of them. I know there's already consideration of how money is spent, what costs are allowable. I get that. So I'm just wondering, how is this different than that process?
Right now, we don't have a restriction on what percentage of patient care of dollars go towards patient care, and this would be seeking to create one. So it's no, so I think that's the purpose of this language.
Understood. Thank you. What would happen if a nursing home spent less than 80% on direct patient care? What's the penalty, outcome, result, action to be taken?
The commissioner may decrease Medicaid rates as a penalty.
Understood. I apologize. Can you just, sir, can you just point me to where that is?
Line 553.
Got it. Thank you. I appreciate that. If we could move to, I appreciate those answers, sir. If we can move to section 8, emergency, I feel like we've talked about this before. So a question for you, Senator, is this language in another bill?
Yes, sir.
And
This is the same language that we just saw in Senate Bill 806.
Got it. Okay. Understood. Thank you. I appreciate that. If we could move into section 12. This is stop loss. Could the senator sort of walk me through what this does and the desired impact?
Section 12 does two things, and it is designed to respond to a change in the insurance marketplace for small employers. It is designed to stabilize a death spiral that has resulted in small employers self-insuring rather than participating in the small insurance market. And so it would require that stop loss insurance policies associated with ERISA plans, that the stop loss policies provide essential health benefits required under the federal ACA and the group state mandated coverage requirements under state health insurance laws, or have a minimum attachment point of at least $75,000 and an aggregate attachment point of at least $250,000.
Thank you, sir. Are there minimum attachment points and aggregate attachment points that exist right now?
Not in Connecticut, to my knowledge.
Okay. Thank you. So what do we expect the outcome to be to these self-insured employers if we implement these attachment points? Like what's the goal?
The goal is to save, to stop the death spiral in the small group market, as well as to ensure that employees of self-insured small businesses have access to essential health benefits.
Thank you, Senator. I appreciate that. You've mentioned the death spiral of self-insured plans twice. Could you please elaborate on that? I don't know what you're referring to.
So we've seen a decrease of participants in the small group fully insured marketplace. We've seen a number of insurance companies leave the market, and we're also seeing small businesses leaving the market and instead choosing to self-insure. And the problem with that is that it has led to a death spiral where the businesses that have remained in the market are higher cost and more expensive. And so that's made insurance more expensive and is leading to market failure. And so the question is, if we provide some consumer protections, we think we can stop that hemorrhaging and stabilize the marketplace.
Thank you, Senator. I appreciate that. So basically, let's just be intellectually honest. So basically, the intent here is to make it very, very difficult, if not impossible, for an employer to choose to be self-insured. That's what I'm hearing. Is that correct, sir?
I think the idea is to provide consumer protections around self-insurance. If the reason that small employers, I mean, we're talking about, in some cases, it could be a bodega. The smallest employers could potentially self-insure. I think we recognize that there's some real risk to companies doing that, and there's some sort of systemic risk to all of us if small businesses are doing that. And so what we're trying to do is to try to say that we understand that companies are price sensitive, but that that essential health benefits are essential by their definition, so they should be not doing that to avoid basic coverage, but that we're also trying to ensure that we're removing the disincentive for folks to leave the fully insured marketplace, because fully insured plans have vastly more protections for the public and for employees than self-insured plans do, particularly for these smallest companies. Obviously, self-insurance makes a ton of sense for large corporations. It's been existed for a long time. The state is a self-insured entity. There's nothing wrong with self-insurance, but it is a little dangerous for smallest employers.
Thank you, Senator. I appreciate that. In my experience, I've not seen really small employers pursue self-insured plans. I just, and maybe I'm missing something. Maybe there's a problem in the marketplace and in employers' choices that I'm not aware of. I suppose that's possible. I don't see that as the real intent here. I don't see this as a consumer protection issue. I see this as a way to tacitly force companies not to choose self-insurance as an option. I'm not questioning the intent. I'm questioning the outcome. And I think anytime you take choice, anytime I'll use the word meddle in the market, I think that's where we get ourselves into trouble. I think that at the end of the day, what we see here and will see here is a byproduct that will honestly drive the state towards a single payer system. And if that's what we want, we should just say that's what we want. But I kind of feel like this is a backdoor way to force that, and that's concerning. We should just call it what it is. And I don't think that's really what we're doing here. And I don't know. I wish we would just say what we're doing, because I don't see that here. I feel like we're posing this as something that's good for consumers, when in reality, I don't think that's the goal. I think the goal is to drive employers to a point where they can't be self-insured and drive them towards a single payer system, because at the end of the day, that's what a lot of people want. And that's concerning. And I don't think that's how we should function here. I don't think that's how we should do business. And quite honestly, I don't think that's how the residents of the state of Connecticut expect us to do business. Call it what it is. And that's really not what we're doing here. I've got a lot of questions. I really and truly do. But I know there are other folks who have questions too. And I don't want to take their time. God, there's just so much here. Good Lord. Can we talk a little bit about the Canadian prescription drug importation program? It sort of starts in section 27. I don't know the details of that, but I'd like to. Can the gentleman sort of give me a short walkthrough of what that program is and how this bill would impact it.
Yes. The bill requires the Consumer Protection Commissioner, within available appropriations, hire a consultant to study the feasibility of establishing a Canadian prescription drug importation program. And the purpose is of reducing prescription drug costs in the state, and that's both to the public, but also to the state's Medicaid program, which is obviously well within our cognizance here. The commissioner must report by October 1st, 2027, the results of the study to OPM and Appropriations, General Law, and Human Services Committees. And then it also, there's the bill also authors in section 29 authorizes the DCP commissioner to, with the consent of OPM, determine a Canadian prescription drug program is feasible to seek federal approval from the FDA. And it describes what the federal approval shall consist of and creates a approval process. And then it authorizes the importation under certain circumstances. It prohibits controlled substances, biologics, infused drugs, IV drugs, and inhaled drugs, and certain parenteral drugs. I'm not sure what a parenteral drug is, so please don't ask me about that. And it prohibits those from being included. And then there are various parts about complying with state and federal law. And then it also creates a track and trace process, because they know that the integrity of the Canadian drugs is something of particular concern to the Department of Consumer Protection as well as to Connecticut's pharmacies. And so we require full compliance with applicable track and trace requirements. We also have a drug safety testing component in section 33 that requires that we test. We actually have a testing firm in the state. And so all of that will hopefully provide some protections. We also have some emergency protections around public health in section 34 as well.
Thank you. That was a mouthful, and I appreciate it. Thank you, sir. Just if we could just talk about section 39, I would appreciate it. So this is related to the Vaccines and Related Biological Products Advisory Council. Could the senator please just walk me through again very briefly what section 39 is intended to do and why?
This is actually an interesting problem that we're hoping to address, which is to coordinate the manufacture of vaccines. And this is a problem that stems from the recent decision by the FDA to cancel a regular meeting by technical meeting by vaccine manufacturers. And so the concern is that that could limit the availability of seasonal vaccines in the United States. And so in consultation with the pharmaceutical industry, we thought that it might be helpful to play a convening role where we're helping these manufacturers come together to make sure that every season we are updating the vaccine so that we have continuity of supply in the United States. And Connecticut can play a role there. For minimal impact on us, we can make sure that the United States has access to seasonal flu vaccine and other critical supplies just by playing a convening role. They would be prohibited. These companies are typically prohibited from communicating with each other for antitrust reasons. And so if the FDA is not doing its job, we'll do their job for them.
Thank you, Senator. I appreciate that. I don't know. I feel like DPH is kind of already doing this. I'm not necessarily sure that this is necessary. Feels like, DPH, to their credit, has had a pretty good handle on this. I know they've been active and very involved in vaccines. I'll leave that. I do have one other section that I want to talk about, and that is section 24. I'm sorry to go backwards. This is and most specifically the section regarding rebates. I believe that's in here. Or is it the following section?
Point of order, Mr. Chairman. Could you please ask the good gentleman to cite the page and line number, not just the section, so we can follow along?
Thank you for that. We'll ask for clarity when the gentleman gets to the section, but we're not. I think he's looking up his notes. Line 785. Is that what we're? We'll let Senator Perillo ask the question when he's ready.
let's go. No, I'm sorry, I want to get it right. I appreciate the question because it's easy to get lost in this bill. It's very long. Got it. Okay. No, thank you for giving me time to do that. I appreciate it. There's actually two sections that reference rebate reporting. One is section 16, which starts at line 779. The other is section 25 that starts at line 1185. So
That is a good catch, Senator. That is a duplicate section, I believe. I
they're the same thing.
think it might be. At least that's my,
That
fear.
changes my question.
Okay.
My
Let me
question-
let me
just
double
right.
check before we delete, but I think that. The committee will stand at ease for a second.
In this bill, but
16 and 25. Yeah, they're exactly the word for word the same. It's already in the bill that we're gonna vote on next. That's where the confusion is gonna go by having things in both bills.
I feel like I'm insane. So I leave this place for like a month. You people don't pay attention either. I've been on this committee for like 5 minutes.
You just know that it's
Fresh set of eyes.
yeah, fresh set eyes. Section 16 and section 25. We're just, I get in trouble if I change Senate.
Okay, I'd like to call the committee back to order. We stepped aside for a moment because our eagle-eyed ranking member discovered that we in fact had a mistake in this bill, and that's actually, this is maybe for the benefit of our newer members. There are a lot of times when members on my side are inclined sometimes to exasperation or roll their eyes at a long debate, but it actually is, I think, very helpful for the process at times. It can really point out some problems with legislation and yield to better legislation. So I'm very grateful for the pointing out that we actually had 2 duplicate sections. And so because of that, at this point, I would like to make a motion to strike section 25 in its entirety and direct LCO to renumber the sections accordingly. I'd like to make the motion. Is there a second?
Second.
Seconded by Representative Gilchrist. Is there, but full credit goes to our ranking member. Is there discussion? Seeing no discussion, I'll entertain a voice vote. All in favor, say aye.
Aye.
Opposed? The motion passes. All right. With that, pass amendment. With that, is there additional discussion on the bill? Senator, yeah, on the bill. Yeah, Senator Pearl.
Just thank you. I appreciate that. In relation to, I think we're still in section 16. Just I want to understand, and again, I don't want to belabor, please, the rebate practices. Can you talk a little bit about? I'm concerned because I did read some testimony about the rebates, and I'm just worried that there will be a negative impact in terms of costs, specifically to the state of Connecticut, with some of this rebate language. So if the gentleman wouldn't mind just kind of walking me through the thought process here.
Yes, first of all, I appreciate the question. I will say that this language and several other sections actually come out of, while the whole bill does not come out of the bipartisan prescription drug task force, this language does. And it reflects conversations that we've had with the comptroller, which of course has a major PBM procurer, and also we've also talked to the Department of Social Services, which has a PBM for the Medicaid program. What we're trying to do is just ensure that when rebates are issued, that they're passed along and helped reduce the cost of prescription drugs.
Thank you, Senator. I appreciate it. So currently, where do the rebates go? My understanding is rebates go to the insured, and that there is a piece held by the PBM. Is that correct?
So no, the rebates go to the PBM. Well, actually, the rebates will go to the health carrier, but they'll be collected by the PBM.
So the rebate. So let's just take the state of Connecticut. So any rebates experienced in the state of Connecticut employee plan that are, negotiated, managed by the PBM, those rebates come back to the state of Connecticut. Is that correct?
Well, some of it goes to the state and some of it goes to the PBM.
Thank you. Understood. Do we know how much comes back to the state as opposed to how much goes to the PBM currently?
I don't think that I think that is a good question. We don't necessarily know that.
Okay, I remember. Thank you. I appreciate the answer. I recall from testimony, and I might be remembering poorly because I, wasn't on the committee yet, that number was north of like $200 million. That's real. And I worry that this section of the bill may have a bit of a chilling effect on whether or not PBMs want to even get involved in the state of Connecticut. I don't have any proof of that, but it's a concern. And I think we need to have a very good handle on how we are treating these rebates until we fully understand what the financial impact could be to the state of Connecticut. I don't feel like we have that understanding at this stage in the game. But I just think we need to, because I'm worried that there could be a very significant cost to the state as a result, not necessarily a direct result, but even an indirect result of Section 16. I just want that out there.
Thank you. And I certainly, we would, the whole point of the bill is to save money, to save taxpayers' money and save the public money. We've consulted with the comptroller, which of course is the gentleman who's procured this and his staff. And so we will continue to work with them to make sure we get this language right. But certainly the whole point of it is to save taxpayers' money and the public money. So if it's not doing that, then it's not doing its job. But that's what we think it will do. And obviously we will continue to talk to him and to others to make sure we get that language correct.
Thank you, sir. I appreciate it. I'm all set. I appreciate that.
Thank you, Senator. Other discussion on the bill, Representative Meskers.
Yeah, I have a couple of concerns on the bill. I want to start with the singling out of the distribution arm. I had the privilege, or I don't know if it was a privilege, got cornered by people in the distribution business, and I believe there are federally chartered distribution agents of the pharmaceuticals that receive a slight fee and transact the business back to back flat. And they're concerned they're being captured in the definitions of distribution agents, and they think they should be excluded. So I'm concerned about that. And I just flagged that for the committee. The second piece is, I think, while well-intentioned, the exploration of importing drugs from Canada should be focused on importing drug prices from Canada, because what we have is $2.25 to $2.75, or 3 times the price that the Canadians get for the same pharmaceuticals. And I think what we'll find when we import the pharmaceuticals, that voila, there is a shortage in Canada to supply, 360 million Americans with 36 million of Canadian drugs. They will limit that. So to that end, it's, as another suggestion, if we're going to pay for a consultant to study the feasibility of importing drugs from Canada, I think it would work to coordinate with the states, surrounding states, to see whether there is appetite and willingness for a manufacturing formulary so that we could actually produce drugs at a price akin to what goes on in Canada, because that is the real problem. I mean, the business model is, pharmaceutical industry will all say how much we love them, but they price their stock, their salaries, their profits on U.S. prices. The rest of the world gets a price that is 25, 30% or 50% of what we pay here. So we've got to figure out how to balance that act. And lastly, my biggest concern, and I'll alert the chair, I'll probably be voting no, is my concern about the stop loss. For me, the stop loss on the insurance policies has an impact for me as sitting on the insurance committee and on commerce, is that I think it's going to adversely impact franchisees who have group healthcare plans, because they'd have to customize the plan for their Connecticut residents. Or worse, it could convince the underwriters to move the business and the underwriting out of the state of Connecticut. So for me, I think the private insurance market with stop loss, I understand the concerns on the comprehensive coverage that some of the plans give, and that's, I think, what the intent is. But I'm worried that it will drive both innovation and both underwriting business and coverage out of my state. So we saw, I think, a similar bill in the insurance committee today, and I believe we struck the stop loss action. And with it in the bill, I'll probably be voting a no, just because my concerns on that side, that it's neither being referred to insurance, and it is an insurance product. And lastly, if I'm trying to improve the group market, I think while some of us on the committee may not be fans of the self-insured market, I think association healthcare plans are a way to bolster an alternative for the small business community. And I haven't seen that come through. Frankly, I don't think we've gotten it through the insurance committee either. But those are my thoughts on it. But I think there's a lot of good in the bill, so it pains me, but I think the issues for me, the sticking point is on the stop loss. The other ones I think are improvements that can happen through negotiations in terms of the importation or manufacturing of drugs and the distribution items. So I just raised those as concerns to be addressed, which is why I didn't want to amend and strike the issue on prescription drugs. I wanted to have that say, and just say that stop loss is my probably my no-go on this, but thank you.
Thank you, Representative. I just briefly responding to a couple of points you make. First of all, with respect to stop loss, I do think the language in the bill is significantly more modest than the effort that the New York State Department of Financial Services implemented in New York. So, because we are a region with a lot of businesses moving across state lines, in New York, they simply prohibit all small groups from purchasing stop loss insurance, period, because they're trying to do the same thing, which is to stabilize the small group market and also to protect small employers and the employees of small employers from some of the chaos that would happen if they self-insure. So New York and Connecticut are largely trying to do the same thing. We're trying to do it with a little bit more flexibility and a little more, we're not trying to outlaw it, but we are trying to impose some consumer protections on that. With respect to the supply chain issue about onshoring production, you're absolutely right. That is something that we should be doing. And I would point you to sections 37, 38 of the bill, which are really attempted to focus on drug shortages, but also explore partnerships with domestic manufacturers, including with DECD. There's a current supply chain initiative in DECD, and we're interested in potentially using that program to onshore production. We are exploring, in particular, a partnership with a federally recognized Indian tribe, and I think there's other things that we can do to onshore production. With respect to Canadian prices, you're absolutely right. Totally agree, and that's one of the things we're looking to do with the reference prices in that section as well. So we're certainly bringing in Canadian drugs, but if we can't, wonderful to bring in Canadian prices if that's in fact something that we can justify. And look forward to communicating with the Health Distribution Alliance to see if that's an issue that we can resolve. So I appreciate your concerns. A lot of them are valid, except I respectfully disagree about the stop loss because it's, more modest version of what New York has already done. Other conversations, Representative Vale, followed by Representative Pizzuto.
Thank you. Good questions by the two previous. Mine are a little bit more simple. On line 12, or 11 and 12, consumer price index means the consumer price index annual average for all urban consumers. What is urban consumers? Obviously I know what urban means, but what's the definition? Is there a certain population? Is it a certain density of population within an area? What is that?
So CPI for urban consumers is that there are a number of different inflationary calculations made by the federal government. This urban consumer is it's a measure of the average change over time, the prices paid by urban consumers for a market basket of consumer goods and services. And so it's for a variety of different areas. I think Connecticut under this is Connecticut all urban? Is a good question. Do our friends from the Office of Legislative Research? I see some squinting, but I don't know the. It's a very good question, Representative Vale.
It seems simple, but I wonder what the definition is, again, in comparison to what?
Yes, I live in Middletown. Is Middletown urban for CPI purposes?
I live in Stafford Springs, which I don't think too many people would consider urban, but we have a little area that's pretty densely populated. But again, compared to maybe Montana, it is considered. So that's where it's just a little ambiguous.
You have an answer.
The term urban in the CPI for urban consumers refers to areas around any city or town with a population of at least 10,000.
Okay. So one of my 4 towns was in there. Okay. All right. Okay. On line 354 talks about the Prescription Drug Affordability Council. Senator Perillo had touched on this, and I just want to dig in a little deeper. And we talked about how different agencies being led by UConn Medical or UConn Health, the executive director of Yukon Health will negotiate rates for several different agencies. And then they'll have a council that advises him or her specifically. So number one, to go back to that, why would we put that onus on the executive director of Yukon Health and not the comptroller's office, who might be more experienced in that?
Well, because I think it's harmonizing it with the bulk purchasing in the previous section, or subsequent section. But look, we're trying to figure out, as a state purchaser, can we use our purchasing clout? I actually think that Yukon purchases more drugs than the comptroller. I think that that's one answer.
Okay.
Overall.
And did they have an opinion on this? I didn't see one. So I might have missed that. I can certainly reach out. But then we give them that responsibility, and then we put a prescription drug affordability council together to advise them on how to do it. And the makeup of that committee, is 2 appointees by the speaker, 2 by the president pro temp, 1 by the majority leader of the House, 1 by the majority leader of the Senate, 1 by the minority leader of the House, 1 by the minority leader of the Senate, 1 from either the commissioner or one of their designees from the commissioner of OHS, DSS, the insurance commissioner, DCF, and there's 1 more on there, consumer protection. So I know in this state, I understand what party I'm in, but we're outnumbered about 2 to 1 in the legislature, not overall in the state. Yet this isn't the first time I talked about, it's the first time I talked about in there. That's an 11 Democrat appointees and only 2 Republican appointees. I don't think that is a fair ratio of things. That happens a lot. This isn't new, but I got to just bring attention to that, because I don't think our side gets heard as much on these committees as it should be. And I think, like you said earlier, sometimes we actually have some good ideas, or we bring things to light that might be helpful. So, and I certainly don't think, at least if it was more representation of our breakdown here in the capital, I think that would make more sense. So that's just me saying that. Maybe I don't know if you have an opinion on it or.
We certainly value minority representation on this and other task forces and boards. And while I won't support changes tonight, I'm happy to have a conversation going forward to ensure that it's a fair and adequate and appropriate distribution. We can have that conversation. I'm certainly open to that.
I appreciate it. And again, I certainly understand the makeup and I respect that. It's just still a little off. On line 545, I believe this is Senate Bill 805. Is that correct? And is it verbatim? I know we had an earlier amendment, Representative Case brought out. It wasn't this one. It was on another area where we talked about something we talked about earlier. So,
I believe it's verbatim,
okay.
but sure, LCO could speak to that better than I can. Yes, it's verbatim.
So if I may, I'd like to make an amendment to strike section 7 and redesignate the remaining sections accordingly.
Motion made by Representative Vale, seconded by Representative Mastro Francesco.
And can we please have a roll call vote, sir?
And when the vote be taken, Madam Clerk, we ask that it be taken by roll.
Is there an LCO number that should be read out?
67 or 6367.
Okay, Representative, do you have a copy of that? Would you
I
like
do.
to distribute to the committee? Oh, you've got that. Okay.
May I speak on, or
Yes, while
Okay.
our good chair is handing out the copies to the members, yes, you may certainly speak on that.
And again, to me, it's redundant. And I actually think there's other sections of this bill as well, which we'll focus on this amendment now. But just have concerns. It's redundant. I don't understand why it's necessary to do it twice. We've already debated this issue. So that's the reason why I hope my colleagues support the amendment. Thank you.
Thank you, Representative. Other members who wish to speak on this amendment? Seeing none, I will just say that, this section is important for a number of reasons, including ensuring that taxpayer funds are appropriately spent on patient care, and would urge members to reject the amendment. With that, the clerk will please take the roll.
Representative Gilchrist. Senator Lesser.
No.
Representative Case. Senator Perillo. Representative Comey. Senator Marr.
No.
Senator Moore.
Senator Anwar votes no.
Representative Butler.
Representative Butler votes no.
Representative Dathan.
Representative Dayton votes no.
Representative D'Amico.
D'Amico votes no.
Representative Fortier.
No.
Senator Gaston. Representative Hughes.
No.
Representative Johnson.
No.
Representative Kit.
No.
Representative Master Francesco. Representative Meskers. Representative Pizzuto. Representative Santiago.
Yes.
Representative Santiago.
Yes. Can you hear me?
I can hear you, Representative.
Okay,
How do
thank
wish to
you.
vote on the amendment?
Oh, I'm sorry, it's no. No on the amendment.
Representative Scott. Representative Shake.
No.
Representative Stewart. Representative Vale.
Yes.
And Senator Gaston.
Senator Gaston votes no.
The roll call is complete. Oh, Senator Perillo?
The clerk will please announce the tally.
It is 5 yeas, 16 nays.
Amendment fails. Is there further discussion on the bill?
I have more.
Representative Vale.
It's not much. Although I would like to say, I don't think our staff should be waiting to make sure people vote correctly. That's on them. So that's my 2 things. On line 718, we have an advisory committee to study cost effectiveness and strategic plans. There's patient advocates on it, pharmacists that use Medicare, and medical professionals. That's how a committee should be made up of people that understand multiple people on both sides of an issue. Maybe it doesn't have to be 2 sides of an issue, and they can find one. So that, again, I just wanted to draw attention to that. And I may be wrong on this, but lines 983 to 1015 and lines 1063 to lines 1095 are identical. Now, I'm not saying they might apply to 2 different things, and that may be why, but I just wanted for verification from you that they apply to 2 different statutes.
They do apply to 2. This time you didn't get me,
No,
Representative.
I wasn't trying to. I just wanted, yes.
No, as one refers to individual plans, the other to group plans.
Okay. I appreciate that. And then again, on line 1459, there's another task force that has the exact same breakdown as the earlier one with an 11-2 Democrat to Republican ratio. So I just wanted to draw attention to that. And I appreciate your indulgence. Thank you.
Thank you, Representative. Any other? Yes, Representative Pizzuto.
Thank you, Mr. Chairman. Under section 8, line 603 to 613, It states the commissioner shall establish an administrative system for persons to apply, quote, in advance, unquote, for emergency Medicaid coverage. The federal law I have in front of me says sudden onset, again, sudden onset is required for emergency Medicaid coverage. Therefore, requiring an administrative system to apply for coverage is not sudden onset. So, and that doesn't meet the intent of the law. So you can't apply in advance that you're going to get hurt and you need coverage. And that's per the Department of Health and Human Services federally. So again, in these line 603 to 613, they talk about establishing this administrative system. So I don't think the feds would honor that as far as Medicaid coverage goes. It's, yeah.
Thank you, Representative, for the comment. I didn't hear a question, but
Yeah, no, it's just a comment to say, I know what our intent is, but I don't think we can do it because the feds wouldn't support it, you know?
understood. I understand your
Yeah.
concern. Other questions or comments from members of the committee? Representative Mastro Francesco.
Thank you, Mr. Chairman. So this really is I'm going to say a monster bill. I've had a chance to sit here and review it a little bit. You know, there may be a couple things in here that are okay, but there's a lot of stuff in here that I really don't agree with. And I think it's going to really cause a problem, not only within the state of Connecticut, but for our consumers. I mean, if you think about everything that we talked about today with this bill, you know, this bill deals with bulk prices for drug purchasing agents, maximum fair price and with drugs as well, prescription drugs, it deals with affordability. It even goes as far as nursing home rate setting rates for nursing homes, emergency Medicaid and so forth. We talk about in this bill eliminating assets for Husky C. I mean, this is a large bill. Private insurance coverage of general anesthesia, Mr. Chairman, and that is in section 10 and 11. Would you be able to give me a little overview on what they mean by that?
Yes, so those sections prohibit individual and group health insurance policies sold in the state on or after January 1st, 2026 from imposing an arbitrary time limit on reimbursement for general anesthesia provided during medically necessary procedure, denying, reducing, terminating, or failing to provide reimbursement in whole or in part solely because the duration of the care exceeded a predetermined time limit determined by the insurer, and imposing unilateral arbitrary limits on reimbursement for medically necessary ancillary services. Requires an attending board certified anesthesiologist to determine medical necessity for administering general anesthesia during any medical procedure. And under existing law, medical necessity means healthcare services that a physician exercising prudent clinical judgment would provide to a patient for the purpose of preventing, evaluating, diagnosing, or treating an illness, injury, disease, or its symptoms, and that are in accordance with generally accepted standards of medical care, clinically appropriate, and not primarily for the convenience of the patient, physician, or other healthcare provider.
I mean, I was looking for an easy explanation for the public to understand. Yeah, but you're very thorough, I have to admit. So thank you for that.
Just wanted to make sure you got your answer, Representative.
Yeah. So again, this particular piece of the bill really should be in the insurance committee. There's a lot of little moving parts to this bill, right? That should actually go into other committees. But I got to tell you, one of the probably equally as disturbing as some other parts is section 12 of this bill, and it deals with the stop loss insurance. And I know, having been on town council in my town for many, many years, how important that stop loss insurance is to them. And right now it's at $20,000. And this bill particularly would put it at $75,000. It would devastate your towns that are self-insured, any businesses that are self-insured. They would not be able to afford it. We have received a lot of feedback on this, a lot of very, very much concern from our small businesses and from our towns on this one. This will absolutely make you think your taxes are high now. Wait till this happens. It's certainly going to make your taxes go up if your towns are self-insured. And it's basically putting small businesses out of the insurance market, and they will eventually close. This is a real bad section. Mr. Chairman, I would like to propose, and I don't have a amendment ready, but I'm going to do it verbally. And I'm going to make a motion that section 12 be removed from this bill.
Second.
And I would ask that it vote be taken by roll.
Okay, when the motion has been made and seconded to strike section 12, and a request has been made that it be that the vote be taken by roll. Is there discussion on the amendment? Representative Mastrofrancesco?
Thank you, Mr. Chairman. Yeah, I would just say that, listen, there's a lot of things in this bill that I don't agree with, but taking this part out will help a lot of people. It will help a lot of businesses. If we care about our businesses in town, our small businesses, our municipalities, taking this language out will help. I guess my question is, why? Why are we interfering with a contract between a small business and an insurance company? Who are we to make that decision for them? This is private insurance within a business, and the insurance company should be making these decisions. For some reason in this building, we feel that we can involve ourselves in private contracts, which obviously I don't agree with. So I would urge, if you want to do something right today, to vote for something to help a business today, vote yes to take this portion of this bill out of here. Thank you, Mr. Chairman.
Thank you, Representative Case.
Thank you, Mr. Chair, and I agree with the good representative from Wolcott. I mean, honestly, section 12 doesn't even have a purview to be in human services. This is totally an insurance bill. This is a decision that needs to be referred to the insurance committee. We don't have cognizance over this because it doesn't affect DSS. It's for private insured contracts. And I agree, it's protection, and it has to do with the employer benefit plan, but we don't do insurance in this committee. I don't understand why something having to do with insurance is put into a bill here. Just a comment, and I'll be voting for the amendment. Thank you.
Thank you. We'll just reiterate that this language is important to protect small businesses, to provide additional consumer protections, and it is a more modest version of something that New York State has already done in its longstanding law there. With that, I would urge my members all members, not my members, they don't work for me, to reject the amendment. And the clerk will please take the roll.
Representative Gilchrist.
No.
Senator Lesser.
No.
Representative Case. Senator Perillo. Representative Comey.
No.
Senator Marr.
No.
Senator Anwar.
Senator Anwar votes no.
Representative Butler.
Representative Butler votes no.
Representative Dathan.
Representative Dathan votes no.
Representative D'Amico.
D'Amico votes no.
Representative Fortier.
No.
Senator Gaston.
Senator Gaston votes no.
Representative Hughes.
No.
Representative Johnson.
No.
Representative Kit.
No.
Representative Mastrofrancesco. Representative Meskers.
Representative Maskers votes no.
Representative Pizzuto.
Yes.
Representative Santiago.
No.
Representative Scott. Representative Shake.
No.
Representative Stewart. And Representative Vale.
Yes.
The
Madam
roll-
Clerk, this is Senator Anwar. I wanted to make sure you got my vote.
I received it. Yes, thank you.
Thank you. Thank you.
The clerk will please announce the tally if the roll call is complete.
It is 5 yeas and 16 nays.
Amendment fails. Is there further discussion on the bill? Yes, Representative Mastrofrancesco.
Thank you, Mr. Chairman. It's unfortunate that that amendment did not pass. It just goes to show truly how political the environment is up here. We have members, even on this committee, who don't agree with that section of the bill, but yet we can't strike it out, which is unbelievable. That's the way it is here. When Republicans put amendments in, they're struck down by the majority. We get it. We go through this all the time. It's nothing new. It's unfortunate. So again, there's a section in here that deals with, I can't believe it's, what section is it? Senate Bill 806 that we've already voted on. Again, Mr. Chairman, that is in this bill. I was going to call an amendment on that to remove that, but I will save us from that. There's no use in it. We know that every amendment that we call is going to get struck down. So I think we've proven our point here today. The other section in here that I have concerns with is about the weight loss, the Ozempic, that we're paying for that. I've seen a lot of data or studies online about how bad actually Ozempic is when you're using it just for weight loss and is not for diabetes, people who don't really need it. So I have a lot of concerns with that section as well. This whole bill is really, I can't even imagine what the cost is. We don't know what the data with the financial implications of this bill are yet. Do we have any idea at all, Mr. Chairman?
With this bill and with all other bills, since this is not a money committee, we are a policy committee. So we will JF the bill. It'll get provided it gets enough votes, and then it will hit the calendar. It will get a file number, and then at that point, the Office of Fiscal Analysis releases a fiscal note. So anything that I would tell you at this point would be conjecture on my part. It's really that fiscal note that guides our policy, and that's none of the bills that we consider in the Human Services Committee have a fiscal note until after they've been voted on, and that will inform the rest of the legislature and the Appropriations Committee about the fiscal impact.
Thank you. And also, Mr. Chairman, I understand in this bill in section 23 is a duplicate of House Bill 7192 that we haven't voted on yet, but it's actually coming up. And I do, without reading the bill, Mr. Chairman, if you can just kind of give a high level overview of what that section does. Now, I have a lot of concerns about that section, and I do realize that the colleagues on both sides of the aisle, Republicans and Democrats, did work on a task force to try to come together with something, but I do have some concern on it. So if you wouldn't mind, Mr. Chairman, kind of give us an overview exactly what we're trying to accomplish here without reading the bill, because I just want, in layman's terms, people to actually understand what's going on.
I will do my best in layman's terms. That bill or those sections that I think you're referring to in this bill are really focused on drug middlemen and ensuring that they're not raising the price of drugs, but rather their incentives are around with lowering the price. Specifically, we are creating a fiduciary standard for PBMs, and we're requiring the delinking of pharmacy rebates and compensation. And we're trying to do that to lower the price of prescription drugs. And as you noted, these are all recommendations of the bipartisan prescription drug task force, which had representation from all 4 legislative caucuses.
Thank you, Mr. Chairman. And that was just on the pharmacy benefit manager. I also believe that it deals with the contracts for pharmacy services as well, pricing, and also Canadian prescription drug. Could you kind of give us an overview on those as well?
Absolutely. We're trying to limit spread pricing for pharmacies. We're also bringing in the prescription. We've had a discussion already about Canadian prescription drugs, but that is a recommendation of the task force. And we talked about the drug shortages. That's also a recommendation. So all of these are recommendations of the work. Now, there were additional recommendations around that the task force made around step therapy and prior authorization. Those are not in this bill. Those bills that is in fact, I think there's legislation in the Insurance Committee that addresses that.
Thank you, Mr. Chairman. Again, we haven't seen that. We haven't done that bill yet. I think it's coming up on the agenda, but again, it's on here twice. It's actually in this bill, Senate Bill 10, and then has a standalone bill on its own. But I guess when we get to that, we may have some more questions on it. Thank you, Mr. Chairman. I don't have any other questions.
Thank you. I see Representative Meskers had his hand up for the second time.
Yeah, I just want to make sure that I state my position accurately. There's many aspects of the bill that I strongly support. I think the intent of the bill as it relates to many of the issues relating to importation of drugs and price, trying to get a fiduciary responsibility out of the PBMs. I think all that's important and try to reduce drug prices. But I think, as I said before, I think both the stop loss and the fact that it's not under the purview of the insurance committee would lead me to a no on that. But I want to assure the good woman that I listen to everyone's positions, and I do know my own mind, and I do vote my own mind. But I appreciate that we will all be held to account one day, they say. Thank you.
God help us. Representative Case.
Thank you, Mr. Chairman. So within this bill, SB 11, I'm not going to call all the amendments that we have, but there are 6 sections that are identical to bills that 5 that we've already voted on and passed, and 1 that we're going to be doing. And I think you said it explicitly that 7192 was the act of a bipartisan working group that passed the language out. Now you're taking a bipartisan bill and putting it into a large bill where we're not going to have the chance of a standalone bill. It's taking the bipartisanship out of it and putting it in with everything else, or with 6 other bills that we're working on today. Some things that people can't help. I think that's not fair. That's not fair to the bipartisan task force that put the language out on HB 7192. I don't think it's the proper process, and some might think differently, but to talk on a bipartisan task force that there's a bill, and we're going to be voting on that one next, but that one's included into SB 11. The bipartisanship is just thrown out the window. It makes no sense to me. So with that, I'd like an amendment, LCO 6371, to eliminate sections 23. Oh, I can't do the amendment because we had to change the bill because there were duplicate sections. So I just strike sections 23 through 37. I have a second.
Motion made by Representative Case, seconded by Representative Pizzuto to strike, I'm sorry, which sections?
It would be 23 through 37 now, since we had to change section 38.
And is there an else? There is no LCO number?
I could change it because we had to change it because of the stuff we had to be taken out.
So it's just an oral amendment, and
Correct.
I believe that's proper, but it just confirming yeah, that is proper. Okay, good. I thought so, but and when the vote is taken, I assume you want to
Taken by roll.
Okay, I thought so. I just wanted to make sure we weren't.
And just to reiterate, this is a section of a bipartisan bill that is being put into a larger aircraft carrier. We're going to be voting on this bill next. This should be a standalone bill that we work on because it was worked on by both sides through a task force, through a committee, to try to do something good for the constituents of the state of Connecticut. So I move the quote, the motion.
Thank you. And I think you just did discuss this, spoke for, I don't know what I'm saying anymore. You think you spoke further on the amendment. I would just say, obviously my caucus supports the bipartisan task force and its inclusion in this clearly partisan caucus priority bill reflects an endorsement of the bipartisan work, but it's not to the exclusion of the bipartisan bill, which we're going to be voting on next. So we would support it twice, but I think it's an important vote of confidence in the task force that this Senate Democratic bill has endorsed that language and the work of the caucus, and hoping the other caucuses will feel the same way, no matter what. And so I will not support the amendment at this time. Is there any additional discussion on the amendment? Seeing none, the clerk will please call the roll.
Representative Gilchrist.
No.
Senator Lesser.
No.
Representative Case. Senator Perillo. Representative Comey. Senator Marr.
Senator Marr votes no.
Senator Anwar.
Senator Anwar votes no.
Representative Butler.
Representative Butler votes no.
Representative Dathan.
Representative Dathan votes no.
Representative D'Amico.
D'Amico votes no.
Representative Fortier.
No.
Senator Gaston.
Senator Gaston votes no.
Representative Hughes,
No.
Representative Johnson,
No.
Representative Kit,
No.
Representative Master Francesco, Representative Meskers,
Representative Meskers votes no.
Representative Pizzuto,
Yes.
Representative Santiago,
No.
Representative Scott, Representative Shake,
No.
Representative Stewart, and Representative Vale.
Yes.
The clerk will please announce the tally.
5 yeas and 16 nays.
Amendment fails. Further discussion on the bill. Representative Case for the third.
I'm just
time?
following up on that vote if I can. Please.
Okay.
Thank you, sir. So, I mean, I just want to be clear. I'm writing my screening notes because this bill needs to go many different places. We have stuff in here that needs to go to the insurance committee. We have stuff in here that we've talked about in 6 other bills. 5 have already voted out of this committee. Earlier, we're doing 1 next. I just think it's the wrong way to legislate. I mean, why did we vote on the previous 6 bills if they were all being put into 1? Why are we voting on bills twice within a committee? And I'm really scared the way, there can be confusion on bills, but man, if we amend one bill and don't amend it here in SB 11, but they both pass, there's going to be 2 sets of language. That can happen. Usually when bills like this happen, aircraft carriers, they happen over in the other building, and those bills are taken off the calendar because they're included into an aircraft carrier. Now we actually have 2 sets of bills. If one gets amended and the other one doesn't, I don't know who's going to fix the mess the following session. I don't get it. I hope this bill gets moved to different committees, which it will. It'll have to go to Judicial, it'll have to go to Insurance, it'll have to go to Appropriations. It'll have a long way to go. I don't like seeing things done that way, but it is what it is, and we'll move forward to a vote. Thank you, sir.
Thank you, Representative. Other discussion from members of the committee? Seeing none, the clerk will please call the roll.
A motion has been made and seconded to JF as amended SB 11. Representative Gilchrist,
Yes.
Senator Lesser,
Yes.
Representative Case, Senator Perillo, Representative Comey, Senator Marr,
Senator Marr votes yes.
Senator Anwar,
Senator Anwar votes yes.
Representative Butler,
Representative Butler votes yes.
Representative Dathan,
Representative Dathan votes yes.
Representative D'Amico,
D'Amico votes yes.
Representative Fortier,
Yes.
Senator Gaston,
Senator Gaston votes yes.
Representative Hughes,
Representative Hughes votes yes.
Representative Johnson,
Representative Johnson votes yes.
Representative Kit,
Representative Kit votes yes.
Representative Master Francesco, Representative Meskers,
Representative Meskers votes no.
Representative Pizzuto,
No.
Representative Santiago,
Santiago votes yes.
Representative Scott, Representative Shake,
Representative Shake votes yes.
Representative Stewart, and Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. As a reminder, we are keeping votes open. We are now moving on to number 23 on the agenda, House Bill 7192, an act implementing recommendations of the Bipartisan Drug Task Force. Is there a motion?
So moved.
Is there a second? Moved by Representative Hughes, seconded by Senator Marr. This, as the title says, comes out of a bipartisan drug task force, and it's the recommendations. Any discussion or questions? Yes, Representative Pizzuto. Oh, Representative Case, followed by Representative Pizzuto.
Thank you, Madam Chair. So just a couple questions. I didn't ask them in the last bill, but I really don't like voting for 2 of the same bills, but I'm gonna ask this question. So when we talk about PBMs, and I've really learned first about PBMs, when there's a rebate, where does that rebate go?
it's intended to go to the consumer. But the PBMs might be taking a percentage of that. And so this bill is attempting to have transparency so we can better understand that process.
So I think we ought to, and honestly, once I started hearing the task force work with PBMs, there's been some reports out there, and I've been looking and reading. So 99% of it goes to the employer. Would anybody be able to help me out and understand that? Is that something that's trying to change? Or is there more work to be done on this? And I tell you, I talked to Representative Marr, and she's done a lot of agreement on this bill. But we always find other things that come through. And would you have anything to offer on that through you?
So we've had many conversations at the task force and subsequent conversations with various entities about these rebates. And although one of the issues is that sometimes the drug cost will be so high, then the rebate would be a certain amount that at the end of the day, we're actually not getting the best price. And so really these two pieces are about transparency to better understand the practices that PBMs undergo, so we can understand kind of what is the underlying cost of the drug, what are these rebates, and how do we ensure that at the end of the day, the individual, the consumer, is getting the best price for the drug.
Okay, I guess I get what you're getting at, but I don't know if we're there yet. I honestly, now seeing that it's in SB 11, I don't know if I can support this today coming out of here. I think there's a lot more questions after the discussion that we had in the previous bill. I want to support it. I want to be there. I want to hear if anybody has any other comments on this. I think you guys did a phenomenal job on working through and meeting and talking. I just don't know. I don't think this is the final product coming out of this committee, either going to the House or going to the Senate, because it's in both. It will be in both chambers. I guess I'll have to wait to see the final product. So thank you, Madam Chair.
Thank you, Representative. Representative Pizzuto.
Thank you, Madam Chair. Just to echo what my colleague, my good rep Case had said, he answered asked many of the questions about rebates. I just, speaking with the colleague on my side, Tracy Marr, I know how hard that bipartisan committee worked. So just as a matter of record, I do probably will vote yes, but I do have concerns that it may raise costs for employers. And I just wanted that to be on the record. But I do appreciate the committee's work. And again, to Representative Case's point, maybe on the floor, things will change. Thank you very much.
Thank you, Representative. Yes, Representative Meskers.
Yeah, I just want to thank you for the good work on the bill. I have the similar questions or concerns about the private sector companies, but having sat on insurance and gone to various conferences, I sat for presentations of PBMs, and they gave me a flow chart that was complete hieroglyphics. And I could not understand what the pricing was, where the pricing transparency, and who was getting the benefit. And I realized that my algebra is really good. My geometry may not be great. And if I can't figure out which way the numbers are going, at this point, I'm supporting the bill because what I want to see is better transparency. And I'm willing to listen to arguments about how we can make the bill better. But I think an accountability of transparency is super important. It's the same reason I fight on other bills in different sizes. I need fair pricing, better pricing, and we're not getting it on any part of the medical system, whether it be the insurance, pharmaceuticals, or hospitals. We just don't have the transparency we need. So hopefully this helps. Thank you.
Thank you. Yes, Representative Master Francesco.
Thank you, Madam Chair. Just a couple things. I do appreciate the bipartisan effort. Honestly, I truly do on both sides trying to work this out. Although I'm not convinced yet that this is going to help the consumer. Maybe things will change. It seems to me that it's a a battle between, the hospitals, the pharmaceuticals, the healthcare industry, the pharmacies. And then here's us over here, right? Everybody wants their little piece. And here we are over here. I'm not convinced that this is going to help the consumer. And I am a person that I always like to vote what's in front of me. I don't like to keep it in progress, keep it going, vote just to keep the conversation going, because the conversation is here, the conversation's today. That's just me, though. That's just the way I do things here. So unfortunately, I'm not going to support this today, but I appreciate my colleagues on this side of the aisle and that side for trying to work together. I just can't get there based on the wording that I'm seeing today, but thank you, Madam Chair.
Thank you, Representative. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFHB 7192. Representative Gilchrist.
Yes.
Senator Lesser.
Why, yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes.
Hughes votes yes.
Representative Johnson.
Representative Johnson votes yes.
Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers.
Yes.
Representative Pizzuto.
Yes.
Representative Santiago.
Yes.
Representative Scott. Representative Shake. Representative Stewart. Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. Moving on to number 24 on our agenda, an act concerning, Senate Bill 1417, an act concerning the establishment of a nursing home workforce standards board. Is there a motion?
So moved.
Second.
This is number 24.
Moved by Representative Hughes, seconded by Senator Lesser. Any questions or conversation? Yes, Representative Case.
Can you help me understand a little bit of what we're trying to do with the Work Standards Board through this bill? Madam Chair, do you want me to get into line by line?
Nope, I'm gonna head over to Senator Lesser. Yeah, please don't. Senator Lesser.
Oh, we're just getting started. No, we're trying to ensure fair compensation and at nursing homes in Connecticut.
Representative Case.
And through you, how are we going after fair compensation through you? Is this for private, nonprofit, through you?
Senator Lesser.
Through Medicaid funded nursing homes, I believe.
Representative Case.
So this bill is just for Medicare, Medicaid, pays into nursing homes. Is that what I'm getting at?
Correct.
All right, I'll see if anybody has any other comments. I don't think I can support this today as it sits. Thank you.
Thank you, Representative Case. Any other questions or comments? Representative Vale.
I see that this requires the board to report annually starting December 25th. If I thought maybe you might want to be proactive and make them report twice a year and save us the trouble of coming back next year. So
Thank you,
it might
Representative.
make sense.
Thank you for the feedback. Yes, Representative Meskers.
I just like to see coordination between this and the study about the allocation of funding. And just as a follow-up commentary, I don't think we mentioned capital because some of the commentaries were about the atrocious physical condition of the facilities. So we have to look at the salaries, we have to look what percentage goes of Medicaid reimbursement and what goes into the capital structural reinvestment. So I just like to see, if we tweak one of the two of them, and I don't know whether we combine them or look at them, because I don't think you can look at 80% without looking at compensation, et cetera. So you may have those two bills at some point. I won't tell you how to write your own bills, but those are just what my thoughts.
Thank you, Representative. Any other questions or comments? Seeing none, would the clerk please take the roll?
A motion has been made and seconded to JFSB 1417. Representative Gilchrist. Senator Lesser.
Yeah.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Senator Marr votes yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dayton votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes.
Yes.
Representative Johnson.
Yes.
Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers.
Representative Meskers votes yes.
Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. Moving on to item number 25 on the agenda, Senate Bill 1415, an act concerning Medicaid and Medicaid funded programs. Is there a motion? Moved by Senator Lesser, seconded by Representative Hughes. Any comments or questions? Representative Case.
Thank you, Madam Chair. So a little bit more explanation, if I can, from the senator for the Senate bill to see exactly what we're trying to do. It mentions a lot in here about the nonprofits.
Senator Lesser.
Yes, thank you. Through you, Madam President, Madam, not yet. Madam Chair, one day. This sets a minimum wage for direct care staff in nursing homes and in group homes of $22.50 in 2026 and $25 in 2027.
Representative Case.
Thank you, Madam Chair. And once again, I mean, the concept is there. I don't know if we have it in DSS or appropriations to fund that, because these are Medicaid funded, Medicare, Medicaid funded programs. So the money is going to have to come from us to increase those wages. I think I need to hold off on finding out where the budget is and where appropriation sees this. While I will always say the people that work in these facilities and the people who
girl.
Oh,
Representative Dathan, if you can mute yourself.
I'm so sorry. My dog was,
I hope the dog went out.
she wasn't happy with it.
We've many of us have been there.
You let the dogs out, right?
Yeah.
So, I guess what I'm saying, this affects the state budget and how this happens, because the money's come here or come out of here. So yes, we want to make sure that the people who take care of our most vulnerable are taken care of. I get that. I want to see where the fiscal note falls. I always say the fiscal note for these people who take care of our most vulnerable, it should be people over projects, not projects over people. I'm just torn that there's so many things here, not only in this committee, but in appropriations this year between Medicare, Medicaid rates, this bill now mandating how the nursing home staff is paid, the reimbursements to the nursing home, because that's going to have to be increased. I think there's a domino effect, and until we get a write-up from appropriations or OFA where we are, I don't know if I can support it right now. So thank you.
Thank you, Representative. Representative Vale.
Thank you, Madam Chair. Won't this greatly affect the previous bill that came out of this committee about the 80% that has to go to direct care. Isn't this directly related to that, correct? Because this minimum wage would apply to people who provide direct care. So we're already kind of squeezing that a little bit that people were concerned about. And now we're forcing a minimum wage of $22.50 and then 25 in January 27. I think that makes that other bill even more difficult. Depending on what people are paid now, which I don't know. I certainly know, having had family in facilities and understanding the work that people do. I have a hard time putting a minimum wage, like what other, besides our state minimum wage, which is now $16.35 an hour, what other industry do we force a minimum wage upon outside of that?
Senator Lesser.
Yes, I believe we have a standard wage for custodial staff in state office buildings, for example.
Okay.
Representative Bale.
Okay. I certainly have concerns with this. By January 20, the way that minimum wage is going up based on that percentage, it might be $25 an hour by January 27 as it is, but understand again intent, but I just don't see how this is manageable. So again, I'll listen and see if anyone else has anything to say.
No, I think the intent is admirable.
Representative Mesk.
Sorry about that. Thought I was recognized. I think the intent is admirable. Yeah, I'd only caution, excuse me, that we look at direct compensation, because I believe some of the people are paid by agency. And so I want to make sure that the money gets to the paycheck if we're doing that. And it doesn't work as an inflated agency price that they never see. So that would be my only concern.
Representative Comey, followed by Representative Pizzuto.
Thank you, Madam Chair. So I was looking at the testimony on this bill, and there's not any testimony in support of this bill. And, so I'm wondering, I see this testimony by, of course, our alliance partners, and what are they missing? What are they, can you explain to me, very simply what it is that they feel that that perhaps some other consideration should be taken into effect? There's a lot of suggestions here, so I'm not going to go into it, but it seems a bit complicated than just to generally do the bill of 1415 as it's written. And I'm just wondering if I'm missing something.
Senator Lesser.
Thank you, Madam Chair, and through you to the honorable representative. Look, I think whenever we're looking to raise wages, we do get concerns, and I respect the concerns from our friends in the nonprofit community about wage compression. And certainly there are also other nonprofits that provide services other than group homes. And so I think that it's clearly the intent of this committee. Over the last few years, Representative Gilchrist and I and all of you have worked to increase compensation for nonprofits. We were able to make a substantial increase in last year's budget, and we hope to do our level best to do the same in this budget. I don't have a magic answer for you, Representative, other than to say we have met a lot of times with our nonprofit providers, and we have heard their concerns, and we're going to work with them to try to do right by them, because we know how important they are. We're sensitive to the issues, including the issues of wage compression. After this bill gets out of committee, we're going to get a fiscal note, and we'll see how it intersects with the overall state budget, whether we could do this or not, and have a better sense about how it works with the other efforts that we're going to do to support nonprofits in the state budget. So we'll work through it, and but we hear them, and we want them to succeed and thrive, and serve their public mission and serve people connected.
Okay, thank you. I appreciate your commitment to continuing to work on this. Thank you.
Thank you, Representative. Representative Pizzuto, followed by Representative Case.
Thank you, Madam Chair. Just quickly, I may be splitting hairs. Under section 3 on the bill, they talk about requiring the nonprofit employer contracting with the state to increase wages for employees providing services to people with IDD, and so that these employees have a minimum hourly wage and it identifies the wages. Most homes I've ever been in, it's very hard to isolate people just to take care of folks with IDD. But the question I have is, if they give them the additional money, there's also additional funds that'll be needed for retirement contributions and so forth. That is another expense for these nonprofit, buildings and people. So I wonder if they take that into account. It's not simply an hourly wage and simply isolating what a worker does. God bless them for doing the IDD stuff, but I find it very hard to imagine they're limited to only that. And so I think they're ripe for someone filing, a suit that says, hey, I've done that as well. Don't ask me to help that patient, in which case the patient suffers, unless they have a lot of people, which I find most nursing homes don't. So just food for thought, but that additional contribution could be very significant for retirement. Thank you. Yeah.
Thank you very much.
Right.
Representative Case.
Thank you. And I was just reading some of the testimony and I'm looking through it, and actually the Alliance disagrees and doesn't like this. And that concerns me. And they're looking at it, and while they support the efforts, they're afraid what it's going to do to the rest of the nonprofits, because this is just picking winners and losers. And it struck me when I was looking at it quickly to see when Representative Comey said there were no positives on this and everybody's negative. And when somebody just talked about how the Alliance and how we need to support them, but they're against this because they don't want to pick one nut over the other. So for that case, I mean, I respect the Alliance and their decisions and what they do. I think we do need to look at them and fund across the board. But they are our nonprofit people in the building, and they are opposing. So I have to take that pretty seriously. There's there's 6 other opposing in this bill, and nobody's supporting. But I find it very telltale when the Alliance goes against something. So let's hope something changes with this bill as it moves along, but sometimes you have to listen to how people write in. Thank you.
Thank you, Representative. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFSB 1415. Representative Gilchrist. Senator Lesser.
Yes.
Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes.
Yes.
Representative Johnson.
Yes.
Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers.
Representative Meskers votes yes.
Representative Pizzuto.
No.
Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
No.
The roll call is complete.
Thank you, Madam Clerk. All right, we will now move on to number 26 on the agenda, Senate Bill 1298, an act concerning non-emergency medical transportation standards. Is there a second? Wow, it's a miracle. Motion by Representative Case, second by Representative Kidd. Yes, Representative Case.
Madam Chair, this is something that, I mean, you and I had talked about this. We've met with many people on this. I was adamantly against this until things were brought forward to us and we saw some charts and some graphs. people, the non-emergency medical transportation is a very serious contract that we have at the state of Connecticut to get some of the most vulnerable people around to appointments and different things. And it's basically an agency or other drivers that want to get involved with this. And it's about how they get certified and go through their practice of not only getting the F endorsement, which is a public service license, but going through the program at our non-emergency medical transportation contractor to be approved, because they are the responsible party for people that are in these cars. So people need to go through their program, their vetting. And I think we've come to a conclusion, Madam Chair, you can correct me if I'm wrong, but I think the conclusion is that the right things are going to be done, and we just need to work to get DSS to move forward on it. Because if MTM feels comfortable and they can get more drivers on the road, I think this is a positive thing moving forward. And the liability still all remains with MTM, but finally the F endorsement will move across the F line.
Agreed. And I appreciate our work on this together. Representative Vale.
So this will require an F endorsement. That's it. That's
The F endorsement is already required.
okay.
Part of the issue has been that when you apply for the F endorsement, it can take up to, is it 90 days? 90 days and currently the livery taxi drivers with the F endorsement cannot be doing non-emergency medical transportation for that 90 days, even though they have the equivalent training of the independent contractors. And so what they're hoping for is that with their temporary F endorsement, they'd be able to start doing non-emergency medical transportation as well.
And that would expire after the 90 days if they didn't get their F endorsement.
Correct.
Okay, thank you.
You're welcome. Any additional comments or questions? All right, seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFSB 1298. Representative Gilchrist.
Yes.
Senator Lesser.
Yeah.
Representative Case. Senator Perillo. Representative Comey. Senator Marr.
Senator Marr, yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dayton votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes.
Yes.
Representative Johnson.
Yes.
Representative Kit. Representative Master Francesco. Representative Meskers.
Representative Meskers votes yes.
Representative Pizzuto.
Yes.
Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
Yes.
The roll call is complete, Madam Chair.
Thank you, Madam Clerk. We will now move on to number 27 on the agenda, House Bill 7187, an act implementing the recommendations of a report on employment assistance programs for individuals with disabilities. Is there a motion?
So moved.
So moved, Representative Dathan.
Seconded.
Moved by Representative Dathan, seconded by Representative Hughes. Is there any discussion or questions? You want to go? Representative Case.
Thank you. Just trying to go through the recommendations. It's late, but I'm just trying to see what stands out here that we are doing as far as implementing the recommendations from the employment assistance programs.
Would you like me to?
Just briefly, if you could.
Sure. So what this bill does is it requires the OPM secretary to implement the recommendations that were provided by their office in a December 2024 report. Some of these are to consider a pilot program to provide a one-time grant to mid-sized businesses who hire workers who have intellectual and developmental disabilities for employment accommodations. It would require collaboration with DSS and SDE to increase work opportunities for youth leaving the K through 12 system. It would determine revenue loss to establish a tax credit for new jobs for the disabled population that also offer healthcare. It would develop and distribute a disability employment toolkit for businesses outlining resources, tax incentives, and employee rights. It would publish a list of employers who participate in disability employment awareness trainings on ADS and the DDS websites. It would survey those in the intellectual and developmental disability community to determine employment demands and needs. And that report needs to be sent to the Education, Human Services, and Labor Committees.
Thank you, Madam Chair. It sounds an awful lot like some reporting we asked to come out of 5001, but I'm not too sure. And if it is the recommendation of OPM, then let's get it moving.
Wonderful. And thank you for your work on that important legislation. All right, seeing no other questions or comments, would the clerk please call the roll?
A motion has been made and seconded to JFHB 7187. Representative Gilchrist.
Yes.
Senator Lesser.
Yeah.
Representative Case. Senator Perillo. Representative Comey. Senator Marr.
Senator Marr votes yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Yes.
Representative Johnson.
Yes.
Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers.
Yes.
Representative Pizzuto.
Yes.
Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
Yes.
Senator Gaston votes yes.
Thank you. The roll call is complete.
Thank you, Madam Clerk. Moving on to number 28 on the agenda, Senate Bill 1420, an act concerning the Connecticut Partnership for Long-Term Care. Is there a motion?
So moved.
Is there a second? Moved by Representative Hughes, seconded by Representative Johnson. I thought you'd raise your hand. Representative Vale, go right ahead.
Everybody might want to get comfortable. From, I'm just kidding. I'm not that long-winded. So thank you. I obviously I have concerns on this issue altogether. Having worked in long-term care in the past, and understanding insurance and how indemnity plans work as opposed to health insurance, rates aren't supposed to go up when you buy a policy like this. They can. It says in the policy they can. It's the same as, again, if you guys will indulge me, it really concerns me because when you buy a life insurance policy, it's based on your life expectancy at the time. And the only way they can change those rates if mortality rates change dramatically, because you're in this pool, you bought it when you were a certain age, it's based on that. And it generally stays the same. They'll always put in there, they can change it. It doesn't generally change. These type of policies were sold with that same type of process in mind. And the actuaries didn't do their job well. And so what's happening is I could see if you have a lifetime benefit, then I can see where the benefit might exceed what maybe because people are living longer. But a lot of these policies have stop dates on them. And they're put into this pool and they're done based on the probability that they go into a nursing home. And they pay per day. It's not like health insurance where the cost of health insurance is going up all the time. The cost of the nursing home may be going up, but they have a specific dollar amount, which is easy to calculate. If it's $200 a day with a 5% inflation rider, then it will grow over time, whatever that is. And basically, and this is how they always talk about, you have a bag of money. And if it's part of the partnership plan, and I know a Senator Lesser had said, we advertise this, right, on our website for people. Oh, it's a partnership plan. So then people go out. I mean, I'm not going to make people raise their hand, but not too many people have long-term care insurance. So the people that have the wherewithal to do it, they're looking out for the future of their family. And again, this is something that you purchase when you're younger usually, so your premiums are low. Nobody wants to be in a nursing home, so you almost kind of have to put yourself in there to do this. And then people sell these policies, and again, because they have a specific benefit amount and there's numbers, they're not expecting those policies to go up. Now, if they made a miscalculation and they have to make adjustments once, maybe twice, but every year they're in here asking us for more money, and it's BS. And I've had enough of it. And just understanding that, I think the only reason is maybe they lowballed the prices to get people to buy them. I can't say that with any certainty, but something's just not right. And again, do I know that this is the perfect solution? I definitely support this comment or this concept and this bill. And we've heard it also in the new Government Oversight Committee, which Representative Dathan is the chair of. And we listened to testimony. And that lady, Jan Kritzman, called me young as opposed to, she called me old when we were in there. She's a hoot. She's great. But like her policies went from maybe, I think it was $1,100 a year up to $7,000 or, whatever that is. That's a 700% increase. That's just unsustainable. And there's something wrong with it. Now, you guys can get irritated with me for a second, because all that being said, I do think that the proper purview for this is the insurance committee. And I am going to make a motion that we transfer this to the insurance committee. And I would like to tell you why I think that. That company can hold insurance companies. I was on that committee for 6 years. And we can hold the insurance companies much more accountable in that committee, and also the insurance commissioner. Because again, I'm not picking on this specific commissioner by any means. But somebody needs to be held accountable. People with that background should be asking questions, and they should be coming in front of the committee. Maybe the commissioner shouldn't be allowed to approve any rates without legislative action or something, because this is out of control. And I don't know what the solution is. Again, I mentioned maybe a moratorium on selling new policy till they figure out their actuary. But I did make that motion. I don't know if anyone wants a second. Okay. That we transfer this to the insurance committee.
All right, a motion has been made by Representative Vale and seconded by Representative Pizzuto.
Please have a roll call vote.
To amend the motion on the floor to send this bill to the insurance committee. Any conversation or question? Representative Dathan.
Thank you very much, Madam Chair. I do know there was an instrument in the insurance committee that has been JF'd out of the committee. It's number Senate Bill 1269. And I know there are some issues with going on similar sort of things, but slightly different than the bill that's seen before us. So I'm urging folks to vote against this referral, because I do believe the insurance committee has already voted on such a bill this year. Respectfully, Madam Chair.
Thank you, Representative. Any other comments or questions on the amendment? Representative Hughes.
Thank you, Madam Chair. And while I totally share my good colleagues' frustration, there's also a similar bill that is JF'd out of aging that deals with this. So again, we have multiple different vehicles that are moving through, because the policyholders, like myself, are really frustrated with these catastrophic increases. So anyways, I would vote against amendment, but I totally share my good colleagues, frustration. Yeah. All of that. Everyone's frustration I share.
Thank you, Representative Hughes. Any other comments or questions on the amendment? Seeing none, would the clerk please call the roll?
Representative Gilchrist,
No.
Senator Lesser,
No.
Representative Case, Senator Perillo, Representative Comey, Senator Mar,
No.
Senator Anwar,
Senator Anwar votes no.
Representative Butler,
Representative Butler votes no.
Representative Dathan,
Representative Dathan votes no.
Representative D'Amico,
D'Amico votes no.
Representative Fortier,
No.
Senator Gaston, Representative Hughes,
No.
Representative Johnson,
No.
Representative Kit,
No.
Representative Master Francesco, Representative Meskers,
Representative Meskers votes no.
Representative Pizzuto,
Yes.
Representative Santiago,
Yes. No. I'm sorry, this is the amendment. It's no.
thank you. Representative Scott, Representative Shake,
No.
Representative Stewart, and Representative Vale.
Yes.
The roll call is complete.
Thank you, Madam Clerk. Would you please announce the tally?
It is 5 yeas and 15 nays.
Thank you. The amendment fails. Representative Vale.
Thank you. I'm so surprised at that outcome. So I still believe in what I said as far as that being the appropriate committee, but I'm not 100% sure this is 100% the right avenue to fix it. But it very well could be. I think it's something that at least we're drawing attention to. But it's been around forever. So I don't know why it doesn't get the attention. Maybe it's because we're the insurance capital of the world. I don't know. But and again, it's not all insurance companies. This is a very unique kind of policy. And there's reinsurance. People sell the policy. There's just a lot of things that went wrong with this. And the fact that we're drawing attention to it. Again, I think maybe government oversight, which is in that committee, maybe that has some cognizance there. So, and I'm on that committee now, so I'm happy to look at it there. But I think we should really dig our feet in on this one. I will still support this bill out of this committee because I think it's important, and I think we need to hold them accountable for this and do what we can to try to fix it. Thank you.
Thank you, Representative. Any other? Yes, Representative Master Francesco, followed by Representative Meskert.
Thank you. Thank you, Madam Chair. Madam Chair, if there is a rate increase on a long-term care policy, does that not have to get approved through the Insurance Commission? For you?
Yes, it does.
It does. So what does this bill exactly do, though? I know Representative Vale was talking about making sure they can't raise their rates, but they're going before the commission anyway. So I guess I'm trying to figure out exactly what this does.
Give me just one second. So it would add a prohibition of tying the executive compensation to the higher policyholder rate. It's also going to do some transparency in that it requires any issuer of the long-term care policy to annually report on their incurred losses and actual paid losses. It prohibits the Department of Insurance Commissioner from approving any rate increases greater than was allowable at the time of the pre-certification. And it requires any issuer to provide any information of reinsurance contracts during the policy rate increase requests.
Okay, thank you. Thank you. Listen, I appreciate the intent of this, but what I'm very concerned about is, again, the state interfering with a contract between an individual and a company, an insurance company. They clearly, when you buy these policies, I have one, I purchased one. I haven't seen my policy go up that much, and it's done years ago, but you clearly sign, you know, the terms and conditions when you sign them. Every single thing that you sign, when it's a contract, there's terms and conditions on it. And we need to know those, right? It needs to be our responsibility to make sure we know them and to certainly ask whoever is selling the product to you to explain them. And if they don't, and if there's an issue with it, that's why we have a process in place. We have the courts certainly to take action on. So I get the intent of this. I'm very concerned that we're interfering too much in a private contract, because we are already, if they want to increase their rates, they're already going before the commissioner anyway to do it. So that's where my concern is. I don't know, maybe the language will change by the time it gets to the floor, but for today, Madam Chair, I'm not going to support this. I think it's just too much overreach, government overreach on our end. Thank you.
Thank you, Representative. Representative Meskers, followed by Representative Vale, followed by Representative Butler.
Having sat on the insurance committee for some time, look, first, I think because it's a public meeting, it's important people to understand that the policies that are sold today are sold with actuarial tables and expectations that I think match their cash flows. These products were issued 10, 15, and 20 years ago. The expectation on the number of people who might pass on before they drew down, or the number of people who would surrender their policies before they matured, they use actuarial tables. The policies are self-funded. The pool of money that's funding your benefits is the premiums that are getting paid in. It's very hard, and we've regulated this in trying to smooth the increases. The increases have been pretty heavy. The surrender values in some cases are low. People are trapped in a product whose price is going up. We're trying to help them, but it's a problem of an optimistic sales projection 20 years ago coming home to roost, and in many cases our access, because these are firewalled pools of money. It's very hard for us to solve the issue. We've addressed it a number of times in the insurance committee. I think we can take a look at it from other committees. I think we'll get to the same conclusion, which is we have to slow the increases, see if we can improve surrender values, and make sure that they're stable. Because overregulation of them, the risk would be they would end up they would go under and they'd hit the insurance guarantee pool. And none of us are interested in enforcing any default on the premium payment, on the benefits. So we're trying to improve it. Normally, we hear from people who are just in shock at the premium payments. And I just wanted to clarify where we are in this. I don't think today's issue is the long-term care policies issued and underwritten today. I think the policies written about 15 to 20 years ago, and the people still own them, and it's not a great story. And the whole industry had this problem. They didn't expect the life expectancy. They didn't expect the tenancy of the titles. Sorry to go on a lecture on that. I don't know where we get to on this. We've chewed on it like 5 times, and we're trying to improve it in insurance. And we've spoken with the insurance commissioner. We're online on what we're trying to do. I just don't know if it's enough of a solution because it's a very intractable problem.
Thank you, Representative. Representative Vale, followed by Representative Butler.
Again, that sounds all well and good, but, okay, they started selling these policies in the 70s, right? So they've been selling life insurance forever. So obviously that data is more concrete. So that's why you don't see that. So 90s policies that were sold in the 2000, that's 30 years of data they could have used. And life expectancies are longer, but we're also doing everything in our power. We did stuff tonight to keep people out of nursing homes and to keep them at home. Nobody wants to go to a nursing home. No one ever wants to use a long-term care policy. They have it there to protect their family and their assets so that if, God forbid, they have to go into one, that happens. The data should have been there. And so it's on the insurance commissioner to look out for these things. A gentleman testified in the committee. And so most insurance that you can charge so much per how much benefit, you're allowed to make a profit. And I'm all for that. Okay. But you're only allowed to make so much in insurance, right? There's loss ratio, like what you keep premium to loss ratios, correct? Through you.
Representative Meskers.
if the benefit is fixed, if the benefit has a significant cost of living adjustment, there's a premium adjustment that floats with that benefit. That's
It
the
is
problem.
fixed. They buy a fixed amount of coverage. It's a fixed benefit. If it's $200 a day with a 5% increase, it's a fixed amount. It is. It's not, the cost of living is irrelevant. It may, if people are living longer on those policies, but in the early 90s, they started the Connecticut Partnership for Long-Term Care so that they could tell people which are the safe ones to buy and you're not going to get screwed over. And if you bought a certain amount and you had to be 5 years or more because of the look back period for signing your stuff over to your kids, and it was put there to protect people in the early 90s. Okay. And if they're still selling policies and the state is advocating for them and they're going up, that's an issue. That's on us. That's on the state of Connecticut. We're part of the problem. And I think we need to dive deeper into this. It's not a matter of buyer beware. There's a certain expectation you have also. It's not just, okay, in this small print over here, we can raise the policies under these circumstances. They're sold with a certain way. They're not told that. And I feel like they might be selling these policies cheaper. Something that should be looked at. It's a major issue. And I don't think it should just be scoffed at. I think there's a lot more to this. And I think the insurance industry and maybe we are somewhat responsible.
Thank you, Representative. Representative Butler.
Thank you, Madam Chair. And I like to align my comments with Representative Vale. In a previous career, I worked in the insurance industry and worked very closely with actuarials. And as a computer programmer analyst, actually putting together all kinds of products associated with the good work of actuarials. And let me tell you, whether it's the mortality charts for life insurance or anything else, actuarials are very precise people. So there's no reason for this long-term insurance to be increasing by exorbitant amounts year after year. It has more to do with business model and actually companies actually trying to adjust their model for profit. And so we really need to keep an eye on that. Don't put this on the actuarials because I'm telling you, their projections aren't going to change that much from year to year. Okay, that's just not the kind of work they do. So this is more to do with corporate profit. And we need to look at that in terms of the products that they have out there and protect the consumer from these increases that shouldn't be allowed. So I just wanted to add my 2 cents to this, having 25 years of insurance background, working with actuarials and knowing the kind of work they produce. And if this is happening in today's world, we need to definitely have some say into how this is going to actually play itself out going forward. So thank you, Madam Chair.
Thank you, Representative. Thank you very much. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFSB 1420. Representative Gilchrist.
Yes.
Senator Lesser. Representative Case. Senator Perillo. Representative Comey.
Yes.
Senator Marr.
Yes.
Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Yes.
Representative Johnson.
Yes.
Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers.
Representative Meskers, yes.
Representative Pizzuto.
Yes.
Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart, and Representative Vale.
Yes.
The roll call is complete.
Thank you, Madam Clerk. Moving on to number 29 in the agenda, Senate Bill 1476, an act concerning the ABLE Act. Is there a motion?
Second.
Moved by Representative Case, seconded by Senator Lesser. Any discussion or questions? Representative Case. Ooh, we like that. Woohoo. All right, would the clerk please call the roll?
A motion has been made and seconded to JFSB 1476. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo.
Yes.
Representative Comey. Senator Marr. Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston. Representative Hughes.
Yes.
Representative Johnson.
Yes.
Representative Kit.
Yes.
Representative Master Francesco. Representative Meskers.
Affirmative.
Representative Pizzuto. Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
Yes.
Roll call complete, Madam Chair.
Thank you, Madam Clerk. Good news, guys. We're on number 31, House Bill 7191, an act concerning Medicaid rate increases, planning and sustainability. Is there a motion?
So moved.
Seconded.
All right, moved by Senator Lesser, seconded by Representative Hughes. This is a priority bill of the committee to increase our Medicaid rates and establish a process long-term to continue to update the rates. Any questions or comments? Representative Case.
Thank you, Madam Chair. So we've been talking about phase 1 study, phase 2 study for a year now, 2 years. With this, from what I'm reading, am I correct that this is phased in over 3 years through you?
Yes, that is correct.
And unfortunately, it doesn't affect, or it doesn't affect every Medicare, Medicaid facility. Not everyone will get an increase. Is that correct?
It includes those that, those providers and services that were identified in phase 1 and 2 of the rate studies. Additionally, it speaks to FQHCs and some of the entities that have an alternative payment schedule. But yes, yes, there will be some folks who will be left out. This continues also, just to put it on the record, to be a work in progress. We heard a lot of feedback at the hearing, and we will continue to have conversations across the aisle to ensure that we can pass a strong piece of legislation.
Thank you, and I hope, thank you, Madam Chair, and through you. I hope, this is something that we seriously take a look at with appropriations, because they have to be the buy-in with this. We have agencies and people who take care of our most vulnerable. Some of them are small agencies that take care of our family members that are still at home, the age in place. Haven't had an increase in 15 years. And we talk about inflation, we talk about the way things work, we talk about wage increases in this bill, or not in this bill, but today. But things just haven't kept up. I know it's kind of strange to hear that coming from me, but if we're going to make a investment, we need to make an investment in those that take care of our most vulnerable. So I hope we can get something done. I hope it's not false hope, given the budgetary constraints that we have, because these are the ones who take care of our most vulnerable in the state of Connecticut. Thank you, Madam Chair.
Thank you, Representative Case. Yes, Representative Pizzuto.
Thank you, Madam Chair. Just quickly, line 107 in this says, any other factors unrelated to increased costs associated with an increase in change of scope. That's pretty open-ended. Any other related, unrelated? I mean, that could be anything. Is that something that, should there be some constraints on something like line 107? Any other factor to increase costs associated with a change of scope of services?
I'm going to go to Senator Lesser.
Okay, thank you.
I'm going to try through you at this late hour.
Yeah.
Yeah, I think what they're trying to do is is ensure that there's a rebasing when FQHC has a change in the scope of the services they offer. And so it's acknowledging that we're trying to consider all of the costs that could be taken into account, but we don't have an exclusive list. So we're just trying to make sure that DSS looks at the whole book of business for the FQHC and take that into account when figuring out what a fair Medicaid rate is.
Trying to generalize across all the possibilities, I guess. Thank you.
Thank you, Representative. Any other questions or comments? Seeing none, would the clerk please call the roll?
A motion has been made and seconded to JFHB 7191. Representative Gilchrist.
Yes.
Senator Lesser.
Yes.
Representative Case. Senator Perillo.
Yes.
Representative Comey.
Yes.
Senator Marr. Senator Anwar.
Senator Anwar votes yes.
Representative Butler.
Representative Butler votes yes.
Representative Dathan.
Representative Dathan votes yes.
Representative D'Amico.
D'Amico votes yes.
Representative Fortier.
Yes.
Senator Gaston.
Senator Gaston votes yes.
Representative Hughes.
Representative Hughes votes yes.
Representative Johnson.
Representative Johnson votes yes.
Representative Kit. Representative Master Francesco. Representative Meskers.
Meskers, yes.
Representative Pizzuto. Representative Santiago.
Yes.
Representative Scott. Representative Shake.
Yes.
Representative Stewart. And Representative Vale.
Yes.
The roll call is complete, Madam Chair.
Thank you, Madam Clerk. We are going to hold the votes open until 9 p.m. I think just on Zoom, because I don't think people can access the Human Services Suite. Is that a correct assessment?
I'll stay right here to record.
Okay, thank you. So people can vote right here in 2A and via Zoom. And we will recess. Thank you.
Madam Clerk,
Yes, Senator Anwar, can you hear me?
very well. Thank you so much.
Yes.
I missed some of the votes. I'm actually, to make it easy, I'm yes
I'm
on all
sorry,
votes.
one moment. It's quite loud in this room. All right.
Can you hear me now?
All right, go ahead.
I'm a yes on every vote I've missed.
Okay, I will record that. Thank you.
Thank you.
Representative Dathan.
Thank you so much. I think I actually only missed one vote, and that is, but if you could double check for me. If I had screening at the same time, HB 7022, number 4.
Number 4?
I think I missed that
Yes.
one.
How do you vote?
I vote yes.
All right, I have it recorded. Thank you.
Do I have any other missing votes? I think I got everything, but
I think I have you on everything else.
okay, good. I'm sorry. It was a lot to balance this afternoon for me.
All right, thank you.
I appreciate your focus tonight. Hope you have a good evening and a safe drive home.
Thank you.
Bye.
Senator Gaston?
Hi, how are you? Thank you so very much for all your help tonight. I want to just make sure I vote on all the stuff I didn't vote on.
Okay. So for number 1,
Yes,
yes.
yes,
Number 2,
yes,
3,
yes,
4,
yes,
5.
yes.
Oh, I have you on that. Hold on. Yeah. Oh no, that's an amendment. Okay. Have you on that? This is stuff that I 8. Uh, 14.
Yes.
17.
Yes.
18.
Yes.
19.
Yes.
20.
Yes.
21.
Yes.
And 29.
Yes.
And I think that's all of it.
Thank you so very much. You have a wonderful night and drive home safely.
Thanks.
Thank you. Bye-bye.
Right.
Hello.
Hello, Representative.
Hi. All right. I think I left off. I think I went 1 through 19. I missed 20 and I voted 21 is what I believe I did.
Okay. Yeah, I don't have you for 20.
Okay, so 20 I'm a no.
Huh?
All right. I think you have me for 21 as a yes, right?
I do.
Yep. And 22 I'm a no.
Huh? Well, let me move through my stack of amendments to 23. All right, there we go.
I know there's a lot of amendments on that one I missed. I know.
Yeah.
All right, 23, 7192, I'm a yes.
Okay.
24, 14, 17, I'm a no. 25, 14, 15, I'm a no. All right. And then SB 1298, number 26, I'm a yes.
Mhm.
And 27, I'm a yes, 7187. SB number 1420, I'm a no.
Okay.
I'm a yes for 1476 on number 29.
Okay.
And 30 you guys pulled, right? They didn't call 30,
Yeah, we
right?
didn't do 30.
Okay, good. And number 31 is a no, 7191.
Okay, that's a no.
Yeah.
All right, I have your votes.
Thank you so much. Appreciate it.
Thank you. Have a good night.
You too. Bye.